been Sheikh. Dr. Sheikh Sir joined LDSC in Mumbai, the course in 1950, and completed his Bachelor of Dentistry in 1954 and 55. Just see the timeline. In the Sir CM Dental College, now which is known as the Government Dental College, which is the part of the JJ Hospital Medical College. After the brief stint in the army for a short time, he joined the same college, CM Dental College, as the dental surgeon in government service. Then he was the first orthodontic PG to be enrolled in Sir CM and was under the tutelage of Dr. V.V. Iyer. And he got his MDS degree in the year 1959 with distinction of the University of Mumbai. Then he continued in the Department of Orthodontics as professor and head of the department and became a PG guide in 1964. Continued to remain on the post till 1979. Then he relocated as the professor of orthodontics to Libyan University till 82. Then later on professor and HOD of King Fahad University of Riyadh, Saudi Arabia. He stayed in this position till his death in 1996. Dr. H.S. Sheikh sir, along with other six founders, what we call seven founder members of Indian Orthodontic Society, had been one of the very dynamic member. He had been the founder member, at the same time he was one of our past president also. So this particular oration comes as a tribute to Dr. H.S. Sheikh sir, and a saying comes in my mind when I look at his biodata. It says, "The heights that great men reach and keep are not by sudden flights, but they, when their companions sleep, toil upwards in the night." So we all should inculcate these, virtues of him and update ourselves to that particular level. And to give this particular oration, we have none other than Dr. Sheikh Sir's grand student. You know, the way we have grandson, granddaughter, we have grand student because Dr. Vichare Madam had been taught by Dr. Hazare Madam, and Dr. Hazare Madam happens to be student of Dr. H.H. Sheikh Sir. So it's an honor to introduce Dr. Vichare Madam. Vichare Madam completed her graduation and post-graduation from Nagpur University in 1987. She is the diplomate of Indian Board of Orthodontics. She had been the past chairman of Indian Board of Orthodontics. She is emerged from Royal College of Surgeons, Edinburgh. He's the Madam is the in teaching experience for 25 years in Bharati Vidyapeeth Dental College and Hospital, Pune, and currently the adjunct faculty in ESPM College, Nagpur, SMBT College, Nasik. With clinical experience more than 36 years, she also holds a PhD in orthodontics. So, considering the elevated level of this particular oration, Madam is going to speak about the HSA oration, and I request Madam to please go ahead with the oration. We are all looking forward. Thank you. Please give a big hand to the Madam.
Respected President, Indian Orthodontic Society, Dr. Rahakar, Secretary, Indian Orthodontic Society, Dr. Sanjay Nath, respected faculty in the audience, and the future of Indian orthodontics. It is really a great honor to give Dr. H.S. Sheikh oration lecture. For me, that oration word is not important. Dr. H.S. Sheikh word is more important. And actually, I make him twice and thrice, but not much. As he has said, he was not in India when I became orthodontist. But whatever I learned from my PG teacher is from her PG teacher, and that is Sheikh sir. And there is no other word than he was a great teacher. And believe me, I cannot say anything about his greatness. Just my experience is that making while making each and every presentation of this slide of this presentation, I was remembering Sir. That shows how much he has translated the knowledge and plus the ethics and moral. So coming to the talk, I chose this topic, steer your practice. Maybe many of you must have thought that, oh, it must be a practice management topic. So not important. But the meaning of practice, I have used here the word practice is the act which is done repetitively. And I feel there are certain things which we cannot keep aside as to be a successful orthodontist. So I'm going to put forward you one concept. What is steering? Every day you must be traveling from your home or from your room, hostel rooms to the departments. And you are doing, you have to reach in time in the department. So you are doing certain things into auto mode, autopilot mode. Like you will pick up your bags with whatever your seminar presentation, the things what you want to carry. You will drive your vehicle. It's a routine road with known signals and familiar faces you might be crossing at that time in the morning. So even if you are doing it on an autopilot mode, but even if that chaiwala is closed on that one particular day, you will say, oh, why is closed today? Am I late? So it is that subconsciously, or I will say on autopilot mode, you are doing the things. You are driving your vehicle, even you are talking on the phone. So how you are doing all these things? Because you are steering, you are navigating every day. So steer your practice is you navigate your acts which you are doing repetitively and with the that will make you a successful orthodontist. So steer is STEER. So what is S? S stands for stomatognathics, T for tooth movement, E for ethics in orthodontics. Second E for every decision what you take should be evidence based and rational thinking in orthodontic diagnosis. Now we are learning since morning all the lectures, and I realized that yes, what Dr. Graber Prem Kumar, Prem Kumar sir said is about stomatognathics, because what you need to know about growth and development. There's the basics of tooth movement. Now in today's era where companies are coming with different appliances, I feel they all are just the gadgets. And we have to be a smart clinician to use those gadgets. Maybe your self-ligating appliance, maybe micro implants, maybe your aligners, whatever it is. But the basics of tooth movement should not be forgotten. How you can move the tooth. And then, of course, you can choose any appliance, but stick to ethical principles in your practice. And your every decision should be evidence based. And the diagnosis, which is the single most important step in orthodontics, because the success depends on diagnosis, then we need to learn rational thinking or critical thinking, which is required for orthodontic diagnosis. So we know the vital functions in the stomatognathis system. Actually, this topic is at the third year BDS level. it is in DCI syllabus, but we tend to keep it for options and we go after technology. So what I feel is such a vital functions are of this somatokinetic system, and what Dr. Sridhar Prem Kumar said that the functions are dominating the development and the morphology of the tooth, jaws. So it is very important that we understand the importance of functions and how we can study all of them. Stomatognathing system is nothing but just the clinical examination. And I feel clinical examination, even in today's era of digital orthodontics, is very important. So, this is 100-year-old definition given by Salzman. What is stomatognathics? Stomatognathics is the approach to the practice of orthodontics which takes into consideration the interdependence of form and function of the teeth, jaw relationship, temporomandibular articulation, craniofacial conformation, and dental occlusion. See, the dental occlusion is the last word in this definition. So we have to understand what is stomatognathics, and this is a way of practicing. So just to give you an example, a 9-year-old patient comes to me, a usual appearance. There is no abnormality noticed on his face, and if you see intraorally, the chief complaint of the parents is non-eruption of right side central incisor, maxillary right permanent central incisor. Now, what you see in the picture, the child is 9-year-old, early mixed dentition, and only incisors, permanent incisors have erupted, and good buccal occlusion. Midlines are coinciding, and everything else is good, but you can make out the scar formation because of the surgery of previous doctor who has done to expose the central incisor. Now, this is intraoral picture, but if you see the during clinical examination, what I have noticed is in the dental chair there is deviation on wide opening. When the patient is closed in a centric occlusion, there is coincident midline, and when there is an opening, that time there is a deviation. So, which is a classical picture, classical feature, because when we say occlusal prematurities will deviate the jaw into centric occlusion, but this is on wide opening, there is a deviation of the mandible. Now, there is, if you see critically, there is premature history of premature exfoliation of lower right side deciduous canine. Now, what could be the reason for loss of deciduous canine only on that side? Now, if you see his OPG, you can make out the impacted incisor, inverted supernumerary, and all the four incisors deviated on the loss of deciduous canine. Then I took a routine records, PA view and the lateral cephalogram. PA view does show some amount of asymmetry, but the asymmetry was increasing when there is wide opening of the jaw. That means there is some muscular problem. Now, when you see the OPG carefully, there is missing condyle on the left side. So, this is how, it has to be. The clinical examination is very important. The PA view will give you the structural measurements for the amount of asymmetry, but it will not help us in diagnosing what is the problem. So clinical examination is most important in diagnosis. The management of bringing that impacted canine in line is very easy, but managing this missing condyle, that is diagnosed as unilateral condylar hypoplasia. There is agenesis of the condyle. As there is no history of trauma, so it means it is a agenesis. And this is going to worsen now as the age increases because mandibular growth spurt is still ahead. Now, that is what I always see. This teeth, what they are inclined on the right side, mandibular incisors, they are as markers. There are nowadays we talk about markers, cancer markers in blood. So similarly, teeth should be as markers. We can make out so many things as I believe form and function relationship and stomatognathic is the deciding factor. So these are the routine investigations. What we do it, that is 3D photography or CBCT, stereometry with or without implants, computed tomography scans, lateral and PA views, submental vertex also sometimes, TMJ views we take, photographic evaluations, study models, and clinical examination. I have intentionally placed this list upside down, the most important at the bottom and the other fancy things on the top. So it is, one has to believe that to use all the smart technology, the person has to be smart enough to apply it and interpret it. So there is one systematic review which tells the records needed for orthodontic diagnosis and treatment plan. Now, if one has to see the evidence, it concludes that only few high quality studies are available concerning the records needed for diagnosis. And cephalograms are not routinely needed for class 2 management. Digital models can be used to replace the plaster cast, and CBCT radiographs may be indicated for impacted canines. Based on the findings of the present review, the minimum record set required for orthodontic diagnosis and treatment plan remains unidentified or undefined. So, if there is no need of systematic review and meta-analysis for the need of clinical examination. Now, another child which reports to us at the same age of 9 years with the chief complaint that the mouth remains open and the child is whole night sleeping with the mouth open and there is increased gumminess, large interlabial gap. And according to the parents, the child is mouth breather. Yes, continuously the lips are apart. 1 centimeter interlabial gap. If you see his record, the airway is absolutely clear. There is no adenoids and there is no any obstruction in the airway. There is divergent jaw basis. Maxillomandibular angle is also increased. Of course, the lateral cephalogram is not taken into repose. The large interlabial gap is still not seen, but it is there. And if you see intraorally, mild crowding in the lower incisor, permanent incisors, deciduous maxillary canines, and fairly well aligned arches, no crossbite, average overjet and overbite. Since there is no airway obstruction, I diagnosed. We all know that there is two types of mouth breather, facultative and obligatory. And this is after 2 years. He was just kept under observation. And permanent teeth erupted. And this is after 3 years. no treatment. Absolutely well developed arches. The bite is same, mild incisor crowding is also there. And we all know the evidence that lower incisor crowding is given in non-orthodontic patients. There is chances of development of late incisor crowding. So I have not subjected him for any orthodontic treatment. Just passive continuous observation biannually. And this is after 5 years, 4 years. So he doesn't need any treatment. The interlabial gap has reduced. The mandible has taken its course, normal growth. The spurt is ahead. And now he is out of the growth, adolescent growth spurt. So this is possible only if we know the soft tissue changes, how they take place in younger adults. Now this is all we have learned about it. The lips become thinner as the age advances. The soft tissue thickness reduces. The lower part of the face appears to lengthen. The number of vertical muscle fibers in the upper lip decreases. The filtral columns become less prominent. In profile, the upper lip appears flattened and the commissions drop in their vertical relation to the mid filtrum, giving the face the appearance of a frown. The M and W shapes of the upper and lower lips may flatten almost into the straight lines. So when I know this knowledge, I will not give him any high pull headgear, any J-hook headgear for maxillary incisor inclusion. And of course, the difference in the soft tissue changes in boys and girls. The profile straightens and the lip becomes more retrusive in males. The nose increases in size in all dimensions and soft tissue thickness at cogonion increases. Whereas in females, the profiles does not become straighter and the lips do not become more retrusive. The nose also increases in size in all dimensions, but not as much as in males. Soft tissue thickness at cogonion decreases. See the difference in the girls and boys. So we all should know this absolutely in our mind that when we are dealing the boys and girls. So why we need growth assessment? To identify grossly abnormal pathologic growth. Whether this boy is having a airway problems and that is why there is interlabial gap, or it is because of just the facultative breathing habit and there is short upper lip. To recognize and diagnose significant deviations from the normal growth for planning the treatment and to determine the efficacy of therapy. So this is very important, but that doesn't mean that when we are treating adult faces, it is not important. Now this is at the age of 45 years. This female reports with bimaxillary protrusion, little prominent lips and incompetent lips. And when she came to the clinic, she was having very poor oral hygiene, ceramic appliances in the upper arch, upper second premolars extracted, and lower second premolars, you can see fresh sockets. And there is a proximal reduction done by the previous orthodontist. And of course, you can see there is lack of overjet and overbite. There is attrition of all the teeth. Now why, when I took the history, why the previous doctor must have done the first proximal reduction, then only single arch extraction, and then recently the second premolar extraction. Then I asked the patient, why you left your doctor? She said, I lost the trust in my doctor. See, this is very important. The patient should not lose the trust in our treating doctor. She has lost the trust and there the problems litigation starts. Then I thought, if this previous orthodontist should have known the stomatognathics, he or she would not have landed with this problem. You can make out that there is a complex tongue thrust, there is poor intercuspation, that is why all the teeth are showing attrition and there was no fixed bite. That is why the orthodontist must have thought, oh, I just need a minimum space, so I will do proximal reduction. After reduction, no, still there is overjet. Then I think instead of first premolar, I should extract second premolar. See, this is what is important. A simple thing that there is poor bite, that means there is some functional problem. We cannot hold the static models and plan the extractions and space management. This is a classical example that one has to do clinical examination thoroughly. I had no options left. I did not took cephalogram because ethically it is not right. We take it for the diagnosing. Already she has been planned with four second premolar extractions. So I placed four micro implants and I had to complete the case. And this is after the completion. Of course, there is not much great appreciation because there is so much of irreversible damage to the teeth. All the teeth were proximally reduced. So such an expensive appliance. So it becomes our moral responsibility that we do proper clinical examination. The second factor in steering is enough knowledge of tooth movement. I will say enough is basics. The basics of tooth movement, how you can move the teeth. Any bracket, any wire, any appliance, you should be able to move the tooth. And that is very important. So biology of tooth movement and mechanics of tooth movement is a single most important step. Now just to show you how you can be using the knowledge to move the teeth. Again, 9-year-old girl with an absolutely straight profile, class 1 profile, beautiful soft tissues, and at the early mixed dentition stage where upper and lower incisors have erupted and all the deciduous posterior teeth are there and very well aligned lower arch. Of course, it is early mixed dentition stage. This is a lateral cephalogram for the maxillary incisor inclination. All you can see is during the smile only it is evident that there is a proclination of maxillary incisor. Now, you all can see that there is no overjet at the age of 9 years. The maxillary incisors are more procline as compared to the lower incisors. That is what I call it as a teeth as markers. That means maxilla is behind, the teeth have inclined forward to, that is what is compensation, what Dr. Prem Kumar said. The teeth are compensating for the now mandibular growth. And this will now at the age of 9 years she is like this. So this is going to increase. So I just recorded that and I took her x-rays. And what I see, unfortunately, she has a bilateral transposition. This marker is not working. There is bilateral transposition with premolar and canine. Now when I diagnose, when the teeth are inside, that means it becomes my moral responsibility that if I can intercept it to correct the transposition. So I started the treatment. I did not took CBCT because it is too early to take CBCT. What I would like to know additionally from CBCT, I can see that there is crossing of the roots of canines and premolars bilaterally. I extracted the deciduous canines and deciduous first molars in upper arch and I allowed the eruption of first premolars considering the root development stages, and then sorry, oh, they are changing. So I started with the extraction of deciduous canines and premolars, first primary molar, and allowed the primary permanent first premolars to erupt. They erupted in a rotated fashion. Oh. And then I placed a simple folding appliances. After the premolars rotation was corrected, I started moving. You can see right side, the premolar has come back to the original position, but the canine has started erupting. But the left hand side, patient's left hand side, the canine is still buccally and higher. So I started moving the premolar palatally, because we all know that upper premolar has two roots. So I have to see the radiolingual thickness of the bone required for the canine movement. So before the canine descends down, I have decided to start taking the canines ahead. You can see that this is second OPG. Then I have started taking the canine palatally and premolar palatally, and canine started erupting. I, I brought it with a direct force, single force, without including into the arch wire, a very light force to bring it mesial. Now, all of you should know how to move teeth with bone and through bone. It is nothing, it is a direct resorption and indirect resorption, what you can see. So, when we are doing the tooth movement at a younger age, it is always, you require a light force to move the teeth along with the bone. Whereas in an adult age, you also need a lighter force, because we don't want to move the teeth out of the bone. The bone remodeling has to be simultaneously when we are moving the tooth. So it is very important that you know the basics of what kind of amount of force, optimum force required for the tooth movement. Then after the canine has erupted, I have changed the button. I have removed the non-supplant and I have changed the button to the Beck's bracket, and I have placed a root uprighting spring. You can see I wanted to move the root mesially before tooth being brought into the leveling, like into the archware level. As I explained, the root radiolingual thickness of the root. So I have started root uprighting in the higher level with a simple uprighting spring. After that, I changed the bracket to the other side canal bracket, because I wanted to move the root mesially. So there is a mesial crown tip in the canine bracket. So I placed other side canine bracket on that canine. So the root has started moving without becoming prominent. After that, you can see the teeth were included with the palatal cusp bonded with Beck's bracket. After that, I changed the premolar bracket, and the premolar bracket was lower premolar bracket, second premolar bracket, which has the highest buccal root torque. So I inverted it so that I can have a buccal root torque for the canine and premolar. And you can see by simply using the brackets and the conventional appliances, I have corrected the transposition without causing any fenestration, root prominence in the buccal arches, and no bonding of done in the lower appliances. So this is very important, that the basic simple things which are required for tooth movement, this knowledge is very important. And as I have explained you that there is a chin prominence, maxillary deficiency was there, and it is common impacted teeth transposition, higher incidence in maxillary hypoplasia. So we should know that yes, there is a transposition impacted canine. So the alarming feature is this could be a maxillary hypoplasia. So this is what is application of knowledge. The third is E stands for ethics in orthodontics. Now all of you know what is ethics. I don't have to say much about it, but I would say the intentions are always good. No one in orthodontics will have a bad intentions of filing the cases. It's only our efforts are less. So we have to have a absolutely ethical practice. So autonomy in medical ethics is defined as the patient's ability and opportunity to make treatment choices based on sufficient information provided by the orthodontist. It is patient's right to privacy, freedom of choices, and acceptance of responsibility for one's action. Now, this is what exactly Dr. Akhtar also has mentioned, the patient's right. So, we cannot put patient's photographs without hiding the identity. Then, other than autonomy, non-maleficence, the obligation of a physician not to harm the patient. Beneficence, an act of charity, mercy, and kindness with a strong connotation of doing good to others, including moral obligations. Sometimes patients do come to the clinics which you have not started. So we just have to help them. Something is hurting, poking. So that is what is do good things. The quality of being just, impartial, or fair, and veracity, conformity with truth or fact. Now, I would like to show you this diagram, the figure slide. This is a case treated by an angle 100 years back. And can you see the photograph? Adult case, 38-year-old female treated 100 years back. See the quality of photographs, true profile without shadow, and the study models with the bases, and see the treatment provided that time. All the first molars were missing and they were uprighted in the absence of coil springs, in the absence of pre-adjusted brackets, in the absence of night-eye wires, in the absence of implants. So isn't it our moral and ethical responsibility that we are born in such era where we have all the gadgets? So we should do the perfect or maximum more than this to our patients. And this is how it speaks about your ethical responsibility to every orthodontist in this hall. If Angle can do this at that age, why can't we do it? Why we are having less effort? So it is very important. Now just to show you the example, 45-year-old female reported to me history of extraction of first premolars in a younger age, treated, and she came to me because there is severe pain on the palatal aspect of incisors because of 100% skeletal deep bite. You can appreciate the step between the canine and second premolar in the maxillary arch, the amount of maxillary canine root prominence, and the 100% deep bite. And patient is in pain because of the severe traumatic bite. Now I have to relieve her from the pain. This is, you can see there is, the lower incisors are halfway inside the roots of central incisors, maxillary central incisors. That is how one central was endodontically treated. Now second also will be treated. Facets at the below the cervical level of maxillary central incisors. And you can see the step between the canine and premolar. So this is a sequelae of single arch extraction treatment at a younger age. So I had to treat her, relieve her from the pain. So I had given her simple bite platform to relieve that traumatic bite, and I bonded Beck's bracket in the maxillary arch and mandibular arch pre-adjusted bracket, hoping that I will put a correction of curvosity with the fixed appliances, and I tried to correct the step, the curvosity, by simple segmental appliances, which this is the same action we do it in a growing age with the selective trimming of high functional appliances. So I have not done something great. In fact, I am just relieving her from the pain. And you can see the healing gradually, and it is completely healed. The inflammation has been corrected, and there is complete healing of palatal mucosa. Patient is out of pain, and I have corrected the curvosity and gave the without implants. And see, the smile has changed. You can see the step formation in the pre-treatment and in the post-treatment. Change in what? Lower height. The mentolabial sulcus has improved, and you can see the mandible even at the non-growing 46-year-old lady. The mandible got repositioned because it was traumatically held behind. So if I see this same type of growth pattern at the age of 13 years, you can see the same lower anterior face height is reduced and skeletal deep bite same as that way. So it becomes my more, and you can see now that traumatic bite has again the same chief complaint what the patient is having. So we have to consider that skeletal deep bites, one has to be very cautious to extract in such cases. So we have to see the evidence. What is the evidence? All of you please read this Ghaffari's article in Seminars in Orthodontics for management of skeletal deep bite. And it is said bite before jet. Bite correction is the first objective before the overjet correction. So one should not think about extracting the teeth, that too single arch extraction in a growing patient without considering the growth rotation. So that is why the fourth factor, that is E, evidence-based decisions. Your treatment planning should have sufficient backup from the evidence. You cannot be ignorant by just, oh, I want to do space analysis. There are apps and softwares which will tell you that this is the tooth discrepancy and I would extract. No, there has to be solid evidence. So, evidence means a provisional departure point in the consideration of whether or not a particular course of action should be taken in clinical context. So each and every decision what you are taking for your patient, you have to know the evidence. Now the example I would like to show you again a growing pain, and I have realized all the postgraduate students are not interested in that 3 years time to take the growing cases, because you think from the exam point of view, oh, I may not be completing this patient, so why should I take this? But I will tell you, techniques you can learn after even graduation. There are so many courses outside. You can learn how to put the implant, how to do the surgical planning, how to do the self-ablation, how to do mandibular advancement appliances, everything. It is a commercially driven field now, unfortunately. So please don't go after that and learn the science in these 3 years. Otherwise, when you are going to learn about growth and development, if you don't see growing kids in your postgraduate curriculum, after passing out, First thing you will get to see is a 9-year-old kid. So please understand the importance of growth and development, and of course the evidence. Now this is again a 12-year-old female. Female is important, 12-year-old, and all of you can agree that there is mandibular prominence and unfavorable facial aesthetics. You can see it. She is class 3. There is negative AV, but there is less overbite and less overjet. There is no negative overjet.
कैमरा वाले का नंबर है तुम्हारे पास? नंबर नहीं है, उसको बोलो ना, वो जो दे रहा है
There is
फुल स्क्रीन इसको अटैच करें.
something is stopping very light contact between the maxillary and mandibular incisors. There is large mandible, small maxilla,
प्रोजेक्शन कौन कर रहा है?
and she is 13-year-old female.
Position कौन
If
कर
you can see the CVMI, she is between
उधर से
2 to 3.
डायरेक्ट मिल सकता है क्या आपको?
There is concavity developed, but the shape is still horizontal. And if you see intraocularly,
तो आपने इधर
you can see the accretion facets on the maxillary central incisors.
उनका
So part of closure is they are hitting. That is the indication that there are chances that mandible is going to
निकलना
grow,
इसमें से भी आउट निकलना है.
because she is closing and then going it back.
अरे वो प्रोफेसर है ना, उसमें से निकलना है.
There is no bilateral crossbite.
इतना ही होता है.
Beautifully aligned arches.
एक
And
आपने लिया,
patient
आपने
is
किधर लिया?
from that is, I want to improve my aesthetic.
आपको किस लिए चाहिए?
अरे वो मैं यूट्यूब कर रहा हूँ, तो अभी ये जो
Now
दिखा
we
रहा है
have
ना,
a evidence with us that there is a mandibular growth spurt which happens between CVMI 3 and 4. But this is for the peak in the mandibular growth. Peak means there is maximum increment. After that, there are increments in the mandibular spurt. And the other evidence is the increments are later, larger, and longer. Remember 3L. In class 3, there is a growth peak taking place later. The spurt is larger, and the increments are also, the spurt is longer and the increments are larger. And this is the evidence for that.
नहीं बोल रहा हूँ.
In class 3 malocclusion, this is Basseti's
नहीं,
and McNamara's evidence
वो जो चल रहा है ना वहाँ
that
पे स्क्रीन पे.
significant changes in total mandibular length occur until young adulthood, that is 18 years average, with increases between late maturation stages CVMI 4 to 6 that get twice as large in class 3 females and thrice as large in class 3 boys as compared to class 1. So this is a very good evidence what we have, and if we fail to use this, then it's really failure.
एलईडी वाला कौन है? आप एलईडी ऑपरेट करो.
So she came
आपके
either
प्रोफेसर से आउट निकले
after
या
3
नहीं?
years.
नहीं कैसे निकले?
She was
क्या
12
निकलता
years.
आपको?
After
वहाँ से
3
आउट
years,
किया ना लेकिन
आपने
I
इन किया.
took again
आपने
record.
इनको मैनेज
There is increase in the mandibular prominence.
आपने इन किया ना
And you
और
can
एक आउट
see
इधर दिया, वैसे एक
This is
आउट
a
मुझे दो.
superimposition.
स्प्लिट होता है स्प्लिट.
Then we know that
नहीं है ना लेकिन
there is a growth taking place.
आने के
I
बाद दो
can
ऑप्शन होता है.
calculate the amount of
एजीएमआई एनालॉग.
increments which has happened and see the
जेएमआई का आउट
lower incisors have
वो
further
स्पीकर
come
नहीं है
ahead,
मेरे पास.
but they are upright.
तो आपने एलईडी को
That is
एजीएमआई आउट
another
किया.
indication
मैंने डीवीआई
that
एलईडी को
हाँ, तो एजीएमआई बचा है ना, तो एजीएमआई तो होंगे.
एलईडी में उनको
then I again called her after 3 years. This is at the age of 18 years. Now I am free to take the
उनको
decision
एचडीएमआई दिया मेरे लिए
whether I am going to treat her surgically or orthodontically.
तो ये प्रेजेंटेशन
is her-
प्ले कौन कर रहा है?
मैडम ही कर रही है वहाँ से.
तो उनको रिपीट क्यों
Records
दिया?
at the age of 18 years.
उनको रिपीट क्यों
I
दिया?
gave her the option of surgical
पहली बार काम कर रहे हो.
and camouflage.
आप पहली बार कर रहे हैं
मैं आपको टेक्निकली समझा रहा हूँ.
तो रिपीट
Of
मतलब
course, she
क्या
opted for the camouflage option. Then I gave her option of after camouflage, you can go ahead for the genioplasty, chin correction, if you feel it. And I extracted treated her with Invisalign, and this is after the treatment, and she's the lip thickness has improved because I retracted, and she is not willing for the chin correction because now the dimple chin is more evident when the lip is retracted.
इसको हो जाने दो इसके बाद ये
And
ऐसा
this is
करेंगे,
the
इसको block
change after the. So even if you follow the evidence, it is patient's right
तुमको लगा होगा
to know the evidence, the facts. So I believe 5A.
कैमरा वैसे भी क्या यही दिखा रहा है
If you are confused, you can ask your seniors, teachers, acquire the knowledge, appraise the evidence,
यही बोल रहा था
apply it, and audit it. Audit is very important. Unfortunately, orthodontics is a field where when we do some treatment or we take a decision, forget about the treatment, when we take a decision for our patients to see the effects, it is a long time, which is none of the other medical branches have this kind of. So you have to continuously work on execution and you have to take an audit of it, whether I was successful, so that then becomes you are a good clinician. So they will not care how much you know until they know how much you care. This is a Aristotle had said this, but I apply it for my patients. If I have a knowledge, I am privileged to be on this side of the table. I have to give the patients, my patients, complete evidence-based decision. And it is, I know it is difficult for you to cope up with the evidence, but this is just an example I tell my students also. This is 10-year publication of only systematic review and meta-analysis and RCT.
वही तो मैंने आपको पूछा
And if you calculate the number of RCT, at least it's a solid evidence because you are going to use this evidence for your patients. So systematic review meta-analysis, if you calculate, it is more than 700. Now divide it by 700 days. Daily you read one RCT. So you have 700 days. And this is a 10-year publication in the first topmost 14 journals, and it is up to 8,500 articles. So divided by 365 days in a year. So roughly, I feel you have to read every day in 3 years 20 articles. You decide how you want to cope up with the evidence, but to keep, and I am not telling you that you read 100-year-old articles also, but yes, there are still some articles which don't have any other evidence. We have to refer to those gold standard articles. So it is very important that you keep yourself updated with the reading of articles and journals. And the fifth point I would like to stress is rational thinking. R stands for rational thinking. Now, rational thinking and critical thinking. Now, this is a process of orthodontic diagnosis and treatment planning. It is a continuous process. You cannot separate diagnosis from treatment planning. And in orthodontics, it is only one diagnosis. There can be 10 treatment plannings, but remember the diagnosis will be only one. It is a scientific fact. It is the truth. And treatment planning is a wisdom. How you are going to use your knowledge to treat your patient, that is a wisdom. And that is decision, scientific decision will come on your rational thinking. Now, what is rational thinking? We have to interpret, we have to analyze. Now, interpret is when you do clinical exam. what I told you
इलेक्ट्रिकल
is
की बात
clinical examination. You
10 मिनट बाद
interpret
फिर
why
2 मिनट
this
का
patient
रिविजन
is
उसके
having
बाद फिर
this,
1 घंटे का
why
फिर से
he or
लॉन्ग
she
लेक्चर
is
चलेगा।
here.
विशेष नहीं होगा
Then analyze. You do
विशेष
all
नहीं होगा
analysis, what you
तो
want,
बूढ़े
body
देख होने वाले
analysis,
के
cephalometric
1 घंटे का
analysis,
लेक्चर
soft
सेशन
tissue
बाद फिर
analysis,
अटेंड
whatever you want.
जो आपको नहीं खा सकते
Write down the
नहीं इसलिए
information,
बोल रहा हूँ जब 1 घंटे का कंटिन्यू
evaluate,
रहेगा ना तो मैं तो
and
जा
then
सकता
take
हूँ।
a decision.
आप मुझे बता दो
So
तो मैं
it
वो
is a
वीडियो का काम करूँ तब
rational
जाके
thinking.
मेरे को भी
Now,
ज़्यादा करने की जरूरत नहीं
logic and reasoning is
है
required.
हुआ ये
You
मेरी
have
वायरिंग
to
चेंज करना
evaluate the evidence,
इसको इसमें डाल देना
and you have to do clinical reasoning and
ऐसे होगा ही नहीं,
self-assessment.
बंदे ने दे दिया होगा ही नहीं।
Now, critical thinking is the process we use to make a
कैमरा मैन अभी
judgment
उसको
about
वो क्यों नहीं
what to believe and what to do about the symptoms our patients presenting for diagnosis and treatment plan. That is what is critical thinking. Now, I'll show you one example, then you will
और 1
understand.
सेकंड लगेगा
We know the evidence. Now, for a moment, you understand that we are well versed with the evidence. Now, we have to make a judgment
एंगल देख के
and then take a clinical decision about whether we are going to extract or we do surgery first or we do decompensation first. So there are three types of decisions. Decisions under certainty, decisions under risk, and decisions under uncertainty. In orthodontics, always the decisions are under uncertainty. Because as I said, we are not treating the static occlusion, the malocclusion, we are treating a dynamic malocclusion. In a continuously growing phase, we are moving the teeth. And as every speaker in the since morning has said, we have to see that my patient should look good even after the age of 25 years, after the age of 50 years, and it should be stable. Now, stability is again different topic, but yes. So now, the under risk means the predictable outcome is there, but we know that there will be a risk of this, like the previous case, could be root resorption when I am correcting the transposition. There could be a risk is in a class 3 case, if I would have extracted at the growing age, I would have had to do again
क्योंकि यहाँ से
retreatment
काम अटक जाएगा
to treat after the growth.
मुझे 10 मिनट टाइम मिलेगा उसमें मैं खा के
So this is a
फिर मैं बैठ
patient
जाऊंगा
who reports my
बाहर
front
जाके नहीं
teeth
खा सकता
are sticking out and I cannot close my mouth. This is a genuine complaint what the poor child
मेरे
has.
पास वो इसका आईडी है मतलब
Now I will uncover the identity just to show you that how we have to, the time patient walks in, we have to see, catch up so many factors. The sclera is visible in his eyes, so that means it is a maxillary hypoplasia related to some breathing problem. There is nostrils are underdeveloped, the nose is short, you can see, and there is large interlabial gap and typical convex face at the younger age. Now, if you see intraorally, in the upper arch, deciduous canines are present and lower arch permanent dentition. So, dentally he is little advanced. You can see canines are erupting in a transposition phase between the second and first premolar in the buccal vestibule, exactly at the frenum, buccal frenum. The canines are coming there. So there is a transposition. So just few minutes back I said there could be maxillary lesser growth. Transposition is there and you can see there is less overbite and less overjet. Buccal segments are well aligned, class 3 molar relationship bilaterally, and you can see lower teeth, they are inclined lingually. I should take, these are the markers for me that yes, I have to plan now extractions for this boy, divergent jaw basis, but at the age of 9 years, A and B is just 2.7. So A and B is normal. Though his face looks convex, because diverging jaw bases, you can see maxillomandibular rotations and supraeruption of maxillary and mandibular incisors. And you can see adenoids blocking the airway. So after, I will skip this since the time is approaching, I will put all of them. As I said, you need to have a rational thinking. I have jotted down the chief complaints, the problem list, incompetent lips, how can I solve, retraction, convex profile, ENT consultation, functional analysis, we have to do growth modification, mouth breathing is there, I can give oral screen, correction of bite by alignment of teeth, traumatic bite, constricted arches, you can do expansion, severe crowding. There is good article in absence of posterior crossbite, what is the evidence for skeletal expansion. Severe crowding, you can do extraction, transposition, alignment and correction, recession, correction of root position. Now for every problem, I have to first know the solution and then I have to find the interaction among the solutions and then plan the treatment. So I have, now coming back again, now if you see the maxillary arch, if I extract deciduous canine and first premolar, and correct the canine, there will be excess space and it is a maxillary hypoplasia. So I need to move the upper molars forward. Fine. Because there will be, only thing is I have to control the vertical eruption. So I have extracted lower incisors and two maxillary first premolars and of course the holding arch, and I have completed the treatment correcting the transposition. It becomes easy to correct the transposition when you extract premolar. Now this is post treatment. Now you can see, I know there cannot be any magical changes in his nose, but some amount of nasal growth has taken place, but mandible has grown. Now what I want to tell you is that evidence, what is the evidence is factors affecting mandibular displacement. Exactly what Dr. Prem Kumar also mentioned, we can control the displacement. So how it is, the determinants of anterior facial height, maxillary sutural lowering, eruption of upper and lower molars, and determinants of posterior face height, vertical condylar growth may be downward, backward and posterior, upward or straight upward, lowering the articular fossa. Now this is the Bjork and Skeeler, what they have given, implant study evidence, the famous implant study, and it tells the dentalveolar growth changes during adolescence. The maxillary molars, they erupt downward by 1.2 millimeter in adolescence per year and 0.6 millimeter mesial movement, whereas lower is 0.9 millimeter and 0.5 millimeter. Incisors also 0.9 and 0.3 millimeter. Now, when I know this evidence, why should I extract the posterior first premolars in the lower arch? And when he has a lingually inclined molars, posteriors, that means the tongue is not, in spite of airway blockage, the tongue is not coming ahead. So this is how we have to do the rational thinking, critical thinking. And this is how the displacement rotation and remodeling rotation I have controlled. Displacement rotation, it will have a downward and backward, so chin prominence will reduce, and when I do this, control this, there will be a remodeling rotation, which is exactly I have used that to get the results in this case. So define the problem, analyze the problem, identify the severity and identify the causes of the problem, identify a solution, brainstorm, and then narrow down your choices and take the best selection. So critical thinkers, they will be capable of taking positions or changing position as evidence dictates, seek the information as well as precision of information, be open minded, take the entire situation into account, keep the original problem in the mind, search for reasons, deal with the components of complex problems, seek a clear statement, look for options, and exhibit severity, and use credible sources. So, alternate to critical thinking, ask someone else to do nothing, to keep on doing the same thing which is failing, and to do something, anything new just because it has not been tried yet. So these are the possibilities how if they are not, they don't want to do critically think, they will do it like this. So the mistakes are, common mistakes are misunderstanding the role of clinical examination, the importance of evidence, resorting to the intuitions, simple formula, and insufficient individualization. So remember, our beliefs determine our values determine our actions, and our actions are expressed in our care and love for our patients. Thank you so much.
Thank you, ma'am. Over to the chairpersons.
Thank you, madam, so much. It was such a wonderful oration. You have truly justified and you have enlightened our young generation with the, yes, you have given the way to how to steer their life further. And it is so apt, like our theme also this year is ethical, rational, clinical excellence. So you have talked about all those things, and definitely this is going to benefit the audience. So thank you so much. We
Thank
are
you so much.
privileged.
I would request the chairpersons to please felicitate ma'am.
Uh, in honor of the person who has given the oration and in honor of the person who was the founder member, Dr. H.S. Sheikh, in whose memory we have this particular oration, I request all of you to please give a standing ovation.
I request Dr. Shailesh Shenawa sir to please come up the stage and felicitate our chairpersons. Thank you, sir. Our next guest speaker for today is Dr. Abhishek Ghosh. Sir did his post-graduation in orthodontics from Manipal College of Dental Sciences, Mangalore. He is a diplomat of the Indian Board of Orthodontics and has the unique distinction of having a fellowship from all four Royal Colleges of Surgeons, Edinburgh, England, Ireland, and Glasgow. He is the winner of the George Jacob Award for Excellence in Clinical Innovation presented by the Indian Orthodontic Society for the year 2014. He is a fellow of the World Federation of Orthodontics and the American Association of Orthodontists and certified in lingual orthodontics, incognito, and clear aligner therapy Invisalign. We welcome you here, sir. The chairpersons for this session are Dr. Sam Paul, sir, and Dr. Gautam Reddy, sir. Dr. Sam Paul, sir, is the professor and HOD of the Department of Orthodontics, Educare Institute of Dental Sciences, Malappuram. Sir is a medical director Exodus Dental Care, Kalpata Vayanadam, and was a member of Academic Council of Dr. D.Y. Patil University till 2012. Dr. Gautam Reddy is a professor and head of Department of Orthodontics, Kurk Institute of Dental Sciences, Karnataka. He is presently executive committee member of the Indian Orthodontic Society and the convener of the Mysore Kurk Orthodontic Study Group. Also the zonal editor of the iOS Times and the vice president of the Indian Dental Association, Kurk. We welcome you here, sir. The stage is yours.
Hello. Hello. Yeah. So, a good afternoon to all, one and all. And we are going to talk about a very hot topic in orthodontics called as effectiveness of clear aligner therapy in various type of malocclusions. And there's a lot of debates about this topic, okay, as it is a recent trend in orthodontics. And we have to correlate between literature review and clinical outcome. So when we talk about the era of orthodontics called as digital and customization in orthodontics, aligner orthodontics takes a pivotal role. Although aligners have been effective in treating the malocclusions, it has to be understood that it is not the best of appliance which is still available in the market. Predictable movements of tipping, intrusion, distalization, maximum amount of predictability is about 72%, while unpredictable movements are torquing, extrusion, and derotation. None other than Lysel Johnson stated that, in short, today's aligner technology warrants serious attention. The water is rising, is high and rising. So it's not still lived up to the expectation. There is a lot of innovations involved. And here we are to judge what is the present status of aligner technology in the world as such. Whenever we are talking about aligners, you have to understand that we are going to divide this whole presentation into a variety of topics. It's going to be based on malocclusions. The first one that we are going to talk about is class 1 crowding, and we will arrange the articles accordingly. The first thing about the malocclusions regarding crowding, which is a class 1 crowding, is to do with rotations. Rotations, what aligners are not too good at. Garrett et al. In AJODO 205 stated that the posterior rotational corrections are less predictable and anterior rotational corrections are better. Traditional fixed orthodontic appliances are still better in correcting rotational occlusions, malocclusions than aligner therapy. Daniel Kuncio et al. In AJODO 207 suggested that there is a lot of relapse associated with crowdings when they are treated with aligners, and hence it has to be understood that suboptimal root positioning being one of the main reasons. Orpheus et al. Suggested that derotation of the maxillary canines are least predictable of all the teeth. So a lot of articles that has come to the forefront. The one which sums up everything is that the predictability of resolution of crowding width in the upper arch is about 87% and 81% in the lower arch. Hence, it calls for a lot of refinements and other things that needs to be attended to. A whole lot of mechanisms has been used by aligners to correct decrowd. The one of the thing is proclination, which is about 70% predictability, arch expansion, which is about 59 to 83% in the upper and 49% in the lower, and IPR, which is far lesser. IPR is least predictable of all the things, basically because of the operator bias. Now, whenever we talk about articles, it put us to sleep, I know, and therefore every malocclusions would be accompanied with a case as such. Let us talk of this guy, okay, who comes at 22 years of age with gross irregularity of teeth. He comes because of an anesthetic smile or non-consonant smile arc, and as you can see that he also has a mild anterior open bite and severe crowding in the upper and the lower arch. He also has a mild convexity of profile, but relatively it doesn't call for an extraction case. When we talk about the intraoral findings, he comes with blocked out canines, he comes with anterior open bite, And as you can see that there are mild crossbites in the posterior teeth. And here, if you find that, you will find that open bites are there together. So this is basically a typical crowding case which presents with a blocked out canine. Whenever we talk about the intraoral findings, we find that it's a V-shaped arch form. And one thing that needs to be noted in this case is that it presents with dental fluorosis, and hence the chances of dental caries reduces drastically. And hence we opt for a non-extraction protocol like IPR together with arch expansion. These are the lateral cephalobarometric parameters. And once you see, what we find out from the numbers is that it's a class 3 skeletal base, it's a vertical growth pattern, it's an edge-to-edge bite with anterior open bite, and we are looking at a camouflage of a dental class 3. When we look at the orthopantomogram, we find that, okay, there is a definite amount of crowding. We have the third molars in place. So we are in a dilemma about extraction versus non-extraction. So I opt for a non-extraction treatment plan. The first thing that we do is a clean check. The first thing is instruction to the company. You will find that everything is written here. We have written that we don't want to procline the incisors. We also have written that the open bite needs to be corrected by the extrusion of the incisors, basically because of a reduced incisal show. And we need to get a consonant smiler. A dental crowding is basically, this is what you get from an aligner company, the clean check. But everything has to be predetermined. The attachments has to be decided by you. Hence, in order to correct the anterior open bite, we use an optimized gingival beveled attachment. In the posteriors, you will find that we are looking at arch expansion, and hence an optimized expansion support attachment and optimized rotational attachments were used. In the posteriors also, in this side, we are looking at a cross bite correction. Hence, a regular big attachment was used to have a grip on the aligner. Therefore, what brings us to is that this videograph, we shows that how and what time frame we are going to correct it. Basically, we are looking at a bit of arch expansion, a bit of decrowding from IPR, and we are looking at a bit of retraction, because in the process of doing non-extraction, we don't want to worsen the profile. So you'll find that we are looking at decrowding, and we are creating space by IPR in order to bring down the buccally blocked out canines. So whenever we are looking at on the left hand side, you will find that we are looking at crossbite corrections and bringing about dental and skeletal crossbite corrections in the posteriors. So all these things. Now the question comes, how much is it predictable? We have to understand that whenever you are using, it all depends on patient compliance, the operator, how they are operating, use of attachments, use of aligner wears, and a whole lot of predictability factors which actually determine how much amount of correction you're going to get in the first set of aligners. And hence you need to go for refinements. So that's how it corrected. And therefore, this is how we went ahead and did the treatment. So this is an optimized beveled attachment in the anterior. Since it was a class 3, we wanted to give a mild class 3 traction. So you can see a lingual button being placed and a class 3 traction being given. Also an expansion support attachment in the posterior and rotational attachments in the posteriors were given. Into 14 months of treatment, you can see the amount of improvement that has come up, and we want to show that he is on an aligner wear. But that's not the end. We need to see root positioning, and the use of aligner does not allow us to accept cases below par or below norms. So this is on the patient on aligner wear. Mild class 3 tractions with 2.5 ounces of forces, which are given. And this is the final result of the treatment. The final results of the treatment show it's a class 1 molar and a canine relationship with ideal overjet and overbite, with bonded lingual retainers and a Vivera Invisalign retainer, which was suggested to the patient. The decrowding by arch expansion, we have no root resorption, proper root divergence, and proper root divergence in the lower anteriors also. The decrowding was done well, and we were able to retract it by minimal stuff. So therefore, you find that it is still a class 3 to end with skeletally. It's a vertical growth pattern, and we have done the dental decrowding well. Everything calls for superimposition in today's world, as you can understand that we did a little bit of retraction in both the upper and the anteriors. Spaces attained by arch expansion and IPR. So this is how we improved the patient smile from a non-consonant smile arc with decrowding to a perfect smile that you got at the end of the treatment. Now, a profile which was maintained well, and at the end of the treatment, it is a combination of soft tissue-based treatment planning, operator skill, quality of the products, and patient compliance. So nothing in aligners, okay, you need to have a lot of patient compliance. It's not like fixed appliances. We come down to the next part called as class 1 spacing. Orthodontic clear aligner treatment have to be understood that they are very efficient in closing up spaces. Space closure is faster and efficient in clear aligners as supported by Wheeler, which came out in seminars in orthodontics in 2017, and deepening of the bite during space closure is very common. Uncontrolled tipping might predispose to root resorption. So you have to understand that aligners are not good at bodily movement. All space closure is basically by controlled or uncontrolled tipping, depending on the use of power ridges, which we're going to discuss later. A systematic review by Lydia et al. Suggests that closure of space is mainly by controlled tipping. Time required for closure of spaces is shorter than fixed appliances, basically because of the type of the movement, rather than or minimalistic force. A cone beam computed tomographic study by Jiang et al. In AJODO suggests that clear aligners are efficient in cases of non-extraction space closure. Predictability of tipping is about 72%, while the expression of the torque is very, very poor. It's about 35%. Closure of space by bodily movement of the teeth is basically rare. So whenever we are doing orthodontics, all our postgraduate teachers tell that we try to move the teeth bodily. That is probably what aligners might claim, but it's not happening regularly. Has Invisalign improved over the years? Haloli et al. In AJODO 2020 suggested that no, it has not much. Most predictable tooth movement is still buccolingual tipping with about 56% predictability. Overall accuracy is good and predictable, but uncontrolled tipping is still very common. Root positioning and control still remains a question of concern. So you have to understand that whatever protocols Invisalign have come up with, G6 protocol or any protocols, optimized attachments, the results doesn't reveal the same concepts that they are put forth. We're going to talk next about class 2. The first thing that we are going to talk about is growth modulation. One of the commonest growth modulation thing that Invisalign promotes in today's era is about Invisalign Teen, called as the mandibular advancement appliances. Sadly to note that in 2024, Mead et al. And Tony Weir put forth that less than 50% of overjet correction was attained only. Less than 33% of the patients required anterior-posterior correction and molar relationship correction. 20% of the patients finished the MAA phase with increased overjet. Please try to understand that it is not acting like a proper functional appliance, just like a twin block. And this is evidence that we are talking about. We are not talking about individualistic case reports. We're going to talk next about class 2 division 1, extraction and retraction protocol. Fandai et al. In AJODO 2019 proposed that anchorage control of the first molar and incisor retraction was not fully achieved. Age, attachment, and initial crowding affected the variability of results achieved. Auxiliary anchorage devices, power ridges, attachments, and multiple refinements are to be considered if you are to treat an extraction case with Invisalign or clear aligners, any other sort of clear aligners. What does it do? Mead et al. In Angle Orthodontics 2024 suggested that achieved overjet and overbite correction did not match the prediction and completion of aligner where initially it was prescribed. Only 40 to 50% of the overjet correction was achieved. Bowing of effect, what we call as a roller coaster effect, is very, very common with aligners, which means that you get a lateral open bite and anterior deepening of the bite when you are treating an extraction case, and you require multiple refinements and other associated stuff to correct it. Since a problem comes up, Invisalign comes or aligners come with a solution. Zhao et al. In Progress in Orthodontics 2024 suggested that enhanced structure, which is like thickness of the aligner, be increased in the posterior segment, could augment anchorage. Mesial tipping of the second premolars were noted to be less, and bowing of the arch and deepening of bite were less. But this calls for a systematic review because this is an isolated study and we have not found out any other study substantiating the same. The next thing that we talk about class 2 correction is segmental distalization. Now you have to understand that aligners are very good at individually segmentally dislicing the teeth from a class 2 to a class 1. Dislication of the molars predictably can happen in only 2.25 millimeters. Over that, you get distal tipping. Class 2 elastics during dislication is a must requirement, otherwise you have anchorage loss. You can use mini screws, you can use class 2s, but then the effects of the class 2 elastic supersede the effects of the aligners. When we talk about this article in 2023 by Boshun et al., tipping of the molars are associated in segmental distalization. Proclination of the anterior teeth are noted, loss of anchorage is noted. All study talk about loss of anchorage while segmentally dislicing teeth. Liu et al. In 2023 suggested that true segmental distalization of the teeth is possible with aligners. Use of class 2 elastic during distalization augments the anterior anchorage, but there is a problem. It might bring the lower molar forward and might mimic distalization, but you need to superimpose on cases on your x-rays to understand whether true distalization is happening or not. Kwok et al. Angle orthodontics 2023 suggested that attachments are essential for effective distalization process. Mini screws are better than class 2 elastic for total distalization. Due to deformation of aligners, distalization with button on the canines are more effective than direct force to the aligners, because a lot of time aligners give you an option of having an aligner cut in which you can engage the elastics. So it says that aligner is basically flexible and it might bring more flexibility to the aligners. We have been doing aligners a lot, and therefore this is probably a clinical implication that you can see. A segmental distalization happening, an IZC being placed on either side, and a canine being held into place so that it doesn't lose anchor where segmental distalization is happening. These are very prominently used in retreatment cases that we are doing. The third one that we talk about is class 2 div 2. And in div 2, we talk about torque. One of the commonest ways of gaining torque in an aligner is called as a power ridge. Now they claim that a power ridge is very, very effective in controlling torque and bringing about bodily movement, and you can torque incisors. However, studies say otherwise. The moment generated by an aligner within the range of orthodontic force and can bring about torquing theoretically. Power ridges do tend to accentuate the moment generated. It's true, but is it effective or not? In Progress in Orthodontics, again in 2018, results should be determined with caution. Expression of torque in labiolingual movement is one of the least predictable, while tipping being the most predictable. So you have to understand that when you have a div 2 case where you have incisors which are under torque or retrocline, probably you needn't start with an aligner. Probably you need hybrid appliances along with aligners to correct such problems. A systematic review by Lydia et al. Suggests that buccolingual inclination and controls are poorest with clear aligner system. Fixed appliances are better than clear aligners in torque control. When we talk about the effectiveness of torque, Cheng et al. In 2022, it's a recent study, talk about in spite of power ridge, palatal tipping with aligners are inevitable. Favorable for cases of procline incisors, gaining of torque in cases of retrocline incisors are unpredictable and not as per the clean check. So if you get a case like this is a clinical implication. If you get a case like this, where you have retrocline incisors, you need to torque the incisors, get an overjet, and then you need to dislice and retract. Aligner may not be the best option for you to start off with this case. Now we're going to talk about class 3s. We're going to talk about distalization and camouflage of class 3. For all the studies that we saw over the years, evidence for a class 3 camouflage is lacking. As simple as that. They are merely case reports. Effectiveness for class 3 correction, clear aligners are effective in lower molar distalization, segmental distalization. Expect mandibular molar to dislice by 2 to 3 millimeters. And that came out in Curious 2023. Evidence is still lacking. In 2017, it clearly states that Chan et al. In seminars in orthodontics states that class 3 correction is basically opinion based and case report based. Class 3 mild class 3s can be treated with aligners. How do we treat? Is by lower incisor extraction, class 3 elastics, and segmental distalization. Control of lower incisor inclination torque is very difficult. Dumping of incisors are very common. Bowman et al. In 2017 on the similar journal suggested that case selection is the sole criteria for success of cases with clear aligner. Aligners do not provide enough control to camouflage skeletal malocclusions. What is the skeletal thing that we are talking about? Can class 3 be corrected by skeletal class 3 be corrected? Yes, evidence is lacking, but this is an article on orthodontic surgery for Invisalign. And it clearly states that it's Staub et al. In seminars in ortho. It talks about aligners are unable to provide anchoring hardware for intraoral splint. Hence, auxiliary arch bars, IV loops, intermaxillary fixations are all required when you are combining orthognathic surgery with clear aligner technology. So that's an option that is available, but for you to understand and take. Let us see our class 3 crowding case. This is a patient who comes with class 3 skeletal base, dental crowding, and chipped lower incisors. He comes with a negative overjet, reduced incisal exposure, and dental crowding. It's a class 3 malocclusion with negative overjet and dental crowding, and the concavity of profile, mild protrusion of the lower lips. So what do you see? You see there is an occlusal wear. You see negative overjet and overbite. You have spacing in the lower anteriors. What you see here, you have occlusal wear of the lateral incisors. You have spacing in the lower anteriors. You see occlusal wear because of the negative overjet, and you have spacing distal to the canine. You have a wide arch form, and you have to understand that this patient has trauma from occlusion following a class 3 skeletal base, class 1 dental relationship, and dental alignment and negative overjet correction is all that is required. So a lateral cephalogram shows that you have a class 3 skeletal base, a horizontal growth pattern, a negative overjet and overbite, and what you need to do is camouflage the class 3. We are suggesting a non-extraction treatment plan for this patient, and what is our instructions in the prescription that we gave? It's finished with ideal overjet and overbite. You correct the trauma from occlusion, get a positive overjet. So this is what we have. You need a class D crowding and you need class 3 traction. Optimized root control attachments in the lower anteriors are required. Optimized extrusion attachments are required because the class 3 correction also happens with extrusion of the posterior teeth by clockwise rotation of the mandible. Optimized rotation attachments are there, and if you go through the video, you will understand that you are jumping the bite basically. All that you need to do is that you need to jump the bite, and your thickness of your posterior aligner, if they are increased, would provide that bite plane effect in which you can correct this whole problem. This is what you see. Now, when you are bringing a palatarily locked in lateral incisor, you need power ridges to control the torque. Jumping of the bite to control the TFO, controlling the TFO and bringing the lateral incisor forward. And what happened? After 12 months of aligner treatment, things look better. But what is the problem? You have an occlusion problem, you have a torque issue. This is what the guy looks like. Looks promising, but this case has a lot to be done. Due to the clockwise rotation of the mandible, the profile has improved, but we need refinement. So what do we want in the refinement? We want root uprighting, we want overcorrection of the negative overjet, and we want to correct the torque. So this is what we have, an optimized extrusion attachments, because you need to develop a smile arc in a patient of class 3 where reduced incisal exposure is there. So that's what we want. We basically want in this case not much of alignment, but we want to extrude the anteriors, we want to upright the roots, and we want to get a seating occlusion. But you know as such, okay, it does not happen as predicted. So this is how it finished, okay, with a class 1 molar, class 1 canines, after all of aligner wear. But what happened? You have a mesially tipped lower second molar. Can you ignore it? No, you cannot. So what we do, you have a mesially tipped in lower molar, which needs to be individually corrected, and uprighting of molars is one of the toughest movement that you can attain with an aligner. So what do you have? You need hybrid appliances in which you can segmentally bond braces and upright that individual teeth, because it's going to take a lot of aligners. Also, there's a lot of patients who do not become compliant after 20 months of treatment. And this is what we got at the end of the alignment phase of the second molar. It is very, very essential that you treat finishing of aligners like finishing of dental braces treatment. And this is how we finish, with class 1 molars, class 1 canines, ideal overjet and overbite, and a perfectly seating occlusion, and the second molars in place. This is how the post-op OPG looks like, with no root resorption and proper root divergence, just like your braces patient. This is a crowding which is revealed. You got a positive overjet at the end of the treatment and a camouflage of a class 3 well done. So how did we camouflage a class 3? A camouflage of class 3 is by dental tipping, mandibular molar distalization, clockwise rotation of the mandibular plane. That's how aligners work. If you see this patient presents with starting to ending post-op. You have a 45-degree view which looks really good. You have a class 3 which is relatively well corrected. Still the anterior divergence is there. But at the end of the day, it's treatment planning, operator skill, quality of the products, and understanding the deficiency of each product in treating a case, and patient compliance and motivation. Now we talk about cross bites. You know, whenever you get cross bites, posterior cross bites, we want expansion. What does aligners do? Accuracy of expansion in the maxillary arch and mandibular arch is 72 to 87%. The expansion is not skeletal. It is purely by tipping, and dental expansion is only what is expected. So what you see in a clean check as the teeth moving bodily to correct does not actually happen in clinical practice. Ning Zhu et al. In AJO-DO 2020 suggests that dental expansion by tipping only happens with aligners. You need attachments with additional buccal root torque to avoid this problem, and bodily movement in expansion is only 36% predictable. If you look at this article in KJO, it talks about dental expansion with Invisalign did not cause relevant reduction in alveolar bone thickness. That's good. So tipping is slow, so you're not having dehiscence much, but case selection is very, very important. If you really want skeletal expansion, this article by Benedict Wilms in AJO-DO 2021 talks about use of MSC or MARPE and then use aligners to decrowd. This is what we are talking about. Certain appliances are not capable of doing certain things. We talk about deep bites. The management of deep bite with aligners is basically with the effect of virtual bite ramps, use of class 2 elastics, and leveling of the curve of P. Nowadays, the concept of sequential intrusion of the canines followed by lower incisors have come up. However, we need to understand that bite ramps are effective, but most predictable mode of correction of deep overbite is by flaring of incisors, not intrusion of incisors, when aligners are concerned. So you are using Ricketts utility arch and other utility arch, they bring about intrusion or tabs, but here flaring causes overbite correction. True intrusion of incisors are very unpredictable, less than 35%, and extrusion of the premolars and molars are the ones which are usually done along with class 2 elastics to correct your overbite. So it's not very good in cases of vertical growth pattern basically. Has Invisalign improved? The modus operandi of deep bite correction remains unchanged over the years, right from 2008 to 2020. Mandibular incisor intrusion is not predictable. So if you are, so long as, okay, they claim to what is the reality is different. Predictability of overbite control by Blundell et al. Suggests that ClinTech software overestimates overbite correction by 95%. Only 39.2% prescribed overbite correction is actually expressed. Fixed appliances are better for overbite correction. Effectiveness of deep overbite correction by Al-Wafi in Dental Review Journal in 2023 clearly states that your fixed appliances are far better in treating overbites in complex cases than aligners. The last section we talk about open bites. You have to understand these open bites work wonders with aligners. Aligners, when they correct open bite, is basically by maxillary and mandibular incisor extrusion. If you have the idea that since you're wearing an aligner, you are occupying the freeway space and posterior intrusion is happening, it does not happen predictably. Unplanned molar intrusion might happen in 70% cases, so it might give you a little bit of vertical control, but never better vertical correction. Effectiveness of overbite correction does happen. Open bite correction does happen in 94% of the cases according to Su et al. In 2021. Aligners correct anterior open bite by maxillary and mandibular extrusion. Use of aligners do not actively intrude the posterior teeth. Therefore, they do aid in vertical control, not vertical correction. Unplanned molar intrusion with Invisalign. Kogolos et al. In AJODO suggested that in 2022, unplanned molar intrusion happens in 75% of the cases, but it is not what you have planned. In some cases it happens, in some cases it does not happen. Average molar intrusion is about 0.9%. A comparative study by Steele et al. AJODO 2022 suggests that this is very, very important, because now we are talking about TADs in comparison with aligners. Lot of speakers over the years we have been hearing talks a comparison between Invisalign and TADs. Please try to understand their modus operandi is completely different. Effectiveness of overbite correction. Mini plates correct anterior open bite by intrusion of the molars and counterclockwise rotation of the mandible. Therefore, they are correcting the vertical component. Aligners correct anterior open bite by maxillary and mandibular incisor extrusion. So if you have a gummy smile, or if you have certain things and you have an open bite associated with it, expect the gummy smile to increase. If you have a patient where the incisor show is less, aligners will work, because that open bite is not due to skeletal reasons, but it is due to dental reasons. So you have to understand that one sort of system cannot replace the other. Both are advantageous in their own ways. To conclusively talk about how aligners are treated, let us see a very complicated case. Anterior open bite, this patient presents at 26 years of age and would go for online monitoring. Remember that this patient is not from Calcutta, where I come from. Is a patient working abroad or studying abroad in Singapore. He comes with spacing and difficulty of speech of anterior open bite. He complains, his father complains, in fact, about thumb sucking and secondary tongue thrusting till about 8-9 years of age. You have to understand that open bites, that is where case selection comes into the picture. When you talk about, this patient was presented at vertical growth pattern, I would have used mini screws along with aligners. But here you see in this patient, you have a non-consonant smiler and a reduced incisal exposure on smile. And how does aligners close open bite? By extrusion of the incisors. You have reduced incisal exposure, you have an open bite from premolar to premolar region. The anterior open bite that you see is associated with a concave facial profile also. So it's protrusive lower lips and a class 2 tendency. The intraoral finding shows that there is a high frenulum attachment. There is an open bite of about 7 millimeters in the anteriors. Lateral incisor is about 8 millimeters. 4 millimeters in the canine, and in the premolar is about 2 millimeters. So what do we see? We see that there is a class 3 skeletal base, a super class 1 molar relationship, and an open bite we started from the second premolar region. On the left hand side, it is also associated with similar problems, and you also have a class 3 molar relationship. What you find in the intraoral findings is that you have a upper arch, which has a spacing of 5 millimeters, and a lower arch of about 8-9 millimeters. I have not shown you a spacing case to start with, just because this case clubs up both the things. Difficulty in pronunciation, open bite aggravated by tongue posture, is other problem that you see. So you see that you have a pre-treatment problem with open bite, and what do you find? You have a class 3 skeletal base, average growth pattern, negative overjet, anterior open bite, and a camouflage of class 3 that you are looking at. What do we do in open bite cases? We want to extract the third molars, but please try to understand this patient is a horizontal grower, not a vertical grower. So we opted out of it. What is my prescription? I had a whole lot of objective, correct open bite, and you need to specify. Please try to understand that this is not DIY or auto mode. You need to instruct the technician as to what type of tooth movement you want. So correction of open bite primarily by extrusion of the upper incisors, secondarily by extrusion of the lower incisors. So I don't want the lower incisors to extrude too much, but I want a consonant smiler. Correction to class 1 molar relationship, overjet, and we are looking at overcorrection. Because if you finish with the edge to edge bite, you're not going to finish well. It's going to relapse. So this is how the whole thing is. So you have a clean check which came, and we instructed about an optimized gingival beveled attachments in the anterior extrusion. And this is the type of the tooth movement that we are looking at. We are looking at extrusion of the incisors. Had this patient been a vertical grower, I wouldn't opt out of aligner. In my clinic, we are very specific. The patient does not choose the appliance. It is us, we choose the appliance. If the patient doesn't want to wear it, okay, we don't do the treatment. As simple as that. So if this case, the patient would have told that I am abroad, you put aligner for me, and if the patient is a vertical grower, I wouldn't have taken up this case. It was taken up because extrusion of incisors were required. And if you look into the literature, you will find extrusion is one of the most difficult type of tooth movement that you can do or required with aligners. So that's how we have a class 3 traction, because we are correcting the class 3. We have buttoned attachments placed because we want to put box elastics, because only beveled attachments is not going to help. And this is what we have. We want to bring the upper segment forward. You get a positive overjet by dislodging the lower, basically by the effect of class 3 elastics. And what happens is that aligner wear negates the extrusive component of the class 3. That's also you need to note. This is what we attained at the, you need beveled attachments plus the use of box elastics. So that's how you do it. And this is the final result of the treatment. So what did we get? A finished class 1 molar, slightly super class 1 molar relationship, canines with ideal overjet and overbite, but we have corrected the anterior open bite of 7 millimeters. You also have to understand that retention in such cases is very, very important. So she has a nighttime wear of a tongue clip and a bonded lingual retainer. Alternate to this, you can use your aligner, make cuts in the lingual aspect of the aligner, and then that might act as a tongue spike. That's optional, is there, but I opted for this. What is the result that we got? The results we got is astonishingly fine and good. Now, this is the post-op, and we found out that all the, no root resorption with proper divergence of the roots. The anterior open bite correction post-tracing, and this is the final result. We show that it's still a class 3, but camouflage of class 3 is being done well. And how did it happen? It happened by a bit of retraction of the upper incisors and extrusion of the lower incisors also. What we need to see about this case is that after 2 years of treatment, let's compare, because open bites have a problem of relapse. So this is after 2 years into retention. It's still a class 1 molar and still a slightly super class 1 molar relationship, and it's holding well. What is the effect that we got out of this case? We got overall a gross improvement into the facial profile and smile. You have a negative smile arc which is being corrected because you extruded the anterior segment. You have a 45-degree angle which shows a beautiful profile at the end of the treatment. A class 3 profile looking far better at the end of aligner treatment. And you have a presentation of a perfect treatment planning, quality materials, operator skills, patient compliance, and patient visiting the orthodontist for only 10 times because he was abroad. We also have to understand, to conclude, that evaluation of Invisalign treatment and effectiveness. When aligners have come into the market and trying to encroach into the concept of fixed appliances, you have to understand two things. One is marketing. Number thing, the sellability factor, the non-extraction protocol. All these things decided by a company. But when we look into articles over the years, which is like 15 years, what we showed you in the last 40 minutes, we have to conclude and really on an unbiased note tell you that aligners still have a long way to go before they can root out fixed orthodontic appliance from the orthodontic market. Jaifeng et al. In AJ Audio exactly suggested this thing, and we are looking at a gross amount of research being coming up in the next. So let us wait and watch and not come to the conclusion and say that fixed appliances are not the way to go and companies are going to take our practice. This is reality, and this is what we put forth to an orthodontic crowd. Thank you for a patient listening, and I do finish on my time. Okay, for the opportunity and the honors given by the organizing team, with special mention to Shenava sir, and giving me an opportunity to present on a topic other than TADS, which I have been so fondly presenting for the past 12 years. Okay, everyone calls her a speaker by the name of the topic that he presents over the years. I hope I have done justice to the new topic that I'm presenting on. Thank you so much for a patient listening.
Over to the speakers, chairpersons. Thank you.
Thank you, doctor. That was very informative, and you have covered all the aspects of aligners, especially the indications, contraindications, pros and cons, and everything. I'm sure the audience might have benefited by that. Thank you so much.
I request the chairperson to felicitate Dr. Abhishek Ghosh, sir. Sir, please wait. I request Dr. Chetan Jayade, sir, to please felicitate the chairperson for the session. Thank you, sir. Our next speaker for today is Dr. Chetan Jayade. Dr. Chetan Jayade, MDS, MORTH, RCS, Edinburgh. Sir is currently the International Dental Ambassador and Regional Dental Advisor to the Royal College of Surgeons, Edinburgh. He is the Secretary of the Beck Study Group of Indian Orthodontic Society. Sir is the Chairman of Council for Scientific Affairs, Indian Orthodontic Society, 2015, and also serves on editorial board of Journal of Indian Orthodontic Society. He is also the reviewer of Journal of World Federation of Orthodontists. Sir is the author of textbook Class 2 Correction, Demystified with Fixed Class 2 Correctors, which is in progress. He has also contributed to the book Refined Becks for Modern Times 2007 and co-authored the textbook titled Essentials of Orthodontic Biomechanics 2011. Today, Sir is going to talk about understanding clinical orthodontics through biomechanics. We welcome you, sir. To chair for today's session, we have Dr. Gaurav Gupta and Dr. Rajesh Patil, sir. Dr. Gaurav Gupta is currently the Chair Public Awareness Committee of Indian Orthodontic Society, Associate Editor of iOS Times, Section Editor of JCO iOS. Dr. Rajesh Patil, MDS from AIMS, New Delhi 2003, is an ex-professor from the Department of Orthodontics at MGM Dental College. He is currently the director and partner at Braces and Smiles, India's first chain of orthodontic clinics in Mumbai. We welcome you, sir. I request Dr. Gaurav Gupta, sir, and Rajesh Patil, sir, to join the stage. Thank you. Chetan sir.
Yep. पावर सेविंग में स्लो होता है क्या? हम्म। बिफोर लेक्चर itself अभी लगा क्या इधर ही है? बायोमेकेनिक्स ऑडियो ये है ना? Good afternoon, everybody. Just give us a couple of minutes while there's some technical glitch. I think biomechanics post lunch is not a topic that the computer likes, right? But glad to see such a huge crowd and many Indian orthodontists, also the faculty members as well as the life members from the society. ये नहीं होगा because embedded videos है उसमें. वही बोल रहा हूँ ना. Yeah, let's do it. Well, while it is getting set, I must thank my previous speaker, Dr. Abhishek Ghosh, for a couple of things. One is to make all of you stay awake with a very energized presentation. And the second one for the fact that he has reinforced into all of you, especially the first and second years, who come into orthodontists, come into the MDS forum and think that we are going to learn only aligners because that's going to stay. Rather, it's a good time for me to elucidate certain parameters related to biomechanics. And what I'm going to do here is not make it a dry and a dull subject in which we talk only about theoretical concepts, but I'm going to give you a few pointers, let's say 5 or 6 pointers, which you can take back into your clinical practice right from tomorrow. So while we get started, may I know with a show of hands, how many of you are first year postgraduates here? Huge, right? Okay, and second years? That's also pretty large. So anyway, what I'm going to do is I'm going to do a bit of revision of the theoretical concepts and then give you the clinical take-home points. And if there is any difficulty in understanding or grasping in between, maybe we don't have much time, but then you can definitely contact me over email and then we can go ahead. Yeah. Hmm? Restart किया. एक बार एक बार. ये किया तो भी नहीं आ रहा है अपना. Hmm? ये दूसरा है क्या? कनेक्टर नहीं, दूसरा है HDMI. Sometimes HDMI doesn't work the same cable. है जो हेल्प कर सकते हैं? नहीं तो ये डिस्कनेक्ट करके देखो ना पॉइंटर का, जस्ट ट्राई विदाउट दैट. Is that causing the problem? नहीं ये तो हिडन है, ये वाला इशू करो, अभी ट्राई करो. नहीं, शुड वी कॉपी? नहीं ये भी नहीं आ रहा है ना, इस पे आएगा क्या? नहीं, बट दैट्स नॉट गुड बिकॉज नीड टू हैव द एंटायर प्रेजेंटेशन. वीडियोस वगैरह है, वीडियोस एम्बेडेड ऑडियो सब है. ये एक बार ट्राई चेंज करके देखो ना मेरे हिसाब से. डू यू हैव अनदर HDMI केबल, HDMI plug? Because the laptop is working otherwise, it's only with the connection. आ गया? वही बोल रहा हूँ ना, मे बी इट्स प्रॉब्लम विद द HDMI कनेक्टर का प्रॉब्लम. Sure. I'll check, sir. They're just trying out. ये लगाओ, ऑडियो भी है ना. पीछे जा रहे हैं. देखते हैं, नहीं हुआ तो छोड़ दो, बाकी का तो एक्सप्लेन करूंगा. फर्स्ट स्लाइड, हाँ इस पे रहता. Okay, sorry about that. I hope we are on now. Can we just move to the presentation? Yeah, that's nice. So, in the short span that we are going to cover biomechanics, which is otherwise a 2-day program for us in most of our workshops, and otherwise sometimes we have seen, at least I have seen in the departments like the University of Connecticut or even in some parts of Korea, they have an entire 2-month dedicated session on biomechanics. But I'm going to try and keep it as brief as possible and give you mainly what the nutshell is. So when you look at orthodontics and the way it has progressed over the years, it has been personality dominant. You have seen that people have come up with different appliances and magical gadgets, so to say, which focus only on the materials, the brackets, the wires, and the technique per se. But how many of us actually look at how the mechanics work? It's just like having a very fancy car, which is having all the new features, but unless you do not know how to operate, what's the use? So biomechanics itself is the sort of core foundation for a clinical orthodontist. All of you are going to work on patients, going to use brackets, wires, etc., give bends, expect a malocclusion to get corrected. But if you do not know the nuances of how a particular thing works, you're going to be in a big soup. And therefore, I would urge you, some of you, to at least the ones who have not had the opportunity to go through some of these sources which have a detailed and a dedicated focus only on biomechanics. My mentors in biomechanics have been my father, Professor V.P. Jayade, Dr. Burston himself, who had visited India, and this is from one of the photographs in Mumbai itself where he had come, and many of you who met Dr. Ravinanda yesterday, and Dr. Sunil Kapila. exhaustive writing by them, a lot of lecturing, and overall a clinical experience which helped me understand biomechanics. So what I'm going to do in this particular 35 minutes or so is try to give you, try to connect the dots, especially between the theoretical biomechanics and the clinical concepts that you as students should incorporate in your practice. And I'm going to give you some clinical tips for routine malocclusions. And mind you, I'm not talking about self-ligation, I'm not talking about aligners, I'm not talking about TADs, but we are restricting ourselves to understanding the focus of how teeth move under the influence of forces and moments. Now, why should you know biomechanics? I would rather say what happens if you do not understand biomechanics. It's like trying to be on a roller skate. The first time you try, I'm sure many of you might have tried, you lose balance and fall. Likewise, look at this person who tried skiing for the first time and didn't know how to operate the ski. What happened? He has literally fallen on his head facing down in the snow. So I do not want, or none of us want any of you to be in this particular kind of a shape when you work on patients. And therefore, I'm going to introduce or give you some topics which are relevant to clinical practice based on biomechanics. And what are these? Or rather, I would say, as a clinician, why should I really bother about biomechanics? It's just a theoretical subject. It's good for my essay question. I get good marks in that and in the Viva. No. I look at biomechanics from these aspects. The first one is to know the effects as well as the side effects of a given fixed appliance system. And this is very, very important. Remember, these are nothing but prescriptions. Dr. Sridhar Prem Kumar was mentioning in the morning, it's like prescription, the drugs that are given by a medical person, we are having using forces and moments. What is the main reason what we are doing is to also minimize, try and reduce the biological damage which is caused during our treatment. Also, to prevent round tripping. What is round tripping? It is going to a different destination and coming back to the necessary result. So you are actually saving time by reducing the amount of round tripping and also preventing the biologic damage, and overall trying to reduce the treatment duration, which otherwise people fancily call as accelerated orthodontics. You know, Dr. Nanda says that the best way to accelerate orthodontic treatment is to use efficient biomechanics. And if you are good at biomechanics and execution of that, definitely you'll work out to be an excellent orthodontist. So with that, just as when we board a flight, what is the first thing that is done? You are given a set of instructions before takeoff, the safety instructions. Likewise, for all the first years and second years here, let's rebrush our understanding of theoretical biomechanics. I'm going to put only about 3 or 4 concepts here and then go ahead with actually looking at the clinical outcome. So we start with the fundamental. Always in any lecture on biomechanics, it has to be on the starting with the center of resistance, which all of you know, which is an imaginary point, which we look at 3 dimension. But why do you need to know about it? It is because we need to understand the behavior of the tooth whenever you are looking at uh, the force application and how the tooth would behave if you subject a force through or away from the center of resistance. Now, most of you would be aware that for incisor or for a molar, the center of resistance would vary. And this is only from one plane of space, mind you. When you look at it from the 3 dimensions, you would be amazed to see that there can be a variation. And in fact, in 2013, AGODO, there was an article, one of the authors was Dr. Charles Burston himself, wherein he wrote that the center of resistance based on a finite element analysis cannot be actually pinpointed in all the 3 axes. It can vary a little bit, and it's not a fixed point, so to say. And imagine in a patient, let's say a growing patient or a patient with a periodontal damage, etc., there is going to be a lot of variation in where the point, the center of resistance is. So most of the concepts in biomechanics that I'm going to talk about are to be considered not sacrosanct, but to be considered as concepts or pointers which help you to deduce where a tooth might move, what can be the mistake that you might commit, and how to reduce it. So are you with me, all of you? Yes. So let's go ahead. So you look at the center of resistance, and mainly you use the center of resistance concept for what? For explaining what is a translatory movement or what is a bodily movement. So how do you define bodily movement? It is the movement which you see when all parts of the tooth, be it the root or be it the crown, move in the same direction as the line of force to the same tune and by the same magnitude. So tooth displaces from point X to a point Y, need not necessarily be in the sagittal dimension. It could be oblique, it could be vertical, it could be downward, that is an extrusion. All these are examples of bodily movement or translatory movement. Remember this, please, because most of the students always think retraction has to be bodily. What about intrusion? True intrusion is also a sort of a bodily movement. Likewise, extrusion has to be considered under the bodily movement. So this definition helps you to understand. And when do you get a bodily movement? Whenever you are able to pass the force, the line of force, through the center of resistance, and you would expect to get a pure bodily movement. As simple as that. But the things get complicated when you have more than one tooth that is being understood. So you look at just a molar as is shown in the picture there, you know that the center of resistance is somewhere in the furcation area. You connect two teeth, the central incisor and the molar. What happens to the center of resistance? It's going to shift. And how do you know where it is? These are mainly from the experimental data as well as the laser holography studies and the finite element analysis, that people have found that the center of resistance would be at X point close to a particular location. So what you see here is the center of resistance has actually shifted from the molar here further forward, but it is far away from the incisor. Now you might ask, what is the implication of this, isn't it? How does it really matter? Remember, the entire way that the teeth will move, now this is a two-tooth segment, isn't it? A two-tooth segment will move based on where is the line of force and what is its relation to the center of resistance. Are you getting me? So if you understand this, then you can predict the type of tooth movement that you're going to achieve. And therefore, when you look at the two-tooth segment, you know that the center of resistance is here. When you shift and make it a continuous arch, like connecting the central incisor to the molar, where do you see the center of resistance? It has shifted mesially further, but it is between the roots of the two premolars for this particular example. So ideally, when you talk of a clinical scenario, what would you want as a student? You would want that I want controlled movement for most of the malocclusions. I don't want to bring about uncontrolled tipping, etc. So ideally, I would like to pass the force through the center of resistance. Now, is this possible? Not really, though people have tried using devices or additional adjuncts like power arms, which extend, and these have to be rigid, mind you, but these will extend the point of application of the force, and provided that this lever, the power arm, is rigid enough, then we use what is called as the law of transmissibility of forces. Now, what is the law of transmissibility of force? That if you have a rigid extension and you apply force at that point, the force would be considered to be passing through that area of the tooth, wherever it might be. So what do you see here in this example of the center of resistance? The force passing close to the center of resistance, what kind of movement would you expect? You would expect more of a bodily movement. So this is ideal. But when you look at a clinical practice, what happens? You usually apply the force through the bracket, and this causes what? Some amount of rotation. And what is this rotation called as? First years? Moment, M-O-M-E-N-T, moment of a force, because we are applying a force which is causing a rotational tendency. Is this good? Many times it isn't. Sometimes it may be favorable, but most of the time it isn't. So what do you do to prevent this kind of a rotation, unwanted rotation? You have to add what is called as a counter moment. So you have a force causing a moment. You don't want this moment. You apply what? A counter moment. It's like the Lok Sabha, isn't it? You have a ruling party, you have an opposition party. So if the opposition party is strong enough, then things get controlled. Otherwise, anything can happen. So let's look at an animation which explains how to understand the moment and the force, and you have to remember again that it's in the 3 dimensions. Let's hope that the audio works. Otherwise, I'll have to explain it myself.
In this video, the effect of the moment generated by a force to the bracket will be illustrated. The force added to the bracket is generated in a moment equal to the force minus the perpendicular distance to the bracket.
what is important here to remember is it's not just the identification of what kind of moment it's going to cause, but the magnitude, which is calculated by what? The force times the perpendicular distance from the line of force to the center of resistance, one. Secondly, you need to look at it from 3 dimensions. So while you are retracting a canine, let's say you are doing just a canine retraction, what kind of force you are applying? To retract. But what will happen in the occlusal plane? There will be some amount of rotational tendency which is there. That also needs to be countered, which is something that you need to remember well. Now we move to the next concept, which is, we understood that there is a force and you need to apply a counter moment to avoid the moment that is being generated, right? So how do you apply this counter moment? What is the most common way? By using a force couple. And how do you apply these force couple? Let's see what exactly is a force couple. A couple, as it would term, literally mean that it's a set of two forces which are opposite in nature, equal and opposite. But is this a force couple, what is shown here? No, because it's going to get countered totally. So it's a set of forces, two forces equal and opposite, but which are non-collinear in action. And imagine, keep a pen on the table and try doing this yourself. What's going to happen when you apply force here, a force here? You're going to get pure rotation. And remember, orthodontics, the way it is practiced now, is mainly the controlled movement that we can get is simply because we are in a position to apply a force couple which always acts around which point? Anybody? Around the center of resistance. This is the only type of tooth movement in which, other than translation, in which when you apply a force at the bracket level, you are able to still produce an effect exactly around the center of resistance. And this is what helps us as orthodontists. So what do you do uh, in clinical terms? How do you apply the force couple? When you're doing canine retraction, I said the tooth will tip and you don't want the rotation to occur. So how do you prevent it? Simply by using a force couple which is in the second order, which tries to minimize this. Or you apply a rectangular wire in a edgewise bracket or a pre-adjusted system wherein the slot is angulated and you derive this necessary counter moment. So this is understood by everybody, isn't it? This till now, I think this is more or less clear. Things get complicated when we talk of the next concept, which is the moment to force ratio. So let me help you understand in very simple terms. We said that there is a force which causes a moment. To counter this, what are we applying? Counter moment. The ratio of this counter moment to the force determines what is called as the M/F ratio. As simple as that. So if you apply, if you remember the previous slide wherein I had shown a bracket and a wire contacting in the second order, that's in the sagittal dimension. If you have a strong arch wire which generates a heavy couple, what kind of a M/F ratio would be generated? It would be larger than having a very thin wire. Are you getting me? If you are using a night eye wire for bringing about a rotational couple or preventing a sliding movement, is it better than a steel wire? Yes or no? Wouldn't be, because a steel wire which is more stiffer can generate a necessary counter moment. So in turn, it will generate what is called as a higher M/F ratio. And these points have been given based on, or these numbers of the M/F ratio have been given mainly with what? Considering that the center of resistance is about 10 millimeter from the bracket slot. Do not consider these as the sacrosanct numbers, please. And we'll see how do you actually look at it with the help of an animation. So are these M/F ratios universal? No, it's mainly dependent on the distance of the bracket from the center of resistance, and which we know already, and it's also depending on the periodontal support or cases in which the roots have been shortened before even starting the treatment. So you need to remember these things while applying your M/F ratio concept. Now let me play another animation which helps you to understand the relationship of the M/F ratio along with what is called as the center of rotation. Now don't get confused. I talked of center of resistance, which helps us to understand what kind of movement? Translatory movement. But we know in the clinical scenario, we always get some amount of tipping or rotations. And the point around which the tooth would rotate or is expected to rotate is called as the center of rotation. So let's look at the understanding of this.
bracket, the moment to force ratio is 0, and the center of rotation will be positioned approximately 10 millimeters above the bracket close to the CR. When a moment is also applied so that the moment to force ratio is equal to 5, the center of rotation will be displaced actively and will be in the area of the apex about 18 millimeters above the bracket. If the moment and the force with a ratio of 10 is added to the bracket, the translation will occur and the center of rotation is at infinity. If the moment to force ratio with respect to the bracket is 13, the center of rotation will be close to the bracket and a root movement will take place.
So is this a little better understood now? That means the m by f ratio is related to the center of rotation. And can you alter the m by f ratio yourself? Yes. How do you alter it? Either by reducing the force that you are applying or by increasing the counter moment. How did people like Ricketts or the other people who introduced the prescriptions like McLaughlin Bennett increase the m by f ratio for bringing about bodily movement? Anybody? By adding in or increasing the torque in the bracket itself, isn't it? That is another way by which you can look at it. But for every advantage that you get, for example, adding torque in a prescription, there is going to be a disadvantage. And what is the main disadvantage here? If you keep adding torque, you're going to burn anchorage that much faster. So remember that. And then we work with different units that we are working. Now the last concept which has to be understood is what is called as the equilibrium. Now, m by f ratio and equilibrium need extra reading from all of you. So I would suggest that you start off with the AJO April 1984 to understand the basics of biomechanics and the seminars in orthodontics 1995, which talks about the fundamentals of biomechanics. In that, they have explained these concepts very well. And then you move on to what is called as common sense mechanics. I think most of the second and third years would be knowing about it. Dr. Thomas Mulligan, who introduced the concept of common sense mechanics. And then we come back to what we are explaining here. So let me read it out to you. Whenever we have an appliance which is fitted into the mouth, which means that you have the brackets, wires, everything in place, instantaneously, as per the rules of statics, that is the branch of physics, invariably you would get an instant acquisition of what you call as a static equilibrium, in which everything is in a state of balance. And whenever we work with different units, for example, you are applying a force by way of an E chain or by applying a coil spring, that is called as the active element. The active element will generate some forces and moments which will be automatically countered by what is present in the system itself. So since most of the time, if you're not talking about TAD based anchorage and we are looking at routine retraction mechanics, for example, whenever you are applying a force, what is the reciprocal that is happening? Use Newton's third law. For every action, there is equal opposite reaction. So there will be some amount of drag on the posterior segment. As simple as that. But on the day when you place the retraction force, do you see any movement? No. At that point, everything is in equilibrium. And that has been given beautifully by Mulligan, who talks that how the sum of all forces, vertical, horizontal, and the sum of all moments equal to 0. But as a clinician, what is important for all of you to know is the equilibrium forces that are generated within the system might be totally unexpected. I'll give you a simple example. You would have given, let's say, a bend. Let's imagine a 2x4 system. You have a molar, you have two incisors, and you are trying to connect them. And you give a bend which is closer to the, let's say, the lateral incisor. If you just position the wire there, what would you see? That the wire rises gingivally. You would pull it down, and you would expect that the incisors would uh, intrude, isn't it? But if you understand biomechanics, it's the exact opposite of what you're going to get, because by adding lingual root torque, you're going to get a equilibrium force which is going to be extrusive in the anteriors and intrusive in the posteriors. Are you all with me? So it is going to be that some of the equilibrium forces will be undesirable, for which you need to understand how to calculate equilibrium. So let me show you a very simple example. a situation wherein you want to pull a canine down and you are using a simple cantilever in which you have given a bend, a downward bend, so that you can tie it up around the bracket and you expect the tooth to move down. Now, what are the steps by which you can calculate the equilibrium? And this is something that I've pointed down. You can take a snapshot and keep this or try working on this in certain clinical examples. The first thing that you have to do is identify the line of force as well as the resultant moment that is generated. So what is the force and the moment that is generated here? It is mainly by the 2-point contact of this arch wire, the cantilever spring, against the two corners of the bracket. And what kind of a moment is it generating? In this case, it is a counterclockwise movement as depicted by the red curved arrow. In order to counter this, the equilibrium forces would be such that it would generate a moment which is felt on the incisors and the or on the canine and the molar, which would be in the direction that is extrusive here and intrusive here. Now, let's say that in this particular patient, you do not expect any amount of molar intrusion to occur. So, it's an undesirable force and you need to work out ways by which you can control this. So, this is as far as equilibrium is concerned. I'm sorry, I cannot go into further details because we have only limited time. So, let me just summarize everything that we understood till now. So, biomechanics in a nutshell, if you have to look at it, you are talking about a tooth or a group of teeth which are embedded in bone, and therefore you look at what is called as center of resistance for imagining the tooth movement. Since the force doesn't pass through the center of resistance, you also have what is called as a center of rotation, and you are in a position now to vary the amount of forces as well as the moments and derive what is called as the necessary M/F ratio. So, how does this actually work or help a clinician? Let me show you a simple example in which we are talking of canine discalization or canine retraction. So, when you are looking at applying a force, okay, so we are applying a force to disclize the canine, retract the canine. What kind of a moment is being produced here? Because the bracket is away from the center of resistance, there would be a clockwise type of a moment. Depending on the arch wire that is engaging the bracket here, you can produce a counter moment which should be either small or high depending on the stiffness of the wire, depending on how well the wire fits into the bracket. So, we call this as the wire bracket relationship. Remember this, very important. Biomechanically, if you are to understand, the wire bracket relationship determines what kind of counter moment you can bring about. So, in simple terms, if I want a large M/F ratio, what do I have to do? I need to increase the stiffness of the wire that I have here, or I need to increase the wire dimension such that it will completely engage and increase or improve my wire bracket relationship. So, that's how you are going to look at. And based on this, we talk about the M/F ratios and the equilibrium that comes in. Now, this is as good as theory is concerned. Now, you would have seen most of the instructors tell you hammer in so much of biomechanics all the while, but I would like to show a very light video which talks about it's not enough if you know just the theoretical part, you need to know the practical application also. So, let's see this. The student needs to understood theory well, but not the practical, right? So, you know what to do, but you don't know how to do it, right? Finally, the instructor has to help lift the child. And then complete the act. So, does that ring a bell? Most of you understand biomechanics, you know what to do, how to, or what applications of these concepts are. But when it comes to clinical practice, it becomes a little difficult. So, I'm going to make it simpler now from the clinical perspective. So, what are the implications? The first question, I'll raise two questions and try to answer them briefly, and then we go to some clinical caveats for all of you. So can the center of resistance be altered by the orthodontist? Yes or no? Yes, and you need to do it in selective situations because it will help you to improve the kind of movement that you want. You can do what is called as predictable type of biomechanics. So you can, by different forms of consolidation, bring about different positions of the center of resistance. But remember, it will still always be in the root portion. Unfortunately, you cannot play around and try to get the center of resistance to the crown level, right? That's never going to happen. So you can use different mechanics. So one of the simple mechanics that everybody knows of, which Dr. Charles Burston proposed and popularized is, what did he popularize? The segmented arch technique. The second one, which is quite interesting, and this has been described by Melson and Fiorelli, which is called as a two-vector system. I'm going to show a simple picture of that. And whenever you talk about using, let's say, headgear, fixed functional appliances, in which the entire arch is consolidated, the biomechanics is going to differ. Likewise with TADs also. So I'm not going to go into the details of that, but remember that you can alter the center of resistance just by incorporating more number of teeth into the arch, reinforce the anchorage here while you are trying to move only the canine, and simple way of using the T-loop only for canine retraction. Likewise, take this picture, I'll share if possible the reference also. Whenever you are trying midline correction in isolation, especially in asymmetric cases, whenever you apply a force, let's say using class 2 elastics or tip back mechanics, you invariably bring about some amount of vertical canting. In order to prevent that, Melson and Fiorelli have given a concept called as the two-vector mechanics, in which if you have to move the midline, let's say to the right, you use two cantilever springs, one extrusive cantilever and one intrusive cantilever. Okay, the extrusive cantilever would be on the side where you want the midline to shift, and the intrusive cantilever would be on the other side. How did they come to this? They use a software called as the DMA, or the dental movement analysis software, and based on that they have actually generated this kind of a example. But again, you are modifying your center of resistance and applying the force. Likewise with headgear, what happens when you talk of headgear? Though you are applying the force at, let's say, you want to dislice the molar and you are using an elastic to dislice, the force is still felt at both the molar as well as when you want an orthopedic kind of a movement, which is to restrict the growth of the maxilla. How does this work? Because you have to look at the separate centers of resistance. Center of resistance only for the upper molar, center of resistance for the entire maxillary dentation as well as the orthopedic area, that is the basal bone of the maxilla. So this is just to give you an idea that you can modify your center of resistance also. The second question that I ask is, are we good whenever we increase the interbracket distance? Now you would have read from Profit. Profit says in his description on fixed appliances and how to improve biomechanics, he says it's always better to have a long span and a short span of the wire. That is, increase the interbracket distance in a way that you can bring about predictable mechanics. Is this justified? Yes? No? Increasing the interbracket distance helps in many situations, and especially I would recommend in the initial stages of treatment. And for that, I will explain the concept of what is called as a one couple and a two couple system. So examples here are intrusion arches and the Burston three-piece intrusion arch. Now let's see the example, and I'll show you an animation also. So what we are doing here is, necessarily we are trying to have two segments. One is the anterior segment and the posterior segment. The center of resistance for the anterior segment will be dependent on how many teeth you have tied together. So if it is the 4 incisors, you know that the center of resistance would be a little higher in the root, but distal to the lateral incisor. And then you use a cantilever mechanism by which you can apply the force vertically, which is close to the center of resistance, and you also apply a horizontal force. And if you remember that there is a resultant law of resultant of forces, you can actually calculate the vertical, the horizontal, and get the diagonal, which is the resultant force. And thereby, you can bring about predictable type of tooth movement. So with that, let me introduce you what is called as a force-driven mechanics and the shape-driven mechanics, again, from a clinical point of view, which is very, very important. And it resounds or resonates well when we talk of one couple as well as the two couple type of systems. So what is the force driven system and what is shape driven system? All of you, when you work, how many of you actually think of bracketing only a few teeth and work only on a segment of the teeth while moving, while treating a malocclusion? Anybody? Few people at least. But most of us are so familiar or so much programmed to work with continuous mechanics. And what brings about the tooth movement in continuous arch mechanics? It is called as the shape driven mechanics, because you are using the preformed shape of the arch wire, you are engaging the wire into the brackets and hoping that the shape of the arch wire brings about the tooth into the particular positions, right? Are you with me? So this is called as shape driven mechanics. Is this good? Not always. But then you need to know what is the other way, which is the force driven system, in which you can actually calculate the amount of force and the moment that is generated for bringing about certain tooth movements. So what is the problem with shape driven mechanics? If you see, this is from a finite element analysis article, the expression of how forces and moments would be generated in a continuous arch. What do you see here? For a simple crowding type of a malocclusion, if you place a continuous wire, the force is depicted by the red arrow and the moment is depicted by the blue arrow. Can you see the variation, the amount of variation that the teeth are expected to go through before coming to the final position? Yes? So there's a lot of differentiation and you cannot actually calculate it. So that is why this is called as statically indeterminate. That means you cannot physically, just by looking at the shape of the wire and the engagement into the bracket, you cannot pinpoint how much of force or the direction of the movement each tooth in the arch is going to receive. And therefore it is called as statically indeterminate type of a force system. And this is not good. But it is useful in symmetric type of malocclusions. And fortunately for us as orthodontists, most of the time, at least in 50 to 60% of the cases, we work with symmetric malocclusions, and therefore it becomes rather easy. And what are the other types of system? It is statically determinate. And in statically determinate, the typical example that I can think of, and I'll play this animation, is that of a one couple system.
One of the most frequent applications of the statically determined force system is in one of the following intrusions, as in this case, by two cantilevers extending from the inferior tube of the molar and tied with a single force through the anterior loop at the level of the TR.
So what is shown here is, whenever you want to bring about selective movement of the teeth, use a long and a short segment, and for this, a one couple or a statically determinate system in which exactly you can calculate what is the force that is being delivered to the incisor, what is the equilibrium force against the molar and how many teeth to consolidate, or whether to use a TPA, etc., can be predicted beforehand, and then you work on it. So which are the situations in which you can use it? I'm going to talk about it. So in the last 5 minutes, what I'm going to do is give you simple 4 clinical tips to understand and take back home for the sake of clinical practice using biomechanical advantage. And the first one is what is called as planning for a consistent type of a force system. Whenever you see a malocclusion and you have to do treatment planning, what do? You take all the records, you study them extensively for what? For cephalometry, for the facial photographs, the intraoral photographs, etc., the tooth measurement analysis. How many of us actually do a biomechanical planning for a given malocclusion? Very few, isn't it? We always look at how much movement has to be brought about, but what is the reciprocal effect and how to predict it or reduce it? We don't actually do it. So consistent type of force system is when you want to bring about a tooth movement which is consistent with the end result. For example, in this situation, what do you see? Two sentinel incisors which are rotated equal and opposite. You are engaging a wire here. What do you get on either side? You get equal moments which will correct the malocclusion, no round tripping. Correct? Are you with me, all of you? Yes. Next, let's look at another example. Now, in this situation, what do you see? That you have The rest of the arch is good, only the molars are rotated. Now, if you are a shape-driven mechanic person and you try to work with a continuous arch and you engage a NiTi wire, let's say, into the molar and also the two premolars, what's going to happen? Definitely, you are going to get rotational moment for the molar, no doubt. But look at the equilibrium effect. What you're going to get is, because of a step bend that is created here, you're going to get an additional rotation of the premolar, which is not desirable. So you're going to get a distal in rotation of the molar, premolar, and you are going to get a palatal push for the premolar and an outward push for the molar. While it might be good for the molar, is it good for the premolar? No. So what you are doing is, if you use a shape-driven mechanics here, you are creating what is called by Burson as a secondary malocclusion. You are actually creating a worsening and then trying to push it back. What would be a better way in this case? Just derotate the molars. Use a simple TPA, first correct the molars alone and then work on it, or do not bracket the premolars or don't engage the wire into the premolars. Let it be like a long segment and a short segment and then move ahead. So the first clinical tip for all of you, try to look at the pre-treatment malocclusion and develop a consistent type of a force system, which means, as in this case, and this was treated by my good friend Dr. Jayesh, so you have two incisors which are equal and opposite rotated, and what do you expect, as was shown in the first animation or the picture there, is equal opposite moments. And then when you apply the continuous mechanics, and he has in fact used the MPA of Dr. Nikhil Vashi in order to minimize and get a good movement of the lateral incisor. You can see that the centrals have corrected there, and then the complete correction, and then you go for over correction. So the other situation wherein you should not bracket those teeth which are not coming into a consistent type of a force system. So can you see here? The two central incisors are similarly equal and opposite rotated, no doubt. But what about the lateral incisor? It is again rotated in the same direction. If I were to engage this or place a bracket here and engage this wire into a bracket placed on the lateral, what kind of a mechanics are we developing? We are developing what is called as a step bend geometry, just as what was shown in the inconsistent force system. And it would have a lateral effect on the lateral incisor, a push effect on the central incisor, which are inconsistent. So we don't bracket the lateral incisor. So the point, clinical tip is, do not think of bracketing all the teeth. And in fact, Ricketts had pointed out this. He said, do not bond every tooth just because you find enamel on it or white surface on the tooth. So again, going ahead with where do you use segmental mechanics? It would be best to understand what would be the side effects of continuous arch mechanics. Dr. Abhishek showed good cases of molar which were tipped, second molar which was tipped. Imagine using a continuous arch wire just for the sake of correction of that. Yes, there would be some amount of moment to correct it, but remember there is going to be a vertical effect because of equilibrium being generated, and that's not going to help. What about this scenario? Most of you come across highly placed canines. What are you tempted to do? Place wires into all the brackets, isn't it? Though McLaughlin Bennett have stated that don't do it, but you try to do it. And then what happens? You create a secondary malocclusion. So try not to do that. The second clinical tip is use cantilevers as far as possible. I'm going to complete in just 2 minutes. So use cantilevers wherever required. For example, a malocclusion in which you see a canines getting locked. Okay, what do? Should you use continuous arch mechanics here? No, you can use a simple cantilever spring, intrusion spring for both upper and lower canines. Intrude only those and correct the malocclusion in a very simple way, isn't it? So that's something that you can look at. Now let me give you another concept. Whenever you see severely proclined or retroclined teeth, are you in a position biomechanically or in a good position if you have to place a rectangular wire and try to retract? Yes or no? No, because you are going to get the roots which are very close to the palatal cortex in this particular patient, you are going to get more amount of root resorption or making the teeth prone to root resorption. So what do you do in this situation? You can use what is called as a Mulligan arch, a simple arch wire. I'll show you the mechanics also, in which you can use an Australian steel wire 016 with a helix close to the molar a light elastomeric module which ties it to the molar, and see the mechanics here. It's a one couple system if you tie it outside the brackets. So what happens is you are going to have a residual moment there, and you're going to get intrusive and extrusive moments against forces against the incisor and the molar. And this is something that you can do and keep enough expansion so that you prevent rolling in of the molars. This is what we did for this patient, severe proclination, and Dr. Nanda talks about it. Whenever you have severe proclination, start with uncontrolled tipping. A bit of uncontrolled tipping, control, then bodily movement. So that's what was done using the Mulligan arch here. And just into, let's say, about 9 months of treatment, you can see that there is a good improvement. See the lateral cephalogram from being severely proclined to the roots coming into the center of the cancellous bone. So that's something that you can do. And the last thing that I would suggest is Dr. Gauri Vichare in her oration showed cases in which the molars, premolars were buccally flared, isn't it? And she changed the bracket type in order to generate the buccal root torque. But you can also use what are called as boxed auxiliaries, and I'll show just a simple case. I'm not going to show all the auxiliaries here, but you can use simple box auxiliaries like this. It's been described in several places, including our book. You can go through the reference. Boxed auxiliaries for generating what is called as the palatal root torque or a buccal root torque for single teeth. And this works very well. This is a case from our practice in which the two laterals were instanding to begin with. We use the box auxiliaries, and you can see that the root prominence is good in just about 3 to 4 visits. You need to plan this beforehand. Which are the teeth that need separate torque, and try to use auxiliaries like this for bringing about reciprocal type of tooth movement or uniform type of root torquing mechanism. So different auxiliaries, and for those of you who are lazy to bend wires, there is a preformed spring also for single teeth, what are called as Warren springs. These are available in India as well. So you can procure them, but make sure you use an undersized rectangular wire and you engage it against the tooth either for lingual root torque or for labial root torque. So these were 4 clinical concepts with which I would like to end. And most of the time, people ask, can you give us some references for biomechanics? So the references for biomechanics start with Burston, end with Burston. Easy for postgraduates to remember, isn't it? Now, on a lighter vein, but definitely there are many more people like Dr. Nanda who has contributed so much, and you can go through them. And let's hope that with the understanding of all these biomechanics, you can use the clinical conditions or considerations, for example, where the biomechanics, the bypass mechanics can be used. You can take a snapshot of this particular slide just to help you in understanding where you can do it. And also all the new modalities that are coming up. Remember that biomechanics will stay whichever appliance or technique or modality comes in. And this has been stated by both Dr. Nanda and Dr. Burson in their interviews. So finally, I would leave you with another simple message that if you are good in biomechanics, you can achieve wonders, and hope you will be able to do this after listening to the lecture whenever you have a parking problem. So check this out. Good biomechanics or good mechanical understanding. Yeah. With that, on a lighter note, thank you very much, and I would like to express my gratitude to the organizers of this wonderful 27th IOSPG convention, the whole scientific team, Dr. Shailesh Shenava, as well as Dr. Robin Matthew, and everybody who toiled in very hard to make this event a grand success, and also for the IOS for putting up a wonderful event like this. And thanks to all of you for coming back post-lunch to listen to a topic as dry as biomechanics. Thank you very much.
Over to the chairpersons.
Thank you, Dr. Jaydev, for an excellent lecture. It was a refresher not only for students, but also for a lot of clinicians. Thank you. And you made biomechanics sound good. Thank you.
Thank you, sir. Like always, it was a very enlightening lecture, and it was a review of literature for us also sitting here. Thank you. It was a great lecture, sir.
I request the chairperson to felicitate Dr. Chetan Jaydev, sir. I request Dr. S.P. Singh, sir, to please felicitate the chairperson for the session. Thank you, sir. Our next speaker for today is Dr. S.P. Singh. Dr. S.P. Singh did his MDS in orthodontics from Postgraduate Institute of Medical Education and Research, Chandigarh, and Diploma at Indian Board of Orthodontics in 2006. Sir presently is working as Professor and Chairman, Unit of Orthodontics, Oral Health Science Center, PGIMR, Chandigarh, and former Principal, Dr. Harshvant Singh, Judge Institute of Dental Science and Hospital, Punjab University, Chandigarh. He was past president of Indian Society of Cleft Lip, Palate and Craniofacial Anomalies and also past vice president of Indian Orthodontic Society. He has a special interest in cleft care and orthognathic surgery. He has published more than 90 scientific papers in national and international journals and presented more than 120 papers at various conferences. Today, sir is going to talk us about managing functional mandibular retrusion in growing children. We welcome you here, sir. To chair this session, we have Dr. Slivaraju sir and Dr. Anand Tripathi sir. Dr. Slivaraju sir, Principal Professor and HOD Department of Orthodontics, St. Joseph Dental College and Hospital, Andhra Pradesh. Sir is DCI Inspector from last 10 years, Ethical Committee Member, AP State Dental Council, and the former Vice President, Coastal Andhra. We have Dr. Anand Tripathi sir. He is an EC member, Indian Orthodontic Society. He is conveyor of Pune Orthodontic Society, managing editor iOS Times 2023. He is honorary secretary of IDA Pune East. We welcome you, sir, on the stage. Thank you.
नहीं इसमें वो लगा रखा
etiology of skeletal problem. It is a hereditary, intrauterine molding, birth trauma to mandible, childhood fracture of jaw, and muscle dysfunction. So, what are the component of class 2 malocclusion in mixed dentition? There is anterior posterior, vertical, and transverse. Transverse is a constriction of the maxillary arch. Anterior posterior is a relationship of maxilla to the mandible, and vertical is a deep bite. So, the pitch, roll, and yaw comes into the picture. So, this is anterior, posterior, vertical, and transverse. So, class 2 skeletal relationship may result from maxillary protrusion, mandibular protrusion, and combination of both. So, to treat these patients, first we have to diagnose the case. Until unless we diagnose the case, we can't treat the patient. If our diagnosis is wrong, we go somewhere else. As Dr. Gauri Bicharya says, the diagnosis is a key factor of our to treat the malocclusion. So, what is type of class 2 malocclusion? Is a dental or skeletal, true or pseudo. So, how we can diagnose, what requirement is there? So, we require the study models, we require the photographs, and we require the radiographs. Now, diagnosis of class 2 malocclusion on the photographs, SEF and internal photographs. So, if you look at this, there is a excessive overjet, class 2 modulation, and deep bite, and dental compensation. If we look at the other cephalometric parameter, the increased A and B angle, increased widths, increased APP-BP, MF bisector increase, upper incisor proclination, and AB plane angle is negative in these cases. So, the correct diagnosis and treatment plan in these cases are most important. So, the aim of treatment is recognize class 2 and treat early, intercept the abnormal skeletal pattern to reduce the severity of the malocclusion. So, managing of class 2 malocclusion is in growing cases and non-growing cases. In growing cases, the patient comes early to us. We have to do the functional jaw orthopedic, that is myofunctional appliances, bite jumpers, then the fixed function appliances, headgear, and the face bow. In the non-growing patient, we have to do the fixed orthodontic treatment, upper 4s, lower 5, upper 4 only, or lower incisor, and in the later age, the patient comes after 18 years, we have to do the conventional orthodontic surgery, or sometimes we have to do the mandibular dissection. So, these are the various procedures what we are doing, what we can do in the growing patient. The removal expansion screw with the bite jumping appliance followed by comprehensive orthodontic treatment, twin block followed by comprehensive treatment, RME and fixed twin block followed by comprehensive treatment, non-extraction with the Frankel appliance, non-extraction class 2 mechanics with the jigs, non-extraction fixed function appliance MPA4, extraction of all fours with the comprehensive treatment with the forces fixed appliance, and the fixed functional therapy with the power scope appliance. So, this is the first case. I am showing the removal expansion screw with the bite jumping appliance. So, this is a 9-year female girl comes to department with the problem. If you look at the teeth are procline, mandibular retrusion. So, what we plan this case, we give the removal expansion screw, and after that we give the bite jumping appliance and with teeth with the fixed function appliance. This is a patient external internal photograph showing the problem. This is a patient's OPG pre to the post, and this is SEF from pre to post. And this is a superimposition showing the changes, the growth of the mandible from pre to the post, and this is a superimposition on SN plane at S showing the changes from pre to post. There is an increase in the mandibular length, and then overall growth has been taken place. This is the patient pre-treatment to post-treatment external photograph. This is a comparison from pre to the post. This is an internal photograph from pre to the post. This is again stage photograph and after the completion of treatment. This is a comparison from pre to the post. This is occlusal view showing the changes. First we give the expansion screw and then we give the wide jumping appliance and treat with the fixed function appliance, fixed appliance therapy. So this is a close-up pre to post, and this is a retainer after the completion of treatment. We give the hollow retainer in the upper arm and canine to canine bonded retainer. So the next case with the Frankel appliance. So this is a patient, Gaurav Gupta, 13-year female male patient, treatment with myofunctional appliance, the FR2 and comprehensive orthodontic treatment. This is a patient external internal photograph showing that the problem, if you look at the lower mandibular arch, this is a V-shaped mandibular arch, even the maxillary arch is also V-shaped. This is the self OPG showing the this is self showing the deep bite, proclination of teeth, overjet increase. This is the patient's OPG from pre to post. This is the patient post-treatment OPG, and this is the patient self pre to post. And this is a superimposition of mandible at corpus axis and showing the growth in the mandible with the appliance. This is the total superimposition on SN plane. This is a patient external photograph and pre to the post. This is a comparison from pre to post. The changes take place in the patient. This is a profile view of the patient. This is the internal photograph showing that with the appliance, Frank appliance. Then we bonded the teeth and complete the case with the fixed appliance therapy. So if you look at this, the pre-treatment, there is a V-shaped maxillary mandibular arch, and after the completion, there is arches are normal. So this is a comparison from pre to post, and this is the patient, the post-treatment photograph, and this is a retainer, upper arch haulage appliance, and lower canine to canine bonded. So we have published a case report in the journal, and it showed that the case showed that as a result of FR2 therapy, there was significant improvement in patient profile with overjet reduction, and the modulation was corrected to super class 1 from the original class 2 due to increase in the effective mandibular length and the mandibular advancement. The another study, we have done the thesis in the department in 2019, the comparison of skeletal and dental alveolar change in children with skeletal class 2 malocclusion treated with function regulator and twin block myofunction appliance at cervical vertebral maturation index 3 and 4. A supplementary study. So the conclusion of this study was, though there was an improvement in the sagittal relationship in both the group, but the magnitude of anterior positioning and increase in mandible length was significantly greater with the twin block appliance. So next is a bionator. So this is a patient, 10-year male patient, and patient had the treatment plan was 2x pre-functional alternate 2x2 appliance to procline the upper incisors, and then we give the bionator. So this is a patient intraoral, extraoral, and occlusal view. If you look at, there is a 2 lower incisors are missing this patient, and this OPG confirmed that the 2 lower incisors are missing, central incisors are missing, 3141, and this is the patient self. So this is the patient pre to post OPG showing the changes, and this is the patient cephalogram showing the changes. If you look at the superimposition at corpus axis, there is an increase in the mandibular length in this case, and overall there is also increase in the mandibular length and improvement in the patient profile. This is the patient intraoral extraoral photograph from pre to post showing the changes from pre to post, and this is the comparison from pre to post. This is the bionator in position in the patient mouth. This is the intraoral photograph from pre to post. This is a comparison pre to post and occlusal view showing the changes from pre to post. This is the closer view of pre to post changes in this patient. And again, we have given the, the Hollis retainer and canine to canine bonded retainer in this case. So there is a study conducted by Dr. Jana et al. And the skeletal and dental bearer effect of tin block and bioneutral appliance in the treatment of class 2 malocclusion, a comparative study. So the conclusion of this study was both the twin block and bioneutral appliance were effective in correcting the motor relationship and reducing overjet in class 2 division 1 malocclusion in subject. However, the twin block was more efficient than the bionutrient treatment of class 2 division 1 malocclusion. So according to this study, both are efficient, both are effective, but twin block is more effective than the, the bionator. So next is the activator and comprehensive treatment. So this patient, Ankit Dhawan, 13-year male patient, so with the activator followed by orthodontic treatment. So this is a patient external, internal, and occlusal view showing the problem with the patient increased overjet, deep ovite, constricted maxillary arch. This is a patient OPG from pre to post, the SEF pre to post, and this is a superimposition showing the changes from pre to post on the mandible. So this is a SN plane as a S showing the changes from pre to post. There is an increase in the mandibular length and overall change in the patient profile. And this is a patient pre-treatment from pre to post. You can see that there is an improvement in the patient profile. So this is an internal photograph from pre to the post. This is a occlusal view from pre to post. This is a comparison from pre to post of the patient showing the changes in this case. The increased overjet is reduced, deep bite is also reduced, we achieve a class 1 motor ratio in this case. This is the occlusal view showing the changes from pre to post. And this is again retainer after the completion of a treatment. We bonded canine to canine and upper Hollis appliance. Next is activator with headgear. So in this patient, initially plan a myofunctional appliance, therapy with activator headgear, and then we have to accept the first premolar because 3 was impacted in this case. So this is a patient external photograph, internal photograph, and occlusal view showing the problem with the increased overjet and constricted maxillary arch, and 3 was missing. So this is the activator which we planned and given to the patient. Then we did the surgery and we bound the canine and we pulled the canine into the arch. This is a patient pre to the post OPG. This is a comparison from pre to post, SEF from pre to post. This is the pre to the post showing the change in this patient. This is a superimposition of the patient showing the improvement in the patient facial profile. This is the external photograph from pre to the post showing the changes. So there is an improvement in the patient profile after the completion of treatment. This is the patient profile. Though we extracted the premolar in this case, their growth and the nose become more prominent in this case. But if you look at the cephalometric changes, they are within a range. So this is the patient internal photographs showing the changes from pre to the post. The comparison pre to post, occlusal views. This again, the occlusal view comparison pre to post. This is the patient with the retainer, upper Hollis and lower premolar to premolar bonded, second premolar bonded case. Next is the RME and fixed twin block followed by a comprehensive treatment. So this is a 12-year male patient, had the bilateral class 2, skeletal to normal divergent. The clinically missing 2-3 root canal treated was done in 2-1. So this is a patient external photograph, and this is a patient OPG, SEF and IOP axis showing that 2-1 was root canal treated, and 1-3 and 2-3 was not ruptured in the oral cavity. So this is a comparison from pre to the post, SEF from pre to the post, There's superimposition showing the changes from pre to post. This is the external photograph from pre to post showing the changes. This again pre to post and after 1 year of retention. This is the pre-treatment, profile view pre-treatment stage and after completion of treatment. This is a frontal view pre-stage and post-treatment. This is the internal photograph from pre to the post-treatment. This is the, if you look at this, we have given the twin block, fixed twin block with the RME in this case. And this is the patient occlusal view showing the RME and fixed twin block in this case. The very close-up view, RME and twin block. Then again we give the hollow retainer and canine to canine bonded retainer in this case. This is a post-treatment. Then after 3-month retention, 1 year retention and 1.5 year retention of the patient, showing the results are very stable in this case. So next, this is the occlusal view from pre 1 year retention and 1.5 year of retention. This is the patient when the give the retainer and that's clear, and after 1.5 years you look at the retainer is becoming yellowish. So the next is twin block with the comprehensive ortho treatment. So this is a Kamya, 13-year female patient, phase 1 with the removal function appliance with a twin block, and then with a phase 2 with the fixed appliance therapy. So this is a patient, extraoral, intraoral and occlusal view showing the problem, a maxillary artery V shape. This is a OPG from pre to the post. This is a final OPG. This is a SEF from pre to the post and post retention. This is a changes from at the basionasion. This is a corpus axis at PM point. This is the SN plane at S showing the changes. This is a external photograph from pre to the post. Closer view from pre to the post, there is improvement in the patient facial profile. Then the frontal view with a smiling face, there is improvement in the patient smiling. Profile view showing the changes. And this is the pre-treatment, then the VTO and after the completion. So if you look at their results are matching in this case with the VTO and the post-treatment. This is the internal photograph, patient from pre to post, occlusal view pre to post, and this is a comparison from pre to post. The occlusal view from pre to post, if you look at the maxillary arch is V shape, and then after completion of treatment, the arch becomes the oval shape in this case. Again, we give the hollow retainer with the anterior wide plane and anterior divergent, so maintain the corrected by class 2 occlusion. Then we in the lower arch we give the bonded retainer. Another case with the twin block. In this case we give the pre-function appliance, pre-function therapy, and then we give the twin block. If you look at it's a class 2 DIB2 case. 2 incisors are retroclined and 2 lateral incisors are proclined. So this is a SEF, OPG and IOP X-rays. This is the patient OPG from pre to post. This is a post-treatment OPG. This is the pre to post SEF, and this is a superimposition showing the changes. There is a growth in the mandible, and this is the overall superimposition showing the growth of the mandible. So this is the comparison of pre to the post, the pre-functional with the functional stage and post-functional and post-treatment of the patient. This is the closer view pre to the post. There is an improvement. If you look at the profile, there is an improvement in the patient profile. This is a patient frontal photograph. There is an improvement in the smile. So this is the patient pre-treatment, clinical VTO and the post-treatment. So both are there is improvement in the patient profile. So this is the pre-treatment and post-treatment. So look at, there is a balanced facial profile in this patient, and this is the patient pre-treatment to the post-treatment picture showing the changes after the completion of treatment. So here we use the utility archway to proclaim the incisor, and then after that we can give the twin block and finish with the fixed appliance therapy. This is the patient occlusal view showing the changes. This is a pre-treatment and post-treatment of the patient, and this is the closer view of pre and post. Again, this is a final picture, and this is again retainer, canine to canine bonded retainer and Beggs retainer in the upper arch with the anterior bite plane. So in that department, we published a study at the effect of twin block appliance treatment on pulmonary function in class 2 malafluent subject with retrographic mandible. So the conclusion of this study was the correlation of mandible occlusion by twin block appliance had a temporary beneficial effect of various lung functions. So we did the lung function test before the treatment, and then after completion of the treatment, the lung function test remains almost same. There is no improvement on the lung function. So the another study we published a study in the progress in orthodontic effect of twin block appliance on the anatomy of pharyngeal airway passage in class 2 malafluent subjects. So conclusion of this study was fraction of mandibular occlusion by twin block appliance in class 2 malocclusion subject increased with the PAP posterior pharyngeal airway passage dimension and maintain the pre-treatment thickness of posterior pharyngeal wall. So next is the power scope. So this patient comes to department, the TAR called 15-year male female patient. We did the non-extraction and power scope. This is a patient intraoral external photograph, huge overjet, the constricted maxillary mandibular arch. This is a OPG from pre to the post, and this is a post OPG. This is a comparison of pre to the post treatment as SEF. This is a comparison of pre to the post. There is improvement in the mandible comes forward, improvement in the incisor inclination, and improvement in the patient facial profile. This is a superposition at corpus at point PM. This is a overall superposition at S, showing the changes in this patient. And this is a patient external photograph from pre to the post. There is a improvement in the patient profile. This is the closer view, frontal photograph, profile view showing the improvement in the patient face. This is smiling after the completion of the treatment. This is the patient pre-treatment, then the VTO, and then the post-treatment. So if you look at the pre-treatment, VTO and post-treatment, the VTO and post-treatment, they are comparable with each other. So this is a closer view of pre and post. This is the internal photograph showing the changes from pre to post. This is with the power scope. This is the comparison pre to the post. There is an increase overjet which reduce, and there is improvement in the patient inclination also. So occlusal view from pre to the post, comparison pre to post, and again we give the Hawley's retainer in the upper arch and canine to canine bonded retainer. In every case, we give the removable retainer in the upper arch and bonded canine to canine, sometime premolar to premolar, premolar to premolar retainer, fixed retainer. So another case with the power scope, again increased overjet, V-shaped arches. This is a patient OPG and SEF showing the problem. If you look at the SEF, there is huge overjet. Supra-eruption of the central incisor and canines. This is the patient OPG and after the completion of the treatment, look at this. There is the curves were balanced. And this is a OPG from pre to the post showing the changes. And this is superimposition showing the changes. And this is overall superimposition showing the changes. This is a comparison from pre to post. If you look at, there is an improvement in the patient profile. Closer view from pre to the post showing the changes in the patient facial profile. Intol photograph showing the changes from pre to the post. The closer view pre to the post. Occlusal view from pre to post. This is a comparison pre to the post, closer view, and again we give the hollow retainer and canine to canine bonded retainer. Then the another patient with the power scope, the 6-3 was extracted and 2-3 impacted. We de-impact the canine. This is a patient external internal photograph. The OPG showing the problem in this patient. Ceph pre to the post, comparison pre to the post, superimposition, corpus axis at PM point. The overall, there is improvement in the patient profile. There is a patient axial photograph showing the changes from pre to post. If you look at the third photograph, there is improvement in the patient profile. This is a closer view from pre to post. This is the internal photograph from pre to post with a power scope on. After treatment, comparison pre to the post. Occlusal view from pre to the post. This is the pre to post comparison. Bonded retainer in the lower arch. Again, we have given the canine hollow retainer in the upper arch and canine to canine bonded in the lower arch. So we did a thesis in the department, the comparative evaluation power scope and twin block function appliance for the correction of class 2 malocclusion 12 to 16-year of children. So the conclusion of this study was both the appliances were effective in producing similar anterior-posterior correction. There was greater skeletal mandibular growth with the twin block and maxillary retaining effect for more with the and maxillary retaining effect more with the power scope. So the vertical control was greater with the power scope appliance than the twin block appliance. Both the appliances resulted in significant maxillary incisor reticulation and the lower incisor proclamation. If we look at the side effect of both the appliances, in the all of functional appliance there is a proclamation of the lower incisors. So next is the advancing non-extracting patient case. The diabetic, we have the 9-year male patient. We give the Frankel appliance. The patient was non-compliance, and then we did the pre-functional orthodontics, and then we give the advancing in this patient. This is a patient pre-treatment photograph. Then this is Ceph OPG. Then this is the patient pre to post OPG. This comparison from pre to the post. Ceph from pre to the post. This is the closer view of pre to the post. This is the patient pre to the post treatment. The axial photograph. This closer view pre to the post. The frontal view with the smiling. Patient had a good smile. This is the pre-treatment profile with VTO, and this is the post pre-functional profile and VTO. So when we look at this, there is a post-treatment after the VTO. The results are matching. But if you look at the nose, there is a growth at the nose, so there is an increase in the nasolabial angle in this patient. So this is a patient internal photograph with that one on. This is the pre to post. And this is the patient or occlusal view showing the changes. And again, this is the patient post-treatment photographs. And again, we give the retainer bags retainer and canine to canine bonded retainer. This is a superimposition showing the changes. This is superimposition. This is a CBCT before advancing and after advancing. This is a superimposition showing there is a change in the mandible growth. Again, in this one showing the changes. Again, we did the thesis in the department, comparison of pharyngeal airway changes on cone beam computed tomography after twin block and advancing functional appliance therapy, a randomized clinical trial So the result of this thesis was that no significant difference in nasopharyngeal oropharynx, hypopharynx, and total pharyngeal airway dimension were observed between the two functional appliances. So there is a comparatively advancing appliance had greater effect on nasopharynx, oropharynx, hypopharynx, and total pharyngeal airway dimension and minimal axial area. Hence, advancing fixed appliance can be considered as a additional viable tool in the armamentarium for the functional correction of protrusive maxilla. So the another patient, Inderpreet, 13-year male patient. So in this we planned the extraction of 1, 4, 2, 4, 3, 4 and 4, 4. And when the patient not compliance to the class 2 elastic, we give the forces applying this patient. This is a patient external photograph in occlusal view showing the problem. OPG from pre to post. This is the post treatment OPG. This F from pre to the post. This is the post F. This is a superimposition on mandible at corpus axis at the PM point and showing the changes. And again, this is a superimposition at sella showing the improvement in the patient profile. This is a patient pre to the post, there is improvement in the patient profile. The frontal view with the smiling, there is improvement in the patient profile. And again, pre to the post, and the force is on in this patient. The comparison from pre to the post, occlusal view pre to post, and again we give the Baggs retainer and premolar to premolar bonded retainer in this case. Then there is a study conducted by Sankalp Sood and published in JCPD, and the study was muscle response during treatment of class 2 division 1 myelopathy with forces fatigue resistance device. So the conclusion of this study was the forces fatigue resistant device should be given for at least 6 months to allow for adequate neuromuscular adaptation to occur for long-term stability of the result. So the next is combination removal and fixed function appliance. This is a patient. In this we give the first twin block, but patient not cooperative to wear the twin block. Then we shifted to the fixed appliance, fixed function appliance. So this is a patient external photograph showing the problem. This is the OPG pre to post, post treatment OPG, comparison of pre to post. This is a comparison pre to post, and this is superimposed showing the changes. There is no growth of the mandible in this case, but there is a forward movement of the mandible. So this is the patient external photograph pre to post, comparison closer view pre to post, occlusal view from pre to post. This again pre to post photograph showing the improvement in the occlusion. Occlusal view showing the changes from pre to post. Then again pre to post. Again in this patient we give the Baggs retainers and canine to canine bonded retainer. Then the next is the non-extraction fixed function applies with the MPF4. So this is a patient external photograph in occlusal internal photographs, comparison of pre to the post. This is a patient pre to post. There is improvement in the patient profile. This is an internal photograph from pre to the post. This is the MARA MPF4 applies on in the patient mouth. And this is the patient post-treatment photograph after the completion of optimal treatment. So this is the occlusal view, internal photograph with the Baggs retainer and bonded canine to canine retainer. There's OPG pre to post, the SEF pre to post, the superimposition. There is no growth achieved in this patient because patient is adult, but we have repositioned the mandible forward in this case. So this is the SN plane at S. So that's then there is a study conducted by Dr. Jana et al. Treatment effect of twin block and mandibular protection appliance of MP4 in the correction of class 2 malocclusion. The conclusion of this study was twin block and MP4 were effective in correcting the molar relationship and reducing the overjet in class 2 division 1 malocclusion subject. However, twin block contribute more skeletal effect than the MP4 for the correction of class 2 malocclusion. Then another study published in the angle orthodontic effectiveness of twin block and mandibular protection appliance in the improvement of pharyngeal airway passage dimension in class 2 malocclusion subject with retrographic mandible. So conclusion of this study was the tin block appliance was more efficient than the MPA4 in the improvement of PAP dimension among class 2 malocclusion subject with retrographic mandible. So to conclude my topic, prevalence of class 2 malocclusion is very high. Patient with class 2 malocclusion might have a normal skeletal pattern, maxillary protrusion, or mandibular protrusion, often superimposed on a vertical dental and or skeletal discrepancy. As a result, treatment should be planned to correct that discrepancy diagnosed in each individual patient. In general, correction of skeletal discrepancy can be accomplished during period of active growth. The incremental growth pattern in class 2 individual do not differ in magnitude for the normal growth pattern. Normal faces with normal dental occlusion appear to have a combination of skeletal units that are well related to each other. On the other hand, skeletal discrepancy may be result of having similar skeletal units that are less favorably related to each other. The possible etiology, severity, growth potential, individual variability, biomechanics used, patient cooperation, and the retention plan are some of the variables that could be influence the treatment result in patient with class 2 malocclusion. Orthodontist should be attempt to recognize, diagnose, and treat these cases during the growth period to obtain optimal result. So the take-home message was wide range of function appliances, removable and fixed, are available in the market to correct the skeletal class 2 malocclusion, exhibit its various phenotypes during active growth spurt. The children cooperation as well as the compliance are clinical determinant for the choice of appliance and a satisfactory treatment results. Maxillary expansion is an integral part of the management, and minimal skeletal effects major dental alveolar and mild soft tissue effect were seen in with the functional appliance therapy. Thank you very much for patience hearing, and I thanks to the organizing committee for giving me the opportunity to present my topic, and I thanks to my colleagues, Dr. Sanjeev, Dr. Vinay, Dr. Rajkumar, my senior resident, Dr. Chaman, Dr. Naveen, and past senior residents who helped me to present this presentation in front of you. Thank you very much once again for the patience hearing.
Thank you so much, sir. You are always been encouraging since it's a postgraduate students affair. Nice to see and showcase all the array of the different type of appliances used for functional appliances used for the day-to-day PG students' life. Hope they will get a maximum benefit out of it. Thank you so much, sir.
So it's like a review for the functional appliances in skeletal class 2 malocclusion. You are covered in a short duration time all the appliances that are used. Thank you so much, sir.
I request the chairperson to felicitate Dr. S.P. Singh, sir. I request Dr. Sherry Peter, sir, to felicitate the chairperson for the session. Our next speaker for today is Dr. Sherry Peterson. Dr. Sherry Peter graduated from Kerala University with an MBBS followed by BDS from University of Annamalai, Tamil Nadu and MDS in orthodontics in the University of Mangalore. He underwent training in maxillofacial surgery, Royal London Hospital, Whitechapel. He then acquired the FDS RCS Fellowship in Dental Surgery from the Royal College of Surgeons of Edinburgh and the FRCS in General Surgery from the Royal College of Surgeons and Physicians of Glasgow. He worked in Amrita University of Medical Sciences, Kochi, as a senior specialist and later as a clinical professor in the Department of Craniofacial Surgery from 2001 to 2014. He now holds the position of lead consultant in maxillofacial surgery in Aster Medcity, Ernakulam, Kerala. Today, sir is here to speak about pre and post surgical orthodontics in skeletal open bite. We welcome you, sir. To chair this session, we have Dr. Balwinder Singh and Dr. Sukhdeep Singh Karan. Dr. Balwinder Singh, Professor, ex-professor, immediate past President, Indian Orthodontic Society, ex-vice President, Indian Orthodontic Society, founder, convener, Rajasthan Orthodontic Study Group, and the ex-secretary, Indian Dental Association, Jaipur. Dr. Sukhdeep Kalam presently works as professor and head SGRD Institute of Dental Science and Research, Amritsar. Sir has total teaching experience till date of 25 years and as specialist orthodontist in 21 years. We welcome you, sir. The stage is yours. Sorry for the inconvenience caused. We are just moving ahead with the next lecture. We'll have Dr. Sherry Peters' lectures after that. So we are going ahead with Dr. Rajaganesh Gautam sir's lecture.
So, better, better. Chairperson would not have any work to do otherwise. Let Rajganesh come. Yes. Okay, okay, fine. I see. Sir, आगे लिखना आपको सर फिर नेक्स्ट रिव्यू हो रहा है बैंगलोर के कुछ मार्केटिंग करनी हाँ हाँ सर प्लीज 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 श्योर 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 मैं बोल दूँ एक बार आपको Dear friends, as we all know, there is a technical glitch and we are just trying to sort it out. And the much awaited lecture of Dr. Sherry Peter always has so much of data in it that majority of the times we see that the big presentations come with a big bang. So I think we'll wait for the next presentation to come. In the meantime, we have this national conference coming up in Bangalore in this September. So we have the organizing chairman, Dr. Silju Matthew here. So he'll just try to brief up by the time we'll start with the presentation of Dr. Rajganesh Gautam. So over to Dr. Silju Matthew, sir.
Thank you, Mr. Chairperson. Warm greetings to you all from the organizing committee of the 58th Indian Orthodontic Conference, which will be held in the month of September from 21st and 22nd of September this year. We look forward to hosting you all. It will be held in a different venue altogether. You all have been experiencing the conference in institutions last few years. This time we have moved it to a 5-star hotel. The facilities that is going to be provided will be top-notch, and it's going to be a residential kind of a conference. It'll be held in a resort which is next to the airport called the Clark Exotica Resort. It's a beautiful venue. We have got all the facilities there. We have a huge convention hall with a capacity of about 3,000 people who can be seated, and a lot of other facilities that any 5-star property would provide. And we're also having a completely different kind of a trade setup this time, and we're also planning a fantastic scientific program. We have a lot of international speakers who have promised to come. Some of the top-notch people whom you would have to go to the American conferences to listen, they have agreed to come, and we look forward to a wonderful enrichment of orthodontic speakers from all across the globe. We have from Europe, we have people who will be coming from Europe, from US, and the best of Asia. So we look forward to your participation. We also have a stall right here. If you want to register, there's an offer going on. After this PG convention, the registration charges will increase. So it's a beautiful opportunity for you all to register for the conference. The stall is right in the entrance of this college itself. You can go and register, and we look forward to having you all for an experience of a lifetime. That's the guarantee that the organizers are going to give you. It's going to be a wonderful experience. We look forward to having you all. As organizers, we look forward to hosting you all. Thank you, and look forward to seeing you all in Bangalore in September this year. Thank you.
Thank you so much. A big round of applause to Team Bangalore, please, because they have given us such nice prizes, especially for this convention. And that makes me feel why this delays happened. I'm sure that is something related to Bangalore people who are doing this conference. Dr. Silju, otherwise never ever this kind of technical slack has gone for this long. I'm sure that's the Team Bangalore who has done something wrong so that you could come on the dais and market your conference. just jokes. Please have a seat, sir. So we are here the lead speaker, Dr. Rajganesh Gautam. He is the professor and head of the department, D.Y. Patil Dental College, Pimpri, Pune, and is the chairman of Indian Board of Orthodontics. He is a diplomat of National Board and diplomat of Indian Board of Orthodontics. He has completed his international mini residency program in advanced orthodontics at Yonsei University, Seoul, and Kyungpook National University, Daegu, South Korea, and at the Taipei Medical University, Taiwan. He has conducted national workshops related to the use of TADS in orthodontics, and he'll be speaking about finishing and detailing in contemporary orthodontics.
Welcome, Dr. Raj Ganesh. It is such a pleasure to be a chairperson to you too. Thank you so much for being here. Over to you.
Thank you so much, dear Chairman and Co-Chairman, sir, for that kind words of introduction. It's indeed an honor and a privilege to be presenting in a session chaired by the immediate past president. At the outset, I would like to sincerely express my gratitude to the Indian Orthodontic Society and the organizing team of the 27th iOS National Postgraduate Student Convention held in this beautiful campus of Terna. I'd like to extend my special thanks to Dr. Sailesh Sinava, Dr. Prakash Mudaliar, Dr. Robin Matthew, Dr. Prachi Gaonkar, and their entire team who have tirelessly worked to put up this wonderful show. So, good evening, dear students, faculty, and senior members. The topic of my presentation today is finishing and detailing in contemporary orthodontics. In the next 40 minutes, I'm going to be talking on a sort of a quick overview of this very, very important topic, because I'm sure there are first, second, and third year postgraduate students. They are eagerly looking forward to their exams, if I can put it that way. And this is a very important phase of orthodontics that they need to start concentrating from, say, a good 3 to 6 months before they reach their exam timing. So warm greetings from the Department of Orthodontics, Dr. D.Y. Patil Dental College and Hospital, Pune. So stages of comprehensive orthodontic treatment, as we know, evolved from the Beck technique, where we had stage 1, stage 2, stage 3. But even in contemporary orthodontics, we have initially, most of the time, aligning and leveling, correction of molar relationship and space closure, and finishing and detailing. When I mean comprehensive orthodontic treatment, I mean full-fledged orthodontic treatment where you have actually set all the teeth into proper position and occlusion right till the second permanent molars. So it generally happens during late adolescence, and the most common form of appliance, at least as we know it today, is the contemporary fixed appliance. I'm not discounting aligners, which is also a mainstream of treatment these days, but the rules still remain the same. We are orthodontics, practicing orthodontics. It doesn't change just because you use a different appliance. Now, proper finishing is of critical importance in achieving an excellent occlusal and aesthetic result after appliance removal, and it directly affects the stability of the achieved results. You know, I was discussing with President Sir Dr. Jayesh Rahalkar with our students in the department, and he made a very beautiful statement. As you grow in years in practice, and I think many of the senior clinicians would, it's not so important to look at just the finished result. We are happy when the patient comes back 5 years, 10 years back, to try and see how stable the result has been. And one of the critical factors determining this is how well you finish your orthodontic case. Now, finishing and pre-adjusted edgewise appliance, theoretically, ideally, if you look at it, your straight wire appliance or pre-adjusted appliance should produce the greatest benefit in this phase of finishing and detailing. Why? Theoretically, if you have built in all the 3 orders into an appliance, and if you have placed the brackets correctly on the teeth, then ideally you should have very good finished results, isn't it? But you all know that this is not the case in every patient. Why? The actual amount of finishing and detailing required may be increased due to variations in the shape and size of the patient's teeth relative to the average measurements built into the pre-adjusted appliance. Inaccuracies or shortcomings in appliance design which does not end up delivering the right sort of biomechanical systems that you desire to get the result. Use of overpowering force levels. This is a very, very common factor. You are in the last few months before exams, you call the patient every 2 weeks and keep changing e-chains. You do not give breathing space for the appliance to express itself, if I can put it that way. Inaccuracies in appliance placement is still a leading cause of not achieving finished results, and failure to allow sufficient time for the bracket system to express itself. A key factor in contemporary orthodontics. You have to give enough time for the appliance to work. Let the system cook, allow it, just watch it, and you'll see that results come out much, much better. So with this, a brief definition of finishing. It is the last step before active treatment, is discontinued of ensuring that the teeth and the related structures are positioned in such a way as will lead to a better stability of results, enhancement of aesthetics, optimized functions of the stomatognathic system, and an improvement of the health of the periodontium. Whereas detailing is more specifically about individual tooth positions that you want to improve. Now, finishing is one of the most deceiving and difficult phases of orthodontic treatment. Why? The patient does not really appreciate the clinical progress during this phase. Doctor, aap kya kar rahe hain? Nikal do na braces. It's been long and long. Adverse side effects may occur while achieving small corrections. You ended up bonding that second molar and suddenly your anterior bite opened. Occasionally, the treatment time of this stage, if not paid attention to, exceeds the whole treatment that you have done previously for so many months. The majority of patients are eager to finish their treatment after alignment and space closure. Baki, they are not really bothered. But you know indirectly that if that is not achieved, they're going to come back to you with relapse. So what this means for your exam cases, since I'm in a postgraduate forum, to reach this stage a good 3 to 6 months before your target date. Orthodontics, 6 months is actually about 6 appointments, nothing much, right? So you have to reach a good 3 to 6 months before the target date to work towards definitive objective goals right from the first appointment with the patient. You keep the end in mind, begin with the end in mind, the need for a checklist, and to specifically identify and work on common problem areas related to finishing in these cases, which is what is going to be the crux of my lecture. So begin with the end in mind. Orthodontic finishing begins with diagnosis and treatment planning. So finishing is not really a final stage of treatment. It is not that suddenly you come to a stage and you start thinking about finishing and detailing. It is a gradual progress towards the finish stage, which starts right from your diagnosis and treatment planning. It is in tune with commonly accepted orthodontic treatment goals, which we are all aware, which is normal static occlusal relationships, class 1 occlusion with 6 keys, 2 to 3 millimeters of overjet and overbite, normal functional movements, a mutually protected occlusal scheme, condyles in their seated position and centric relation, both anteroposteriorly and mediolaterally, relaxed healthy musculature, and normal periodontal health and optimal aesthetics. So these are your goals of any orthodontic treatment, and this has to be visualized right at the beginning of treatment. Finishing and detailing is intimately related to achieving these goals. And finally, if you achieve this, you have long-term stability of post-treatment tooth positions, right? Now, I'm not going into these details. All of you are aware of this. General objectives of comprehensive orthodontic treatment, specific objectives depending upon what you want for every patient, right? These are there in the standard text. Now, the eyes do not see what the mind does not know. There is a need to develop a checklist, right? So especially when you work with finishing and detailing, it's very important that you list objectives that you want to achieve. Try and assess if these are there in your treatment results when you start entering the last 3 to 6 months of your treatment, right? And start or proactively start working on it. You don't really wait for your instructor or your teacher or your guide to come and say this is not happening. You have to develop a checklist, right? So, in aviation industry, however experienced the pilot might be, they have to necessarily go through a checklist so that they don't miss anything. So this has to be followed, right? Now, this is a very interesting article that all of you should read, A Method of Finishing by Rebecca Poling, where she has developed a notation and a checklist of this sort, which every one of you can follow. It could be your own checklist, your own department's checklist, but do follow something objectively. Because the mind does not, what the eyes do not see, the mind does not know, something like that. Now, in this regard, there was this interesting article by Daugherty, which is called Daugherty's Objectives of Finishing and Detailing, which actually he gave as a lecture series in the University of Southern California in 1976. There are about 17 objectives, which is what we sort of tune ourselves during our finishing and detailing processes. So let's look at it. Now, before I really go to see where are the problem areas and how do I correct it, unless you know how does a good finished result look like, how are you going to work towards it? So that's where put your plaster on the table, assessing the finished result. It's very nice, that you show presentation photographs, and all of you know that you can tweak in a lot of things. So that is where still the gold standard would be either putting your plaster or, have your scanned models which can be rotated, and you look at the finished result very, very critically, right? Now, the Indian Board of Orthodontics also has a similar system, but this is a piece of literature that you should go through, right? So there are about 7 or 8 characteristics that is most commonly found to be missing in a well-finished or detailed result. The first and foremost being alignment, one of the basic prerequisites of any orthodontic treatment. And here there are different determinants of alignment when you're looking at the anteriors and the posteriors. So when you look at the upper anteriors, it's the incisal edges and the palatal incisal surfaces, whereas on the lower anteriors, it's the labial incisal surfaces, because those are the ones that are contacting with each other and can be easily determined. As far as the posteriors are concerned, you basically need to have the buccal cusps of the lower posteriors in one line and the central foci of the upper posteriors in one line, because these are the functioning areas. So alignment is a prerequisite of a good finished result. Marginal ridges, right? The marginal ridges of adjacent posterior teeth and the maxillary and mandibular arches should be at the same level. Why? Only if the marginal ridges are at the same level do you have the cemento-enamel junction relatively same. You would end up with flat interdental bones, and that contributes to periodontal health. Buccolingual inclination, you shouldn't end up having an excessive curve of Wilson. The buccal and the palatal cusp should be at the same level, because if you don't do this, you're going to end up having overhanging palatal cusp in the upper or a steep curve of Wilson in the lower where your posteriors are rolled in. Occlusal contacts, again a well-socked in occlusion. A very good thing would be is towards your finishing stages to take alginate impression for your models and assess your results in all the 3 dimensions. Sometime on the clinical chair side, it's very difficult to do it. You can do that, right? You need good socked in occlusion. You could have a class 1 occlusion, a full cusp class 2 and a class 1 canine, class 2 molar and class 1 canine, or even a class 3 molar but a class 1 canine. Occlusal relationship, antero-posterior relationship, like I talked about. So what we don't like, what we don't want even in exams or any board certification exams is we do not want these sort of occlusal relationship. This is incomplete, right? You need a well-socked in occlusion on the posteriors. Overjet, again, well-trimmed models are placed on the table. You pick them up and you should have a normal overjet on the anterior, and this is both anterior and buccal. What we don't want is what is seen in those below panels. Interproximal contacts, again, very, very important when you show extraction treatment cases. You do not want open contacts. That means you have not uprighted the roots across the extraction sites. So putting all this together, what would a well-finished occlusion look like? This is a non-extraction treatment, soft-in occlusion from the incisors to the molars, well-aligned upper and lower arch forms, and pleasing aesthetics. What about an extraction treatment result? Again, the same features of a well-soft-in occlusion, upper and lower arch forms coordinated, and a good smile, right? So what are the finishing pointers? I won't say exam cases, any case, but being in a postgraduate forum, finishing pointers in an exam case. It starts with alignment. Starts with good bracket positioning, need to assess for a repo at the earliest opportunity. Do not let things to go by. Let me see afterwards, it just builds up, right? Now, alignment is complete when full size and finishing arch wires become passive. In-out compensations built into the pre-adjusted edgewise appliance and correct bracket positioning are key features. As far as upper premolar brackets are concerned, you could end up placing them slightly about a little to the mesial in class 1 and class 2 cases, so that you have that distal out rotation to sock in into a nice class 1. Lower canine brackets to be placed slightly to the mesial, especially when you give your lingual bonded retainers. We don't want a big step coming in between the lateral incisor and the canines, right? So that's a well-finished result when your full-sized arch wires become totally passive. Again, another example. The second important aspect is controlling rotations, right? Now, the degree of rotational control is strongly related to the mesiodistal width of the bracket. So your twin bracket is very, very effective. Your average size twin bracket is very effective for controlling rotations. But when you look at self-ligating brackets or narrow width brackets, this can become a problem. You will have to look at what you want to use as accessories and improvise on them. Now, rotations require slight overcorrection, which would mean offsetting brackets, rotational wedges, or rotational springs. Compare corrected positions with pre-treatment models for undercorrection to become apparent. When we were residents, every time my guide came to my chair, the first thing he would look at is not the patient, but our pre-treatment models, right? You assess that and try and compare what has happened. So when you look at it, you will understand that many of your rotations are actually undercorrected and you need to work on it. In this regard, I would urge all postgraduate students to look up the article by Zachariason, Part 1 and Part 2, Excellence in Finishing, where he talks about 9-10, 10-10, 11-10, and 12-10 orthodontics, where he talks about overcorrection. The idea is, If you overcorrect during the time of relapse, it moves towards the corrected position. And rotations are notorious for sort of relapsing because those fibers take a lot of time to reorganize, correct? Now, problems with lower incisors, many times you will find that a lower incisor rotation is not getting corrected. It is a biomechanical problem because the moment arm is very, very small, you're not able to get that twist. So you will have to look at something else to improvise on that, right? Broadening of contact points to areas is a good idea so that you don't slip contacts. Adjunct gingival surgery, CSF or papilla spit to prevent rotational relapse. And upper premolar brackets, I've already spoken about it, lower canine brackets. And 10-degree offset in upper molar tubes and 0-degree offset in lower molar tubes is needed for a good class 1 intercuspation. You know, the mesiobuccal cusp of the upper first molar should stand out. That's when you will have the good locking into a class 1. So now look at this case. Looks like a relatively well-finished case, right? Until I look at the pre-treatment occlusion. Can you see that all those areas are actually 9-10 orthodontics? They are not really 10-10 orthodontics. It becomes apparent depending upon the number of bends that you give in your lingual bonded retainer, right? So that's the excellent article that I was talking about. So that's corrected, that's 9-10, and then that sort of slips again at that point. A must read. These two parts of this article is must read. It may be a little old, but it's as much applicable today as it was then. It's a common in extraction cases for the molars to rotate in mesiopalatal. So when you typically have a first premolar extraction case, since you're pulling from the buccal, you'll find that the first molar rotates mesial in on the broad palatal root, right? So due to the action of buccal space closing mechanics, and 3 types of undercorrections are frequently seen. One central incisor overlapping the other, mesiolabial rotation and torque of the lateral incisor in class 2 division 2 cases, and mesial in rotation of the upper first molars. So these are 3 corrections that whenever you have it in your cases, you must pay a little more attention. It is advisable for all rotations to be corrected to ideal or slightly overcorrected positions in the early stages of treatment. The longer the rotated teeth are held in correct position, the greater the chance of stability, right? In case it doesn't happen, what do you do? So you use any of the accessories, or you should not be hesitant to give arch wire bends or bracket reposition. So remember that don't think bracket or wire positions, think tooth position. So what do you need in that tooth, irrespective of what method you use? That's the way to go about it, right? The third important thing is coordination of tooth fit. So most of the time you will find that in about 60% of the cases, the total space occupied by the maxillary teeth is a little less compared to what the mandibular teeth. And what do you do? Generally, you immediately jump into doing interproximal reduction in the lower arch. But the problem is not so simple. So when maxillary teeth not occupy enough space mesiodistally, what is it clinically seen as? Cases where posterior occlusion is correct, the overjet and overbite are each 3 millimeters, but the spaces remain in the upper arch, frequently in the extraction side. I think it's a very common situation. Your lower extraction spaces are closed, and you will find that you're pulling, your overjet is closed, your class 1 molar extraction spaces are still open. So what do? You jump and start doing stripping in the lower arch, right? Or overjet is correct, but the buccal segment is in a mild class 2 position. You will find that the molars are getting pulled into a class 2, an end-on-molar relation, right? Or the posterior occlusion is correct, all spaces are closed, but there is an inadequate overjet and overbite in the 3 areas. So maxillary teeth not occupying enough space mesiodistally is clinically manifested as these 3 conditions, right? Whereas maxillary teeth occupying excess space mesiodistally is seen as excessive overjet when the posterior segments are in class 1. They could be because upper incisors are large, or class 3 with incisor compensation. In these cases, you may resort to upper anterior IPR. What about these cases? There are 2 other factors which are important before you jump into doing an IPR in the lower arch and try and correct the problem, right? What are those? It's tip, torque, and tooth size. So these are the 3 things that are important to coordinate proper tooth fit between the upper and lower arches. Now let us look at it. Correct tip of every tooth, correct bracket positioning using proper sighting features. Tip is the strength of the pre-adjuster or the edgewise slot, right? So you really require very less alterations as far as the arch wire bends are concerned to incorporate or express tip, because with the twin bracket, if you place the bracket right, and you place the arch wire, the tip starts getting corrected immediately, right? Whereas in a standard edgewise, you had to give those beauty bends to start diverting the roots and getting the crowns together, right? So correct bracket positioning using proper sighting features is most important as far as tip is concerned. But tip also influences the amount of space occupied by the tooth. So if it's a rectangular tooth and it's going to be tipped, it occupies more space than the same tooth being straight. So the upper arch space deficiency, which I said in the previous slide, can be compensated or could be the result of not having sufficient tip as far as your upper anteriors are concerned, right? Tip differential helps in better anterior tooth fit. A total of 40 degrees tip in the upper anterior teeth and 6-degree tip gives actually a 34-degree tip differential, which automatically makes your upper teeth occupy more space and thereby help in a better tooth fit between the upper and lower arches. Now, incisors with slightly flared roots look pleasing. Again, tip is important as far as uprighting across extraction spaces are concerned. And prescription features which help in finishing are the 0-degree tip on the upper premolars and 2-degree on the lower premolars. 5-degree tip on the upper molar and 2-degree on the lower molar facilitate good class 1 buccal occlusion, which is used in our common MBT appliance. So that's the sort of a tip in a routine MBT prescription, and those are the beauty bends which were needed to sort of give or not give a routine orthodontic look, you know. You had to have the pleasing effect. As against tip, torque is a deficiency of the edgewise bracket. My teacher used to tell me, never lose tip on the canines, never lose torque on the incisors. This is something that you have to sort of get it etched in your mind when you work with pre-adjusted edgewise systems, right? Because losing and gaining it is very, very difficult. So never lose tip on the canine, never lose torque on the incisors. Torque is often lost during treatment. Torque is a weakness, need for incorporating torque in the arch wires, and that's why high torque prescriptions come in, right? And this is a very variable thing. It becomes very, very difficult. Most of your treatment mechanics involve retraction of the upper anterior, so you tend to lose torque. You may have to have additional torque on the upper anteriors, and most of your treatment mechanics tend to procline the lower anterior, so you have to have sufficient buccal root torque on the lower incisors, correct? Inadequate torque will again lead to a lack of tooth fit and hence inadequate settling. Now look at this case. The top panel is pre-treatment, bottom panel is post-treatment. What I want you to appreciate, it's a simple bimaxillary proclination, but these are the cases which are liable to lose torque very, very easily, and you don't get up that correct features. So that's the correction that we get. See the improvement in the lip profile. Now, how is torque seen? You look at the upper incisor to the rickets axis, it must be parallel. This is very, very important because unless you get there, you're not going to be there. And it's very important to take this pre-debond lateral cephalogram when you are about, say, a few millimeters of extraction space remaining, because that's when you can make these alterations, right? Now look at this case, a class 2 division 2 case. This is a case where establishment of upper incisor torque is paramount. That interincisal angle is what is going to maintain stability of the results, right? So look at the torque correction in that case, pre-treatment to post-treatment. So what are the radiographic measures to assess torque? Upper incisors to SN plane and palatal plane, interincisal angle, incisors to respective occlusal planes, and parallelism of the long axis of the upper incisor roots to the rickets facial axis, right? Now, how do you typically, see, one of the most common areas where you don't have given in a good torque would be an instanding lateral incisor which you have pulled into the arch. So such an incisor, when you have not given sufficient labial root torque, is end up going to looking, you know, a little longer from the palatal side. There's going to be bunching of the soft tissues on the labial side. You won't feel the the labial root prominence, and you will have a difference in the incisal edges. So these are clinical indicators to say that you will have to pick up your pliers and give a labial root torque, or alternatively, you might want to invert the bracket. So what are the methods of correcting it? So either invert the bracket on the lateral incisor to get that labial root torque, or you use what is called a reciprocal torquing auxiliary or a spec auxiliary, right? And finally, when you have looked into both these, and if you still find that, you know, your occlusal fit is not happening, you may think of interproximal reduction in the lower arch side. So don't jump into reducing tooth material in the upper arch. You will have to do it towards the end of treatment, but lower arch after these considerations, right? The next point is maintaining closure of all spaces. So once you have finished, it's important to maintain it with a passive ligature tie or even a light E-chain. Sagittal overcorrection of overjet. So in class 2 cases, you want to overcorrect it. So you run class 2 elastics, you reach a normal overjet, you start looking at part-time wear, see to it that it's maintained before you go ahead and debond the appliances. Similarly for class 3 cases. So it's important to overcorrect sagittal relationship. Now this is a very, very important thing, vertical bracket positioning. So among all the errors, mesiodistal, axial or thickness errors, these all manifest as one-dimensional problems. Whereas when you have a vertical bracket height which is wrong, you end up having a three-dimensional problem, right? They affect torque, in-out and height of the tooth. I'll just show you. They become more apparent in the rectangular night-eye stage, and precise bracket positioning and repo required to be done early in treatment, which is why even some of the self-ligating prescriptions, they talk about a bracket zone on the labial surface because that is made for that curvature. If you're going away from it, you're not going to be working with the torque that they prescribe. Upper canines and lower first premolars with long pointed cusp, position the brackets 0.5 millimeters gingival, helps in settling. And for posterior teeth with cusp heights which vary from the norm or with abnormal marginal ridges, bracket positions may need to be slightly modified to accommodate these differences. Now let me explain what I mean by vertical height differences cause three-dimensional errors, right? So they are not only going to cause a difference in the height, they're going to cause a difference in the in-out and the torque. It is more apparent in teeth which have more curved surfaces, for example, the canine, right? So look at the bracket being positioned more and more cervically on the labial surface of a canine, which is quite curved incisogingivally, right? So as its teeth starts going up, you can notice that the torque on the canine is beginning to change. Now, how is this clinically manifested? I'm talking about a 1-2 millimeter difference. Suppose you have a canine where the cusp edge is got treated, right? You use a bracket gauge and you position the bracket. It ends up being a little higher than what it should ideally be, right? So it ends up creating a torque problem on the canine, and you will find in the finishing stages that the occlusion is just not settling. Whatever you do, it is not socking in. The only way to go around it is you will have to take a burr and slightly trim off the lingual surface of the canine so that you get that socking in, because you are beginning to sort of bring a thicker portion of the tooth to the lower, and thereby settling is not happening. So it's quite a practical problem that you have to look at it from that angle. A common error in bracket height occurs in the region of the second premolars and is due to either its incomplete eruption or due to poor access and visibility, very often in the lower second premolar area. The next thing is contact points, which are also affected by vertical bracket height. This needs to be appreciated from two perspectives, both the labial buccal and the occlusal. And very often when you end up using molar tubes with offsets in the lower arch, it's not ideally required. You need to have 0-degree offset. You'll end up creating that sort of a step situation between the first and the second molar, which becomes a big problem as far as getting in that socking in between the first molars is concerned. So this is something that you must pay attention. If not happening, you remove that and rebond with a 0-degree offset on the lower buccal tubes, right? Curve of spee in low angle cases, it's beneficial to level the entire curve of spee since excess curve makes it difficult or impossible to complete space closure. Low angle case, you'll find after a particular point you're not able to close space because you have not leveled the lower curve of spee. And it's important to involve the second molars early. As against that, in high angle cases, you actually want to leave a little curve behind. Why? Typically in the finishing stages, in a high angle case, you go ahead and bond the second molar for the first time. That tooth drops down and suddenly you will find that an open bite which was not there up till now suddenly appears anteriorly. So pay attention to this. Vertical overcorrection, overbite and deep bite and open bite cases. Brackets on the anterior teeth can be placed 0.5 millimeters more gingival in open bite cases and 0.5 millimeters more incisal in deep bite cases. And bite opening curves and rectangular steel wires in the finishing stages in deep bite cases need to reduce overbite. They need to be maintained. And adequate upper incisor torque is important. And further, in deep bite cases, you may have to sort of supplement it with an anterior bite plane in your retainer. Whereas in open bite cases, very, very important to evaluate tongue and habits, right? and they have to come, they need to be sorted out, and you need to follow them up during the retention as well. Now, establishing posterior torque. Now, this is again a very, very significant area. Today, there are a lot of other things which are stated in terms of expanding arches, right? Now, if you do not have sufficient maxillary width, how much ever you expand the posteriors, you are, after a particular point, hitting a bony wall, and then you will start dropping your palatal cusp. So it's important to establish sufficient transverse maxillary width. What I'm trying to say is, where a transverse maxillary expansion is needed skeletally, please, you have to do it. If you don't do it and just attempt dentoalveolar expansion, there is no enough room in the maxillary basal bone for those teeth to go buccally. So the only way that they can go is the crowns going buccally and the roots remaining inside, and thereby overhanging the palatal cusps, right? And after that, you still have to, so you may still give buccal root torque on the posteriors, but it's not going to express itself because there's no room in the basal maxillary bone, right? So adequate buccal root torque on posterior teeth is essential to avoid functional interferences. It is important to have adequate width in the maxillary bone so that buccal roots are not compressed against the cortical bone. Use of a TPA on second molar, using convertible tube on first molar helps in incorporating torque on second molars. And cases treated by different expansion protocols like RMA require close attention regarding posterior root torque. So this is what I mean, right? So if your buccal bone width is not sufficient, in spite of you trying to expand and creating buccal root torque, it's not going to happen because the bone width at the base is not sufficient. Carefully examine the palatal cusps of maxillary molars. They tend to hang down if there is inadequate buccal root torque, and check for excessive buccal root torque on the lower molars. Conversely, lower molars tend to get rolled inwards. There's an excessive curve of Wilson which you will have to correct. Arch form and arch width, you will have to respect arch form right from the beginning. You coordinate the arch forms, have the maxillary arch form about 3 millimeters wider than the mandibular arch form, and should be used as a guide subsequent archwise as well. Midnights need to be matching. Again, the second point, slight discrepancy. This is what literature has said. It's not perceived. Doesn't mean that you work towards a slight midline discrepancy. You work towards midlines concordance. Now, relation between, so when you have a midline discrepancy, you use what is called as cross arch elastics. You use a class 2 on one side, class 3 on other side, but you'll have to constantly watch the cant of the occlusal plane. Tipping is the major tooth movement used to correct midline. So that's the sort of protocol you generally use. You use a class 2 on one side, class 3 on the other side, or an anterior cross elastic. But at every appointment, you watch the cant of the occlusal plane. Midline correction should be achieved sometime before all available spaces have been closed. TMJ, health and functional occlusion, you need to match CO and CR. We work towards a mutually protected occlusal scheme. Which is in centric occlusion, the posteriors protect the anteriors. There's a shim stop clearance. And in excursive guidance, protrusive, the anteriors disocclude the posteriors, and in lateral, the canines disocclude both the balancing and the working side, right? So the anteriors protect the posteriors, and the posterior protect the anterior. That's how it becomes a mutually protected occlusion, right? Eliminate anterior interferences, very important. When you look at closing anterior spaces, it's very important that you have established sufficient torque and interincisal angle. And before you go ahead and debond the appliance, check for fremitus. You put your finger on the vestibule and ask the patient to tap. If there's going to be a lot felt, be rest assured that once you debond the appliance, the patient is going to come up with a mild anterior space coming up. So that's important. Again, when there is a slight anterior or posterior glide, you may want to use class 2 and class 3 elastics to settle the occlusion. To check the canine guidance, ask the patient to slowly slide the mandible to one side. When they disocclude the canine, ask them to gently tap up and down the canine cusp tip, and ask them if they feel any other teeth are making contact. Micro and mini aesthetics, again a different topic. You'll have to look at all these features. Smile arc and buccal corridors. You should not have dark buccal corridors. So that's a case which was treated non-extraction. I want you to appreciate, the buccal corridors has been beautifully, filled up. Radiographic objectives, like I said, it's important to take a mid-treatment radiograph. Post-treatment radiographs are okay as a record, but what is it doing for the patient? It's important to take a progress radiograph and evaluate things. So that's the OPG or the lateral cephalogram, which we've already talked about. Settling, again, there are various protocols. You section the rectangular arch wires and you make them settle. You generally keep one arch and use triangular or various configurations. And elastics would be short class 2 triangular, midline, W with the tail configuration, M with the tail configuration, anterior box elastics, and depends upon the amount of size required. So all this is already available in literature. Now, one slide about finishing in clear aligner therapy. They should not be finished to any extent lesser than what is needed in a fixed appliance. Just because you use a clear aligner therapy, this much is okay, not allowed. You are finally an orthodontist, you are treating orthodontic patient. They should comply to the same standards of excellence in finishing. If it is an appliance deficiency, you will have to find out ways to work around it, right? So in this regard, you will have to look at refinement and additional aligners. So never promise the patient that it's only one set of aligners which are going to finish. Maap Tolkit is almost the same amount of time whether you do it with aligners or fixed appliances. Plan over-correction and over-treatment. These are two different concepts, right? Now, over-correction is for an individual tooth position which lacks predictability, right? Rotation is a correction which lacks predictability in clear aligner. You will always have to plan over-correction. Whereas over-treatment is when you have a deep bite correction, you try and open the bite almost to an edge-to-edge bite because you know that only some amount of it going to express itself even in the final result. There are finishing pliers to make finishing bends in aligner. A new set of instruments developed by Dr. J. Bauman is called the Ascent instruments, which are to individualize aligners, which brings in various, various companies have it. Q-Freddy has this, Raintree A6 has it. So these are pliers where you can give in sort of dents and dimples in the aligner, which helps you nudge those tooth movements better. And as far as spaces are concerned, just like you have an E chain, you have what is called a virtual C chain or a par chain, which tightly gets in the contacts, right? And in spite of all this, you may end up with results which are not very optimal. Please do not give up. You had some lectures previously where the doctor took extra efforts to try and upright that second molar and get it into occlusion. So that should be the approach. Irrespective of what method you use, the rules are the same. So in conclusion, the clinician must define finishing goals right at the beginning and must work towards them at every step. Despite the sophisticated prescription, there are minor adjustments that need to be incorporated in the treatment to achieve optimal functional aesthetic results. And please remember, think tooth position and not bracket position. Think how the tooth should be, whether you achieve it with brackets, whether you achieve it with a Z spring on your retainer or with an arch wire bend is immaterial. Persistence in finishing, as Dr. Andrews put it, and a meticulously finished orthodontic treatment result is what distinguishes a master clinician. I've heard him say once that when you think the case is over, persist for another 3 months. So that's the sort of finishing requirement which is there. So because I'm in a postgraduate forum, I think all of you should take pictures of these slides. These are very important articles pertaining to finishing and detailing. Like I said, Zachariason's article part 1 and part 2. Excellence in finishing, which appeared in our Journal of Indian Orthodontic Society by Dr. Ashok Karad. He sort of detailed it in his book as well. Finishing with the pre-adjusted orthodontic appliance by McLaughlin and Bennett, which appeared in Seminars in Orthodontics. A series of articles by Dr. Sondi on anterior interferences, implications of bracket selection and bracket placement on finishing details. And finally, Kokich's excellent article on modifications for the perio-restorative patient, a must read. The 8 Components of Balanced Smile by Roy Sabri, 10 Commandments of Smile Aesthetics by Machado, and Finishing Procedures in Orthodontics, Dental Dimensions and Proportions, Microaesthetics. And some of the book chapters that I would recommend is Dr. V.P. Jayade and Dr. Chetan Jayade's book, Excellence in Finishing by Dr. Ashok Karad, and the finishing and detailing chapters in the Systemized Orthodontic Treatment Mechanics book by McLaughlin, Bennett, and Trevesi. So thank you so much for being such a patient audience.
Over to the chairperson.
Thank you so much, Dr. Raj Ganesh. You've been always the best. And thinking of end in mind was the call for the day. Your finishing skills are past excellence, and I'm sure with your skills and your knowledge deliberation to all the postgraduates, they will be doing a wonderful case
Thank you
further.
so much.
Thank you, Dr. Raj Ganesh. It was a wonderful presentation, and I hope that all the residents, they should, bring all these points when you are taking your cases. And it is not only when you are doing your residency cases, but even after that. That's very, very important to give all these features an important aspect, so that you get your patients finished with a nice occlusion and they do not report back to you with any kind of relapses. Thank you once again for a wonderful presentation.
I request the chairperson to felicitate Dr. Raj Ganeshan, sir. I request Dr. Sherry Peter, sir, to please felicitate the chairperson for the session. So laptop is... Moving on to the next session, we have Dr. Sherry Peters, sir. The chairperson for this session would be Dr. Nabnita Barua and Dr. Nilutpal Bora, sir. Dr. Nabnita Barua, ma'am, is Professor and Head, Department of Orthodontics, Guwahati University. Ma'am has teaching experience of 25 years and is also the convener of Guwahati Orthodontic Study Group. Dr. Nilutpal Bora, sir, is currently working as an assistant professor, Regional Dental College, Government Dental College, Guwahati, Assam. Sir has total of 13 years of clinical practice in the field of orthodontics. Thank you, sir. I will now request the chairperson to please introduce Dr. Sherry Peter, sir.
Good evening, everyone. It is my honor and privilege to introduce Dr. Sherry Peter, sir, to all of you. Dr. Sherry Peter graduated from Kerala University with an MBBS followed by BDS from the University of Annamalai, Tamil Nadu, and MDS in orthodontics in the University of Mangalore. He underwent training in maxillofacial surgery, Royal London Hospital in Whitechapel. He then acquired the FDS RCS fellowship in dental surgery from the Royal College of Surgeons of Edinburgh and FRCS in general surgery from the Royal College of Surgeons and Physicians of Glasgow. He worked in Amrita Institute of Medical Sciences, Kochi, as a senior specialist and later as a clinical professor in the Department of Craniomaxillofacial Surgery from 2001 to 2014. He now holds the position of lead consultant in craniomaxillofacial surgery in Aster Med City, Ernakulam, Kerala. Today, sir is here to speak about pre and post surgical orthodontics in skeletal open bite, and we welcome you here, sir. Over to you, sir.
Thank you, ma'am. Thank you for the nice introduction. I'm sure you're confused, audience. I can imagine what you guys are thinking, what this guy doing out here. What is this funny qualifications about? Yeah. I hope I understand that this is a time of the day when your senses are becoming a little blunt after lunch and before tea, that time. So am I. Anyway, let's see whether I can keep you awake. Now, my job today is to talk about pre and post surgical orthodontics and skeletal open bite. I'll stick to few things. General principles of managing skeletal open bite on a non-growing skeleton is what I'm going to focus on. I'm not going to talk too much about theory. Let's keep it simple to give you an idea about what's the general principles and how to go about treatment planning it, and how to combine orthodontics with surgery, and what are the general principles. Now, when you're talking about open bite and surgery, we could see what kind of surgery we're going to choose. And you have few choices about single jaw, either the maxilla or the mandible, or between the single jaws, which one would you do? and would you want to do both? And when you want to do that, would you rather operate on the mandible first or the maxilla first? There's a few small things which is going by at the moment of time, and we'll think about it. And then I'll express my ideas through few cases which we have done and few important points in those cases. Now, pre-surgical orthodontics, all of these, let's see how we supplement that. And a very important thing, stability. There are certain things about stability which we don't know. So we'll talk about what we know, and keep a little far away from what we don't know. Some disasters, because when there are things which we don't know, we are likely to get into disaster. And how to face those disasters, and what I have had a few illustrate few of them. And the most important thing, the partnership. Okay, now when you talk about open bite, you got to think what is the primary problem and what are the secondary problems. So you got a primary problem which is in the vertical plane and also in the other planes like transverse planes as well. So you can have an excessive vertical growth of the maxilla, which produces an open bite, but mostly it's a differential growth. It's mostly the posterior part of the maxilla which grows down more and creates the problem. So we are looking at a vertical growth of the maxilla which is differential, or a vertical deficiency of the ramus. So each jaw has different problems. One is a deficiency, one is an excess. You could have both as well. And then as a result of this, you can have some secondary AP problems because of the clockwise downward rotation of the mandible, so which is a positional problem. So when the maxilla is at fault, the mandible is positioned wrongly, so you have a positional problem on the mandible. And it can be a transverse problem because the mandible rotates downward and forward, the tongue is positioned downward, the maxilla has nothing to stop it being collapsing. Because the forces outside is more, you can have a narrow maxillary arch as well. So open bites are rarely just a vertical problem, it can be a transverse problem superimposed on it. So when we are talking about open bite, we are talking about mostly in the posterior vertical height. That's where the problem lies. So we're going to concentrate on those areas. So the vertical maxillary axis posterior is much more than the anterior, and hence the mandible rotates backward and downward. Your anterior facial height increases as well, and more looks like a vertical long face. So let's say it's a class 1 skeletal base. Yeah. And the maxilla posterior part is down. So the mandible rotates backward and downward, and it is increasing an interlabial gap. Now, for explanation basis, let's say we put it into class 1, class 2, and class 3 skeletal open bites. Okay, so let's say that's a class 1 skeletal open bite, and we're going to, because since the maxilla vertically is much more longer, we're going to take a piece out of the bone and move that maxilla up. So, and the mandible auto rotates into position. So that is class 1. Okay, now when you do orthodontics, if you put a single arch wire, that's what happens. It extrudes the anteriors, it probably relatively intrudes the posterior. So if it is a single arch wire, that's what happens. And when you take that piece of bone out and impact the maxilla posterior up, the mandible auto rotates in the right position. So this is pre-surgical orthodontics and the surgery. So you planned it accordingly. You know it's a class 1. Okay. Now, when do we do segmental arch? Okay, when this is a segmental arch, when the upper anteriors and the lower upper posteriors are in two different huge steps, then I wouldn't think in terms of a same arch form. I would think in terms of a segmental arch, and segmental arch posterior impact tip the maxilla, that is clockwise rotation, mandible auto rotates into position. Okay, so in class 1 open bite, the orthodontic preparation is decision to make is segmental arch multi-piece mechanics versus a continual arch which is the one-piece one, and also in terms of extraction versus in non-extraction. Based on the surgery which they're planning to plan, you can make your bone cuts either between the canine and the premolar, or between the lateral incisor and the canine. Based on this, your orthodontic plan will have to vary, and the segment will have to change based on what the cuts is going to be planned. Now, if you do vertical elastics on that, that's what happens, and you are forced to extrude the upper anteriors, and thus you're pulling the upper incisors down and increasing the incisal exposure, which probably is not what you want. So When there is a dual occlusal plane, which is more severe than the vertical alveolar and the dental step off, so where there's a major step off, and more exaggerated the curve is P, you want to avoid possible orthodontic extrusion of the anteriors, which we don't want. If you extrude, the incisor exposure is going to be more. What you need is more posterior intrusion of the maxilla. So you may want to think in terms of segmental arch, multi-piece mechanics, followed by a segmental maxillary surgery, where the maxilla impacts more. When there is a single occlusal plane, you think in terms of a continuous arch wire, one-piece mechanics. Okay, now if it is a class 2, same thing, maxilla goes up, clockwise rotation, mandible auto rotates, but then we don't get a good overjet here because the mandible is small as well. So you may want to do a bimax, bring the mandible forward after a sagittal split osteotomy and get into occlusion. So that is class 2, where there is an open bite of the maxilla and mandible, both are at fault. Now, same thing in a skeletal class 3 base. When the maxilla and mandible has a skeletal class 3, you have the maxilla posterior down, you take a piece of bone out, impact the maxilla clockwise, and then allow the mandible to auto-rotate. You have a class 3, which is worse than what it was before, because the mandible is auto-rotated up in counterclockwise. And from here, you decide how much you want to take your mandible back, or if the quantum of the problem is large, do you want to take the maxilla forward as well? So you're converted a vertical problem into an anteroposterior problem, and you're trying to solve that. Okay, so that's how you're going to plan. So maxilla forward, mandible back into occlusion. Okay, now that seems simple, isn't it? Okay, so now sometimes maxilla, oh, we thought maxilla is at fault, bad boy, but mandible also can be at fault. So that's, when do we do that? When we see the cases like that, we look at this guy. He's 37-year-old male, obstructive sleep apnea, multiple episodes of loss of consciousness. AHI is about 32. Oh, his lungs are not doing good. His brain is not getting enough oxygen. Okay, but why? Look at his mandible. You see the ramus is very short. Look at his airway and look at his bite. So he's got an open bite. The mandible ramus vertically is so small, the posterior vertical height is small. Mandible is auto-rotated downward and backward. Posterior vertical height is slow. Mandible rotates backward and downward. The airway is compromised as well. So we need to get that mandible forward. Do we need to get the maxilla forward? Maybe. Okay. So in such cases, you may want to do a mandibular procedure or a double jaw, because you need to both to come forward. Okay. So that's where you come across what is called as a counterclockwise rotation of the mandibular complex or even a maxillomandibular complex. Now, hold on, hold your horses. Is this stable? We'll get into that. Okay, it sounds nice, but okay. So let's say this is a 21-year-old female, class 3 open bite and facial asymmetry. Okay, that's the third axis. Got a facial asymmetry there. Okay, that's her. You can see the open bite. You can see that lower midline is shifted almost 1 incisor width to the left. You can see her smiling and the chin is shifted to the left. And that's her. Intraoral, after bimax, settling, debond. I can see some tads sitting there. I use skeletal anchor elastics after that. That's from there. You can see the plates and screws of the maxilla has been tipped up, posterior up, mandible sagittal split, go back up. Let's see the cephalogram. Open bite, pre-surgical orthodontics completed on the second figure, and the third one after the surgery, settling in occlusion, that's after debonding. And the plates, you can see that plates there. So we haven't done the genioplasty yet. Yeah. So that's the same thing, to just make that the asymmetry has been corrected onto the last one, where you can see the plates and screws, which are bicortical plates. That's her. Now, this is after, the middle picture is after the surgery. The third picture is after her rhinoplasty. So, soft tissue, always remember, we're thinking about soft hard tissue alone, but soft tissues are very, very important. So you can see how the nose has changed after the rhinoplasty. So to balance the situation, you may have to deal with the soft tissue at a later date or in the same step if it's okay. So that's her, you can see her nose and the profile. Okay. Now, that's the model surgery we did, traditional, that's the final occlusion for the final cast. That's a few bit of enameloplasty I did to get that occlusion stamping on. This is the on-table intermediary position. That is after the mandible has been maxilla has been osteotomized. That's the position which we got, and the final occlusion. Now, this is the picture on the 5th postoperative day. That is the picture on the 10th postoperative day. She came back with a small swelling, which she had an inspection, which we were able to control with antibiotics. Now, all are not same. Sometimes we get under heavy fire. 18-year-old female, bilateral cleft dependent, operated 6 times, maxillary hyperplasia, skeletal open bite, and retrogenia. That's a bite. And that you can see the skeleton over there. Now, the plan was maxillary hyperplasia will be managed by maxillary advancement with a red device. Now, but the maxilla is down, posterior part is down. We plan to rotate the maxilla clockwise up with a red combined with the headgear, so that your vector force will allow you to rotate the maxilla in a clockwise direction. So that's a pre-op, open bite. So you can see that she's got a red, which is pulling the maxilla forward, and she's got a headgear, which is rotating the maxilla posterior part clockwise up. Single jaw. The lower jaw just rotated into position. Maxilla forward, clockwise rotation. That's the occlusion. That's a pre and post. And that's the series of steps. In the end, we just put the chin forward as well for a retrogenia. You can see the rotation in the occlusal plane. And the vector which happened, the headgear allowed us to rotate in a clockwise rotation. That's all. Finish. You can see the nasolabial angle and the chin neck angle. Occlusion pre and post. This is what happened. Heel up, advance, mandible auto rotates, maxilla forward into occlusion. That's where we left it. Now, this is a 22-year-old male substance abuser, class 3, open bite, facial asymmetry. Okay, that's him. You can see his open bite there and the crowding in the upper. Extraction, 4-4, recrowd, maintain the O with negative overjet, and Bimax. Open bite, maintain, post-surgical. So we did a trimax, maxilla forward, mandible, maxilla forward, mandible back, and chin. Now look at the fixation there. There's a 4 cortex fixation. I don't want that chin to come backward and relapse. So those are lag screws to fix in position. So remember, retention in open bite cases are very, very difficult. They have high relapse rates. So you need to fix them really well. So that's pre-op, after decompensation, after the Bimax and settling and debonding. That's him. No rhinoplasty. We are awaiting his rhinoplasty. So that's after the decompensation and Bimax. That's a full series. Pre, after decompensation, after Bimax, and after debonding. Now come to the other guy. So till now, we talk about maxillas. So let's see what happens to the mandible. So with an AHI of 32, he was really afraid of surgery. So when he fell down 3 times and his cardiologist said, you better get your airway right, otherwise your lifespan is going to be raised. Then he decided to get his orthodontics done and surgery. So that's him. See the chin neck angle and the mandibular prominence. It's a MMA, maxillomandibular advancement. Open bite, pre-op, open bite increased. That is after the surgery. Maxilla forward, mandible forward as well. In occlusion, you can see the lag screws. Now, he had an advancement of about 17.5 millimeters in that sag split area. I have to tell you, I was afraid. That's a lot of distance. I don't know what's going to happen. So that is why I put double plates. So I got 8 screws over here and 2 plates and a bone graft sitting in between. Okay, so I have to tell you, 17.5 is a lot. So I was really afraid, to the truth. Now, and I put these long screws to make sure the chin doesn't come forward. So it is engaging 4 cortex. You can see that the screws are very long. 1 cortex, 2 cortex, 3 cortex, 4 cortex. Okay, really fix. Okay, now that's the airway. Okay, this guy, immediate post-op, his mother was his bystander. So she called me up around 2 a.m. in the morning, said something's wrong. I was really scared. I rushed into his room. And then the mother said, there is no sound. What do you mean there is no sound? He used to snore like a steam engine. Now there is no sound. I got, oh my God, that's what we did this for. Okay, so that's good, immediate. In spite of the edema which you have when you manipulate that area, yeah. So that is his 3D. So when there, because it was 17.5, I made these models, make sure I bend the plates early and take it on board. So that's his pre-op after 4 years. The bone graft is still sitting there, and that's a 3D representation of the airway. You can see that it's grossly enriched, as well as it is increased in transverse width as well. So these are something which sometimes we don't see because you're so used to cephalograms. The anteroposterior distance is what we always visualize, but things happen in the transverse axis and vertical axis as well. Okay, this is a 20-year-old female, gummy smile, VME skeletal class 2, small mandible, asymmetrical chin, short ramus, and retrogenia. Okay, so that's her. So you got an incisional exposure of 10 millimeters, and that's her occlusion when I saw her. She was referred to me by Dr. Akhtar. So that's the plan. We discussed over the discussion. So we plan to do a counterclockwise rotation, the maxillomandibular complex, short ramus. So that's the VSP plan and the superposition. That's the print model and the cutting guides. To make sure that we down fracture it correctly, we made a splint to make sure that the posterior end is always correct, so that you can put the splint in, make sure that you are down fractured that particular area. So that's the pre and post models. So we adapted the plates and took it in. That's the VTO cast after the surgery with elastics to settle. And that's the settling in process and the occlusion right now. Okay, so that's pre, intermediary, and the post. That's her right now, just about a few days back. That's her cephalograms, pre-op. That's after the surgery. You can see the Riles tube there. So we sometimes maintain the Riles tube for about a day or two. And that's after about 6 weeks. You can see the airway is increased grossly. Just to maintain, make sure that the midline is okay and the symmetry is maintained. You can see the bicortical fixation there, moving through the fracture lines. And that's, again, because it's a larger movement, I put double plates and 3 lag screws in the chin. Now, let's taper it down to something which you can work on. Okay. Now, let's say we have a maxilla at fault, and let's say we have a mandible at fault. So how do we go about making decisions? So take a look at this algorithm. You have a posterior vertical maxillary excess. Let's say you have an upper incisor show which is excessive with a transverse deficiency. Or you have a situation where the upper incisor show is adequate, or in the third one, there is a deficiency. So there are 3 situations when based on the upper incisor show. All 3 of them have transverse deficiency. Now, in a case where there is upper incisor excessive, you will have to do a LFO1 differential impaction like we showed before with expansion, because this is a maxillary constriction as well. In the second one, if there is show is adequate, you're going to keep your upper incisor there and just impact the posteriors as well, with or without surgical expansion if it is constricted. If the upper incisor is deficiency, that means the upper incisor is too up, the lower lip is down, the show is much less, you want more, you will have to downgraft the anterior part and take the posterior part out. So that now you're really doing a clockwise rotation with almost a center point as the premolar region. So anteriors are coming down, posteriors going out, with or without surgical expansion. Now, at this point of time, the mandible auto-rotates into the occlusion which you have planned. And then, now you decide as per what you saw before, is it a class 1 or is it a class 2 or class 3? If it's a class 1, you're there already. You got your occlusion. If it's class 2 or 3, you decide whether you want the mandible coming forward or the mandible coming backward, depending upon its class 2 or class 3. So you think in terms of a mandibular osteotomy. But once the mandibular osteotomy is done, you look at the chin. Do you want the chin to come forward? If so, you do a genioplasty, right? Okay, so you got the algorithm there when the maxilla is at fault. Now let's say the mandible is at fault. So you have a shortened mandibular ramus, right? So maybe you have a normal condyle or a fractured condyle. If there is a fractured condyle, you'll see a lot of cases where post-condylar fractures, the condyle has moved in and the mandible is rotated backward and upward. They look asymmetrical, or if it's a bilateral, they look like short ramus deformities because the condyle is fractured, moved medially, there is loss of posterior vertical height. So the mandible is rotated clockwise, right? So there is loss. Okay, if the other choice of having a short ramus is to have a resorptive condylar change. So in such cases, beware of this. These are young women who have condyles which are very, very small. It's a typical long, small condyle, and you will see the resorptive pattern on the top cortex. These are tricky cases because if you do an orthognathic surgery on them, you will probably end up in continuous resorption and you will lose your posterior vertical height again. The mandible will rotate backward and downward, and bang, you got another open bite in front of you. Okay, so be careful. So if you think that is the case, you should monitor the resorption. And if the resorption is progressive, you think in terms of a condylar replacement. Okay, if the monitor and the resorption is not progressive and it's stable, you correct the open bite with a maxillary posterior impaction. So you're back onto this side, right? So once you impact the maxilla, the same story again comes. You have a resultant occlusion, which is either class 2 or class 3. Based on that, you think in terms of getting the mandible right. Because you have corrected the maxilla now, think in terms of the mandible. Take it back if it's a class 3, take it forward if it's a class 2. Then chin. You want the chin backward and forward. Okay, so now if it's a normal condyle, you're going straight for the mandibular osteotomy because you don't have a problem with the maxilla. You're going straight for the mandibular osteotomy. Now, sometimes they still, in spite of all these things, they catch you on the wrong side. The class 3 with an open bite and a mutilated dentition. She was a nurse, so that's how we did it. Now, she was a very irregular patient as well, so I was struggling with her to get that some kind of acceptable occlusion. That's where we did a maxilla bimax. You can see the difference in her facial ratios. That was the open bite, and you can see that the occlusion was really difficult. Open bite, and we closed it. But she never turned up for post-surgical orthodontics. And that's the last CEF I managed to get just about a few days after the surgery. Now, she landed up 8 years later, just one day, bang. And that's, you can see that. So when she walked into the clinic, I thought, oh, not too bad. Looks more or less the same, yeah. I took a CEF, not too good. And then you open the mouth and take a look at it. Boobs. Okay, so sometimes they catch you. The open bites are very, very nasty at times. So you got to be a bit careful with that. Follow the principles. So take home messages. Diagnosis and treatment planning is important. Teamwork is the key. Support your partner in the face of disaster. There are lots of things which we believe we know, but we don't. Take calculated risks. Thank you very much. I can take questions.
Good evening, everyone. First of all, I'd like to say that it's been an honor and privilege to chair a lecture presented by the great Sherry Peter sir. That's how we used to know him during our post-graduation days. And I'm pretty much sure all the postgraduates over here must have learned a lot from him. He's a very good teacher, actually. Thank you, sir. Thank you for this wonderful presentation.
Thank you so much, sir. Even we are like, I know, I am sure everyone here has been like very much benefited by your lecture, and they might have a lot of questions. But I don't know whether our
I do have
team
time.
will. You have a time, 10 minutes.
Yeah. So can I take some questions?
It's open for questions.
lateral open bite. Okay. Yeah. So usually lateral open bite happens because of the tongue which is overactive. You will have to find out what the etiology, because lateral open bites are not so common. You will have to find out what the etiology is. So if you allow me, can I just show one case of lateral open bite? Actually, I thought I'll be running short of time, so I just. Sorry, I think I misplaced the file. Sorry. The idea is to make sure that you identify the hyperactivity, that is tongue, which is a problem, and try and take how much is the involvement of the tongue to create an open bite. Now, when you do that, what important thing is, what is the dentoalveolar compensation which happens there? Because what happens is when the tongue pushes through, the lower teeth will either intrude, the upper will intrude and allow the tongue to come through. Now, what happens to the skeleton when you have a tongue which is asymmetrically moving? So usually the mandible starts to grow in an asymmetrical fashion, or the maxilla doesn't allow the maxilla to come down. So if that is the problem, so if there is a lateral open bite and a facial asymmetry, you're looking at a maxilla not descending on one side. So you should be having a cant, a skeletal cant, and a mandible which is growing asymmetrically to accommodate the tongue. So you have a defect in the maxilla, you have a defect in the mandible, and a dentoalveolar compensatory mechanism which is intrusion in that side to let the tongue to come through. So you're looking at assessing this patient to correct the jaw basal bone deformity. So you're looking at a lower jaw procedure, surgical procedure, and a maxillary procedure. So maxillary to correct the cant with a LIFO1 and a roll correction, and a mandible with a sagittal split or a vertical ramus osteotomy to correct the roll and bring it in. Right. So then your incisors are extruded. So you need to decompensate it by extrusion. So now you'll have to calculate how much of the skeleton movement are you going to do to correct the facial asymmetry. That is the lower border. Lower border needs to come symmetrical. How much will that allow? And how much will the maxilla come down to correct it? Once you do that, how much of extrusion will it permit you? Because the maxilla is coming down, the mandible is coming up to correct the open bite. So the open bite is going to reduce. Still, do you have any space for the molar, premolars to extrude and meet? This you will have to take it case by case. Now, so this is how the deformity is corrected. But how do you control the tongue? That's the key. Okay, now there are no fixed things to this, but clinically the best thing is to get a tongue grip to stop the tongue coming into that area and see how the response is. For example, this is one of the cases which I was thinking of showing you was she kept having a huge tongue. I put a tongue crib in. She bent the tongue crib in at about 6 weeks' time. The tongue crib was looking at me like that. Okay, so I took it out and put a new one in. Again, back here, it's just bent through. That means this tongue is really stubborn. So such cases, I changed it, didn't work. I started retracting just the anterior space. There was, because the lower incisors was dumped forward because of the force of the tongue. They tried to just close the space and took off the wire for about a day. Bang, it's come forward. So the tongue is really, really, really nasty. So we decided doing a tongue reduction. So during the Bimax, we took 1/3 of the tongue from the middle, did a glossal reduction, and sutured back in.
Thank you, sir.
That reduces the force.
Thank you, sir. Thank you so much. Wonderful cases. Sir, what is the upper limit of mandibular advancement? Actually, in our center, if it's greater than 10, 12 mm, we have to struggle a lot.
Sorry, the limit of mandibular advancement.
Mandibular advancement.
Okay.
You have shown case with 17 mm.
Yeah, that's a bit, like I said in the end, a little bit of a calculated risk. Beyond, like I have one case right now which I'm doing, which requires a 30 mm advancement. In the VSP, in an osteotomy, I felt it should be about 27. And if it's really going to be coming forward without a genioplasty, it's about 30 mm. So we decided in terms of a distraction.
Distraction osteotomy.
So the distraction is in progress. So what I would do is, if you think what I would do is, that is where VSP comes into play. When you do the VSP, you can see the sag split overlap from all axes and see how much overlap is there in the two axes, right? So if you are comfortable getting a good fixation of bone in that axis of movement in the overlap, then I think you should do it, because I'm just looking at case by case basis, right? So we are talking about overlap in the anteroposterior axis, right? Suppose, let's say this is a thin mandible, very thin mandible. The amount of calcareous bone in the middle is very less. So when you split it, you're looking at two thin pieces of cortex rubbing on each other and fixing. It's tricky. So in cases of that, so I don't have a number to say. So I look at how much bone overlap do I have, how much of thickness of bone do I have in these two pieces so that I can comfortably fix it. Based on that, I will take a decision. But 17 is a little bit of a excessive distance. Any more questions? I'm open for questions even after the lecture as well. So
thank you, sir. I would request the chairpersons to please felicitate Dr. Sherry Peter, sir.
thank you, ma'am. Welcome.
I would request Dr. S.P. Singh, sir, to please come on stage and felicitate our chairpersons. That's it, sir? With this, we conclude with our sessions for today. Please be seated for the inauguration. We are going ahead with the inauguration now. Thank you.
Hello, hello.
This is announcement for the awardees. The all awardees have been already informed via WhatsApp group. So get yourself sit from 1, 2, 3, 4 order from left to right. My left to right as of now, right? Because in the batch of 5 we will be sending on the stage while collecting the speaker certificate and the medal, right? So get yourself sit in the 1, 2, 3, 4 line manner, and on the back row again start from the 8. Suppose 8 is the last, then 9, 10, 11, 12 this way. And if your other colleagues are there, those who are not here present right now, call them also and get it sit as early as possible, because we already have the guest reached the venue. Thank you.
Center, front. Center.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि
Let's have a proper picture. Yes, please. Come back. Yeah, please, let's have one picture. Zala? Okay. Thank you.
We would now like to request our organizing secretary, Dr. Prakash Mudliar sir, scientific convener, Dr. Robin Matthew, our guest of honor, Shri Prithviraj Padmasiya Patil, organizing chairman, Dr. Shailesh Shenava, chief guest, Srimati Sudha Chandranji, president IOS, Dr. Jayesh Rahalkar, guest of honor, Dr. Rajesh Reddy, president-elect IOS, Dr. Puneet Batra, vice president, Dr. Eddington Arumugam, honorary secretary, Dr. Sanjay Lab, to kindly take their respective places on the dais.
फोकस हो रहा है कि ट्रेन क्यों नहीं आ रहा है? कुछ बटन दबा दिया, बंद करना चाहिए।
I request Dr. Sanjay Lab, Honorary Secretary, Indian Orthodontic Society, to adorn the jewel of IOS office to IOS President Dr. Jayesh Rahalkar.
LED ब्लिंक कर रही है। इसमें आएगा, पास में है ना कैमरा, क्लोज से हुआ? अरे कुछ तो ऑटो कर दिया है। वो अच्छा। शटर क्यों क्या हुआ? कर उसको 50 पे ला। बस गेंद ले, बस बोले, बस 18।
I would now like to call upon the organizing chairman, Dr. Shailesh Shenava of this convention, to address the audience.
Life, in spite of facing tremendous challenges, following unfortunate incidents in life that transformed her and evoked her inner strength and bounced back with vigor and passion. Sudha Chandran is a Bharatanatyam dancer. She is a known actress both in silver screen and television. She overcame her disability in the most astonishing ways, setting a true example of inspiring success to any who have ever doubted their ability to achieve their goals. Who better could we have invited? Ma'am, we are overwhelmed to have you here. It is a moment of pride and honor to have our own member, Dr. Rajesh Reddy, who is an eminent orthodontist from Hyderabad, to have been elected to the Telangana Legislative Assembly. A hearty congratulations on behalf of the Indian Orthodontic Society. Our Honorable Sri Dr. Mr. Patil, the Executive Trustee and the backbone of Prithviraj Patil, who is the Executive Trustee and the backbone of Terna Dental College, who is a visionary, philanthropist, and who has a passion for excellence in education. I also extend my gratitude for encouragement and support from the founder member Padam Singh Patil sir, Rana Jagajit Singh Patil, and Mallar Patil. I welcome the President of the Indian Orthodontic Society, Dr. Jayesh Ralkar, Vice President Eddington Armugam, President-elect Dr. Puneet Batra, and our efficient, hardworking, and committed Honorary Secretary, Dr. Sanjay Rao. Our dynamic and vibrant Dean, who has always encouraged us, extended complete support towards the grand success of the convention, Dr. Shishir Singh sir. I extend a hearty welcome to our ever supportive CEO, P.T. Deshmukh. To you, sir. Well, my guru, my mentor, Dr. U.S. Krishnanak sir, who is lovingly called as boss. I welcome all the past presidents, office bearers of the Indian Orthodontic Society. A warm welcome to all the eminent speakers and guests from all over the country from different walks of life who have come here to share their knowledge and vast experience with the student community. Well, the most important people are the postgraduate students able to hold this conference. A warm welcome to my colleagues at Kerala Dental College of different specialities. Finally, to my colleagues in the department. Well, our theme is Together Towards Tomorrow, which promises moving together with a vision of future orthodontics, along with the roots from the past. The convention aims to blend the experience and innovation of stalwarts in the field of orthodontics with the hope to cultivate a shared vision in young minds for tomorrow. Well, an emphasis is given to quality and excellence in academics with a list of intellectual speakers and pre-conference courses. We also hope to provide the best hospitality with moments of joy and a load of memories to cherish. Well, once again, I welcome all the delegates with a warm heart to be a part of the iOS 27 PG convention and make memories for eternity. Jai iOS, Jai Maharashtra, and Jai Hind.
Thank you, sir. I now request Dr. Jayesh Rahalkar, President, Indian Orthodontic Society, to address this august gathering.
कसं काय नवी मुंबई? आपली संघटना राष्ट्रीय संघटना असल्यामुळे साहजिकच इंग्रजीमध्ये भाषण करायला लागणार आहे, त्यामुळे मला तेवढी परवानगी द्या. Good evening everyone. Respected Srimati Sudha Chandranji, renowned actress and the Bharatanatyam dancer, our own dear Dr. Rajesh Reddy. I think this is his first outing as an orthodontist after he is elected as the member of Legislative Assembly of Telangana State. So I think he is looking more relaxed and free. Mr. Prithviraj Padmasingh Patil, Trustee, Terna Institution, Dean of Terna Institution, Dr. Shishir Singh, Dr. Eddington Arumugam, Vice President of iOS, Dr. Sanjay Lal, Honorary Secretary iOS, Dr. Puneet Batra, President-elect iOS, Dr. Balwinder Thakkar, Sir, immediate past President, Indian Orthodontic Society, Dr. Shailesh Shenava, Sir, the Organizing Chairman, Professor and Head, Department of Orthodontics, Terna Dental College, Dr. Prakash Mudlia, Sir, the Organizing Secretary, and my dear Dr. Robin, the Chairman of Scientific Committee. Dignitaries in the audience, my Executive Committee members, past presidents, faculty of the symposium, senior practitioners, delegates, fellow members, friends and students. It gives me immense pleasure to address the August gathering at the 26th IOS PG Students Convention being held at Terna Dental College. Amongst the aims and objectives of the Indian Orthodontic Society, one of the aim is to popularize and promote the study of orthodontics in India. So this postgraduate student convention is an education program which helps in honing the skills of our student life members and of course even the life members who attend this particular program, as it is always necessary for the clinician to unlearn, learn and relearn. We always say at iOS that learning never stops at Indian Orthodontic Society. Every year the head office has one theme, and this particular year 23-24, the theme of iOS head office is rational, ethical, clinical excellence, where we'll be striving towards clinical excellence but with rational as well as ethical means of clinical practice. And that's the reason, for the information of the guest, the iOS head office has planned the activities which will focus on the academic enrichment, translational research and clinical excellence of our life members and student life members with a combination of curricular as well as beyond curricular activities. For this particular program, apart from the annual national conventions and PG student conventions, many other curricular activities are also organized by iOS, such as we have the clinical symposia, workshops. For the PG students, we are going to conduct zonal typodont workshop, PG orientation programs, practice management and ethical marketing symposia. iOS is also going to organize the extracurricular or beyond curricular activities, such as we have something called as Orthodontic Premier League, where the orthodontist and the student test their sports skill as well. We are planning a golf tournament. We have the national and international wildlife photography workshop, and we are going to have heritage photography workshop, which is going to be in Tanjavur, which will be initiated and headed by our vice president. iOS also works for the benefit of members via iOS Care and iOS Protect programs. Those life members who are here, I request them to take information about these two activities and be part of it. We are also having for the students the National Student Exchange Program, and for the members we have the International Observership Program, where we have exchange of students within the country, and the life members we exchange with international universities. At this particular juncture, I would like to announce a very ambitious program of the head office. On the 1st of July 2024, the Indian Orthodontic Society is planning to have one national drive on the diagnosis of malocclusion at various places. We plan to make it as an activity which will probably touch a diagnosis of more than 1 lakh of people, where we are looking forward for all the 350 dental colleges, orthodontic departments will be taking the part. At the same time, we have the study groups which are going to take part in this particular activity. So we have, say, around 400 units which are working, and every unit diagnoses around 500 cases also will be touching that magic figure. It will help us in gathering the data of the malocclusion on a segment of 1 lakh data will be a great thing. At the same time, we are trying to make this event as a record event. We are trying for Guinness Book or Limca Book of Records, so that we can utilize this activity for the public awareness. Because see, the way medical specialties are known to people, everybody knows what is a cardiologist, what is a dermatologist, what is an oncologist, what is a neurologist. It is a high time that all the dental specialties should make effort to be known in general public, who is an orthodontist, who is a prosthodontist, who is an endodontist. So these specialties also should be known to all the people, general people. So iOS head office expects similar support to all the calendar event and the endorsed programs. The PG conventions are basically to learn from the reputed national and international teachers in the field of orthodontics, make friends from other dental colleges for exchange of help and support. For a postgraduate student, discipline, dedication and devotion are the 3 Ds which are part of the PG curriculum. Now to that, we need to add the 4th dimension of being a good human being. Always remember to have sugar on your tongue, love in your heart, and eyes on your head, which will help you not only be successful during the post-graduation but also as a clinical practitioner. My teacher, Dr. K.K. Mistry, used to say, if your heart is pure and mind is clear, there is no need to fear. So focus on your 3 years of post-graduation, compete with yourself. At this particular juncture, we have dignitaries, we are going to have National Dental Council. I had discussion with some of the senior people to whom I revered, past presidents, that there is a high time that the syllabus also needs to be modified at the National Dental Council. We probably have to think about more human intense, skill-oriented programs where probably we can get, guide systems are having sometimes issue. I also had a concept that we should not be also having a ranking system. After an MDS is done, why I want to know a ranking? During our time, there used to be a binary system. So if this ranking system will be eliminated, I think a lot of issues in the teaching programs also can be eliminated. So let's all make a promise to follow the aims and objectives of our society with proper code of ethics, and also take efforts to popularize and publicize our branch. Okay, at this particular juncture, the Department of Orthodontics of Prerna Dental College has taken great initiative in organizing this postgraduate student convention. So I appreciate the efforts taken by Dr. Shailesh Chenava, Dr. Prakash Mudliar, Dr. Robin Matthew, and the whole organizing team for this wonderful event. It is heartening to see that so many staff members and PG students from other branches of dentistry of the Prerna Dental College are taking part along with the undergraduate students coming together to make this particular great success. So Dr. Shishir Singh was telling me that this is Prerna culture. I really appreciate this. This puts actually what we call it as Vasudhaiva Kutumbakam. And finally, why we learn? I always have a habit of ending my speech with a subhashitam. So one of my favorite is Vidya Dadati Vinayam. Vinaya Yati Patratam. Patratvat Dhanam Apnoti. Dhana Dharmam Tata Sukham. So Vidya Dadati Vinayam. It gives you patience and it gives you humility. From humility, one attains deserving character. From this deserving character, one acquires wealth. From wealth, good deeds or righteousness follow, and then the eternal happiness comes. So at this particular juncture, I would like to thank my head office, especially Honorary Secretary Dr. Sanjay Lam, the Principal Office Bearer, and whole team for rendering full support to not only this particular event, but for all the head office activities throughout the year. And I hope the delegates will enjoy and benefit immensely from the scientific deliberations. I wish you a great success to the 26th iOS PG Student Convention. And I end my presentation, this particular speech with which Sarve Sukhinas Santu, Sarve Santu Niramayah, Sarve Bhutrani Pashyantu, Ma Kaschit Dukkham Apnuya. Jai Hind, Jai iOS.
Thank you, sir. It was indeed a pleasure listening to you and your words of wisdom. Now, as we unite in pursuit of scientific excellence, I would like to request our guest of honor for the day, Dr. Rajesh Reddy, sir, to officially inaugurate the scientific session and flag off the ceremony.
I officially declare the 26th iOS PG Convention Scientific Session open.
Thank you, sir. I request Dr. Puneet Batra, iOS President-elect, to unveil the souvenir and commemorate this event.
So I unveil this souvenir in virtual reality for the 27th iOS PG convention. Thank you.
No scientific event is complete without the support of our trade partners. So now I would like to request our iOS Vice President, Dr. Eddington Arumugam, to officially inaugurate the trade fair.
Very good evening, everyone. I officially declare the trade fair open. Thank you very much.
Atithi Devo Bhava, which means our guests are our gods. Today we are privileged and honored to have amongst us distinguished and eminent personalities who have numerous achievements and accomplishments to their credit and have contributed immensely to our society, fraternity and country.
I truly consider it my privilege to have the opportunity to introduce our chief guest for the day. She is a name synonymous with resilience and excellence, a renowned Indian actress and a Bharatanatyam dancer, and whose journey is nothing short of inspirational. Despite facing a life-altering incident, her unwavering spirit and determination propelled her towards remarkable achievements. Her passion of dance remained undiminished, and she defied all odds to become a celebrated Bharatanatyam prodigy, captivating audience with her grace and precision. Beyond her extraordinary talent in the dance, Sudha Chandranji has also made significant contributions to the Indian cinema with her versatile acting skills. Her indomitable willpower and resilience serve as a beacon of hope and inspiration for countless individuals worldwide. A true icon of triumph over adversity, she is also a popular motivational speaker and has won a special award, Silver Lotus, for her acting in her biographical film, Nache Mayuri. It is indeed a great pleasure to have someone as iconic, renowned and charismatic as Srimati Sudha Chandranji amongst us. A phenomenal dancer, versatile actress, motivational speaker, and a real-life inspiration to many. Please join me in welcoming our celebrated guest, our very own Nache Mayuri. I would now like to request Dr. Jayesh Bahalkar, Sir, President iOS, to felicitate Srimati Sudha Chandranji.
Let's have one picture. Let's have one proper picture, sir. Thank you. Thank you.
Thank you, sir. Thank you.
Thank you.
Imran?
चल अपनी वीडियो पे चल इसको पूरा खोल दो वीडियो को उल्टा लगा दिया पूरा आगे पीछे भाग रहे ऐसा काम है तो वायरल
It is with profound respect and admiration we extend our warmest welcome to our distinguished guest of honor, Professor Dr. Rajesh Reddy, sir. He completed his bachelor's and master's in orthodontics at the prestigious Bapuji Dental College and Hospital, Davangere. In 1996 and 2002 respectively, he further earned his expertise by obtaining his M.Orth from the Royal College of Surgeons, Edinburgh in the UK. In 2005, showcasing his commitment towards continuing learning and professional development. An academician at heart and clinician by profession, he has been training the budding orthodontists to enhance their skills. He, a professor at Sri Sai College of Dental Surgery, Vikarabad, has multiple private practices in Hyderabad, demonstrating exceptional leadership. His administrative prowess is exemplified by his role as the first president of Telangana State Dental Council. In addition to his illustrious career, he has taken on the noble responsibility of representing the people of Nagar Kurnool, Telangana as the elected member of Legislative Assembly in the recent elections held in December 2003, displaying his unwavering dedication to public service and community development. So please join us in welcoming a dedicated teacher, versatile and dynamic leader, and a social activist. We request Dr. Sanjay Lap sir to felicitate Dr. Rajesh Reddy.
Perfect. Yeah, slowly, yeah. Yeah, very good. Yes, perfect. Yes, perfect. Ma'am, turn, ma'am. Yeah, sir.
That's my heart. Yes.
Yes, let's have one proper picture. Yes, sir.
Come on, Robin.
Come on, let's have one proper pictures. Everyone. Yeah, let's have one proper picture. Look here, everyone. Robin sir. Robin sir. Yeah. Thank you.
We also take this opportunity to felicitate our second guest of honor, Sri Prithviraj Padam Singha Patil. He is the Honorable Trustee of Terna Public Charitable Trust. He has played a pivotal role in steering the organization towards new horizons of excellence. He has relentlessly ensured that Terna Trust remains a beacon of educational quality and catalyst for change, delivering an exceptional and future-ready learning experience. We request Dr. Rajesh Rahalkar sir to felicitate Sri Prithviraj Padam Singha Patil.
Robin sir. So flower thoda side. Flower thoda. Yeah, let's have one proper picture. Come on, smile. Yes, yes. Yeah, look here, sir. Smile. Thank you. Thank you, sir. Thank you.
We would now like to request the organizing chairman of this convention, Dr. Shailesh Srinivas sir, to kindly felicitate Dr. Jayesh Rahalkar, IOS President.
Yeah, sir. Yeah. Sir, basa, sir.
We would also request Dr. Prakash Mudliar sir, Organizing Secretary, to kindly felicitate Dr. Sanjay Lab, iOS Secretary, with a flower bouquet.
We take this opportunity to also welcome Shri P.T. Deshmukh sir, the CEO, Terna Public Charitable Trust, with a floral bouquet. And also we welcome our dynamic Dean sir, Dr. Shishir Singh. We take this opportunity to extend a warm welcome to all the past presidents, iOS office bearers, deans and HODs of all colleges, seniors, and each one of you present here. We would also like to extend our gratitude to the members of media who are present here with us today. We welcome you all wholeheartedly.
With great pleasure, I call upon our esteemed chief guest, Srimati Sudha Chandranji, to deliver the inaugural address.
Good evening, all of you. A big hi to all the dignitaries seated on the dais. I would say it's a moment of pleasure and honor for me because I have attended a lot of functions, been a motivational speaker, but today after coming here and spending quality time with the most eminent personalities, I have gained a lot of knowledge. 2 hours I was sitting in the room with all of you and I could gain maximum knowledge today regarding dentistry and what all that my knowledge was very limited. मुझे सिर्फ इतना ही पता था कि बचपन में मैं चॉकलेट्स खाती थी, मुझे डेंटिस्ट के पास लिया जाता था, आप बोलते थे stop eating chocolates, pull out one tooth, gone. So I used to be very scared of this entire department. And all that I knew was the life of a dentist was something from extracting a tooth to the dentures. बीच का मुझे कुछ नहीं पता था. But it's only now that I've realized, after coming to a field which is very commercial, how important it is to look beautiful. And I think what attracts a person most is the smile. When your smile is beautiful, you attract people, people want to talk to you. So I think this is such an important thing. If I had known all this before, I would have done all this even at that time, I would look a little more prettier. My smile would have been more beautiful. But unfortunately, मुझे ऐसे लोग तभी नहीं मिले. But up from Bandra to Andheri, I have got people to support me. So whenever I feel that I need a corrective surgery or some corrections in my smile, you bet you will see me at your doorstep, at your clinic. Well, jokes apart, thank you so much for inviting me here. And it's such a beautiful convocation that's happening here. And to all the PG students, I think it's such a beautiful moment for all of you because a convocation of this level is very important for all of us because it's a very important phase in our lives when we are taking a very important decision and you're moving towards starting something new, learning a lot of things from your seniors. And I know it's not an easy journey. It's not going to be an easy journey though. There are a lot of trials, there are a lot of ups and downs in life. Many a time you would want to give it up because of the stress and strain. But let me tell you one thing, no gain without pain. And I stand as an example for this. In my life, it's very important that I talk about my life here today because that's all that I can impart to the coming generation. And I want the generation that's following us to be very strong, because we as a country have started depending on our youngsters. So you are the future of this country. Stress is something that I listen to every day, day in and day out. Today's generation has just one word to say: oh, we are stressed out. I don't understand what is this stress all about. We've all undergone this in our lives, but we never gave up. And because we never gave up, and that's the reason that we are all here as eminent personalities contributing to the development of our country. So this is what I want to tell you. You might face a lot of dejections in life. Many a time you would want to give it up. But just look up to people who have inspired you in life. Unfortunately, when I met with an accident, I didn't have living examples in front of me. I was always given examples of people from the West. And I always thought that we Indians have that inbuilt strength to fight adversities. Then how come we are running short of not having examples in our own country? And that is when my decision changed. And I decided after losing a leg that I have to do something where I can inspire the coming generation. But I didn't know where to go after I lost my leg. All that I knew, my parents were with me, and there was a God above me whom I believed in, and the medical fraternity. Today, if I stand so tall and strong, a big thanks to the medical fraternity who stood with me, who believed in me. Starting from my doctors in Chennai when I met with the accident and that led to the amputation, to the Jaipur foot that I'm wearing today, Dr. P.K. Sethi, who invented this foot. We're talking about Make in India. This was made in India almost about 40 years back. Everybody suggested, go for a limb that, abroad mein aisa hota hai, waisa hota hai. I said, aisa kaisa hota hai? Hindustan mein bhi to aisa koi banata hi hoga. And they say when you manifest, you get the answer. And that's when Dr. P.K. Sethi got the Raman Magsaysay Award for the Jaipur foot. And when I went and met him, the first question that I asked him was, can I dance? I didn't ask him whether I can walk, because I knew for sure that with an artificial limb I can walk, but my dream was to dance. And when I met him, he said, yeah, why not? So coming from a doctor, he said, why not? So I thought it was very simple. I took the artificial limb, came back to Mumbai, and I said, oh, probably next 3 months I'm back to dancing. But life was not so simple. It took me 3.5 years to come back to stage. I had to relive my childhood. I had to start learning from the scratch. But I'm very thankful to my parents who believed in me. And today also I say that if I've done something in my life, it's only to give back to my parents. I didn't want to prove anything to this world. And I still say what I have given back to them is just the interest of what they have invested in me. The principle still stands. I may have to take many rebirths उस ऋण को चुकाने के लिए, शायद एक जन, 2 जन, I think that will be a little too less to give back to my parents. But all that I have to say is, after I got the artificial limb also, people said, we're talking about a very modern society, but it is not as modern or as forward as we think. Today times have changed. I'm talking about something that happened 40 years back. When people actually walked up to me and said that, oh, you're quite a bright student. Why don't you pursue your education? Why are you thinking of dancing? And that's what I keep saying in this country. The only problem with this country is, लोग आपके घर में दरवाजे में डोरबेल बजा के आपको free advice देंगे. And this is what you have to say, please don't give it to us, because we have a mind that thinks and we know what we have to do. And when I adopted this approach, people thought I was very arrogant. It was not being arrogant. It was only a defense mechanism. Because if I had not adopted the defense mechanism, probably I would not be able to reach the position that I'm in today. So when I actually started building this confidence within me, and I said, I can do it and I will do it, that is when I started moving towards a goal that I had dreamt about. So this is very important for today's generation. People will misguide you. People will try to impress you. People will try to give you a lot of suggestions, but you know what you want to become. So have a very focused goal in life and pursue it with a lot of dedication and professionalism.
be sincere in what you do. Because they say, when you're very sincere, ऊपर वाला भी 2 बार सोचेगा, जरूर you will get the results. He cannot deny those results to you. And today when people say that you are successful, I say it very loudly that I deserve the success because I worked for it. So it is nothing that कि किसी ने मुझे खैरात में दिया है, कि किसी ने somebody has just given it to me because I deserved it. No, because I worked for it. So it's very important that you work for something that you want in life. And after that, when I started dancing, a film was made on my life story called Mayuri, thanks to Mr. Ramoji Rao. Sir, Reddy sir, you must be knowing Ramoji Rao sir, who first made this film Mayuri. And today I'm still known as the Mayuri girl. And after that, there was no looking back, because the film was a film which gave a lot of social message. It was not just a film. There were a lot of people who were inspired by it. And when today I meet people, they walk up to me and say that we're almost given up on life. That film changed our lives. So my dad used to tell me, when you're born with a purpose. And today I feel that I was born here to actually, I wouldn't say to encourage, but I just wanted to become a real life heroine. Unfortunately, I became a real life, but today I'm a real life heroine too. So I have 2 roles to actually enact. One, a real life heroine where I'm playing negative roles, and a real life heroine where I'm very positive in life. So, zindagi यूं ही चलती रही, फिल्में करती रही. Even after films, people said, "Oh, she's just one film wonder." ये तो एक film किया तो क्या? The commercial circuit cannot accept a specially handicapped person on the, commercial circuit. And I was very dejected because all my films flopped after that. So I said, maybe what people are saying are true. Absolutely, that they must be saying that, well, since that was your film, your life history, that's why the film was a hit. But after 6 long years, I waited for 6 years when television happened. And then the magic happened. And I was given the best negative role of my life, Kahi Kisi Rose Ramola Sekand, and that created history. And then there was no looking back. The same industry which rejected me as an actress today has accepted me in a position where they cannot deny the fact that Sudha Chandan is definitely a good actress. And I want to say a big thank you to the audience, my fans, who still love me and bless me. Because today people are very busy in their own lives, but they still have that 1 minute where they actually pray for me. And I think, kai baar aise kehte hai, ki probably God must not be praying for me, but my fans are definitely praying for my success. So this is all that I have to say, and it's been a beautiful event today. I'm so happy I met the most leading people in their own fraternity. So, and all that I have to say is that जाते जाते मैं एक ही शब्द कहना चाहती हूँ कि जब भी हम जाते हैं ना कुछ भी दांतों में करने के लिए पैसे थोड़े ज़्यादा होते उसे कम करने की प्लीज़ कोशिश कीजिएगा. Because कई बार जो bills आते हैं ना वो बहुत लंबे लंबे हो जाते हैं तो वो उसमें भी हम मतलब poor thing they still give us installments कि आप installments में भरिए वो facilities तो दिए जाते हैं. But yes, I appeal to the government also that please make let's have an insurance for this, because a common man, we are trying to create awareness. The awareness is happening, but the point is affordability. Is a common man able to afford? So अगर ये insurance, if it's incorporated, खास तौर से मैं रेड्डी साहब से ये ज़रूर कहना चाहूँगी कि आप अगर इंश्योरेंस को इनकॉर्पोरेट करने की किसी भी तरह से सेंट्रल गवर्नमेंट तक अगर आप ये प्रपोजल लेकर जाए, so I think it will be beneficial for a common man. So on behalf of a common man, I'm asking you, sir, please take our request ahead. Thank you, sir. Thank you so much. Thank you.
Thank you, Sudha Chandranji. You really inspired us today. It was really a warm and inspiring speech. I mean, I'm short of words. Secretary is a key member of any organization, and any event is incomplete without his speech. So without further ado, I request Dr. Sanjay Lab sir to address the audience.
Yes. Yes. Good evening, very good evening, dear students, dear senior members. Before I speak something, I would like our dear friend and the MLA, Dr. Rajesh Reddy, to give his words of wisdom to our colleagues. Yeah, please.
Thank you, Sanjay Bhai, for inviting. Hello, yeah. Madam, those were real inspiring words from you. So I have to tell my story now. The dignitaries on the dais, friends, Chief Guest Madam, Patil sir, and all the orthodontists, friends who are on the stage, my dear teachers like Girish Kalanikar sir and Krishnak sir, my seniors, my colleagues, students, my alumni members, one and all, a good evening. So coming to how I became an MLA. My dad tried to become MLA a couple of times and he never succeeded in that, but he's a sitting MLC now. So it was always there in my mind, and most of my friends, colleagues know that I was always trying for that, striving for that. And this was the time I got an opportunity and I became an MLA. But I'm an orthodontist first, then a legislator second. That's why I'm still wearing this iOS scarf. So and I feel proud the other day in the assembly when me and my dad, there was a combined session of council and assembly. Both of us drove together, sat in one place in the assembly, and that was a very proud moment, and it was all over, the news was all over the state that father and son sitting in the assembly. So what my father couldn't do, I have done it, and we sitting in the assembly together in one seat, like sitting in a classroom, was, a lifetime achievement. So madam, those were the inspiring words. So when you, as there are many orthodontists here, young orthodontists here, if you have anything in the mind, if you have dreamed about something, you wanted to become a painter or MLA or whatever. I mean, most of us want to become something, but we have become orthodontists. Even though you're an orthodontist, be an orthodontist. But if you have something there in your mind, like madam said, you have to fight, you have to try, you have to do it, you have to kill it. So that's how. Don't keep yourself confined to one thing. If something is there in your mind, if it's running in your mind that you have to become something or you have to do something, please do it. But only thing is, there's a lot of hard work behind that. So now, it's not that easy that I've just become MLA. It took me almost two years to really be there in the ground, know people. Even though my dad's there for a long time, for me to get recognized by the people of my constituency, it took me almost 2 years to be there, to be in the public, to be in the people, to listen to the people. That mustache there in the picture is just because of the public of my constituency who asked me to grow the mustache. I had to go. But today, I was coming as an orthodontist, so I removed my mush last night and came. So I thought, let me look like an orthodontist, because my heart is always filled with orthodontic. I mean, because I grew up it's been almost 22 years that I've been practicing. And to tell you, I've still not resigned my job from the college I'm working. Only thing is I cannot take 2 salaries, so I've stopped taking salaries. So I'm still signing my student's thesis. And once in a while, I thought I'll go. I told my management that whenever I'm free, I'll definitely come there and share my whatever knowledge I have in orthodontics. So I really thank when my dear friend Shenava called me a few days back and said, boss, you have to come here for